On behalf of CII, a very, very warm welcome to everyone present here, and welcome to the 7th edition of CII Hospital Tech 2024. The theme this year is Aligning Technology to Elevate Healthcare Delivery. On behalf of CII, we'd like to welcome Consul Generals, leaders from the industry, friends from the media, ladies and gentlemen. We begin with the inaugural session of the CII Hospital Tech 2024. I'd like to call upon our esteemed speakers to join us on the dais. Mr. Joy Chakraborty, Chairman, CII Hospital Tech 2024 and Chief Operating Officer, PD Hinduja National Hospital and Medical Research Center. Dr. Parag Rindani, Chairman, CII Western Region Subcommittee on Healthcare and CEO, Wockhardt Hospitals. Dr. Tarang Gyanchandani, Co-Chair of the CII-WR Western Subcommittee on Healthcare and Group CEO, Healthcare Initiatives, CEO, Sir H.N. Reliance Foundation Hospital and Research Center. Dr. Tarang will join us shortly. Mr. Rahul Guha, Managing Director and CEO, Thyrocare Technologies Limited. Ms. Ajita Hatlia, Deputy Director for Trade and UK Exports, South Asia. Mr. Sagi Aicha, Israel Trade Commissioner to Mumbai and West India, Foreign Trade Administration, Ministry of Economy and Industry, Israel. Mr. Sven Osberg, Consulate General of Sweden in Mumbai. Mr. Nabil Uti, Consul General of the Kingdom of the Netherlands. Mr. Rizwan Koita, Chairperson of the National Accreditation Board for Hospitals and Healthcare Providers, co-founder, Koita Foundation and co-founder, CITIS Tech. A big round of applause, please, to our esteemed speakers. And we'd like to start with inviting Mr. Joy Chakraborty, Chairman of the CII Hospital Tech 2024 and COO for the PD Hinduja National Hospital and Medical Research Center, to give the welcome address.
Good morning. So it is very nice to see so many of you in our 7th edition of this Hospital Tech. We started in 2018 in a very humble way, and I see that it has taken a big shape today with the presence of all of you. So, dignitaries on the dais, Mr. Rizwan Koita, Chairperson, NABH and co-founder, Koita Foundation, then Mr. Rahul Guha, Managing Director, CEO of Thyrocare, Mr. Nabil Tawati, Consul General of Kingdom of Netherlands, Mr. Sven Ostberg, Consul General of Sweden in Mumbai, Mr. Sagi Icher, the Israel Trade Commissioner to Mumbai from Israel, Miss Ajita Hatlia, Deputy Director, Trade and UK Exports South Asia, British Deputy High Commission for Western India, and my friends Dr. Parag, the CEO of Wockhardt and the Chair of CII Western Region Healthcare, and Dr. Tarang, our CEO of HN Reliance Hospital and co-chair for the CII Western Region Healthcare Committee. So, a warm welcome to the 7th edition of CII Hospital Tech in this vibrant Mumbai. I understand many of you have been hassled with the traffic, but that is the spirit of Mumbai, and I'm happy to see by 10:10 so many of you were there. So, as you all know, the healthcare sector, the healthcare vertical of this industry is going so fast and rapidly progressing and expected to grow around $638 billion by 2025. We failed to continue our momentum, our action also. And in this edition of Hospital Tech, we are going to share some of the innovations, some of the practices, and some of the thought-provoking sessions in terms of sharing some of the best practices and wherever technology has been used. In this edition, one of the key features what we have kept very thoughtfully, that is keeping the clinical part of the technology. A lot of technology application in the clinical parts have been kept here, and we'll be seeing and meeting some of the experts in next 2 days. And we are also going to see some of the discussions on, CAR T-cell therapy, then areas like antimicrobial resistance, gene therapy, and conventional AI and its application in multiple areas. I'm sure that in these 2 days, when you come across 8 different sessions and so many experts, you are going to go back with a lot of knowledge, and we are going to have very fruitful discussion. Another very integral part of it is the competition, the award function what we introduced 3 years back. This is the third edition. 2 years back we started, and in a very humble way again, but this year the participation and all are extremely well, we have seen. And Krishnan, who is spearheading that, he and his team has done a wonderful job, and you're going to see that in a big way. And why this technology, digital and all? Because the country has seen over a period of time the emergence of Ayushman Bharat digital mission, and we have amongst us Mr. Quetta, who is chairing NABH. NABH introduced first the hospital accreditation, but now the digital health, the way things have been progressed. And I think most of the healthcare providers and whoever associated with healthcare, we are going to take that journey forward, because that is going to be the future. And keeping that objective in mind, this entire event has been spearheaded. And I hope a very engaging session, and we'll be looking forward your valuable feedback, your contribution, your involvement during these 2 days. So once again, with all this, I want to welcome you all in this seventh edition of Hospital Tech. Thank you very much.
Thank you, Mr. Chakraborty. May I now invite Dr. Parag Rendani, Chairman, CII Western Region Subcommittee on Healthcare and CEO, Wockhardt Hospitals, for the opening address, please.
A very good morning, ladies and gentlemen, dignitaries on the dais, dignitaries of the dais. It's a privilege to welcome you all here. Let me, at the very outset, put a very, very strong word in for the spirit and the fire behind this entire hospital tech for the seventh year, and that is Mr. Joy Chakrabarti. Let's have a big round of applause for the fire. It's a privilege to be here with such a distinguished group of people, healthcare professionals, technologists, and industry leaders. Today, we are at a very pivotal moment in healthcare industry, and I'm excited about the discussions and collaborations that we're going to have over the next 2 days. We just stepped away from what is the National Patient Safety Conference at the NAPH, and there were a huge lot of learnings, and some of the learnings that we got there, we are going to continue to percolate through over these next 2 days as well. As you know, over the last decade and more so post-COVID, we've seen the transformative power of technology in healthcare. All these years, it was restricted to telecom, it was restricted to television sets and so on and so forth. Today, we're actually seeing it touching patients' lives. These changes that are coming should be made sustainable. They are important for us, and especially post-pandemic, we've seen that resilience is the name of the game for Indian healthcare. We need to constantly endeavor that these changes that we're seeing in technology remain patient-centric. Technology has to remain at the heart of the transformation, but the heart of healthcare, the human touch, should never move away from healthcare. Today's conference and tomorrow is not just about discussing advancements in healthcare and technology. It's about reimagining healthcare delivery for a better tomorrow. Whether it's through AI, telemedicine, robotics, or blockchain, we're already seeing how technology is revolutionizing the way we are approaching patient care today. But the journey is far from over. We are at the beginning yet. Aligning technology with healthcare delivery means integrating advanced tools to ensure that patient care is enhanced. We need to enhance operational efficiency because cost is something that's constantly chasing us. We need to enhance clinical decision-making support. Big data analytics itself can reduce the cost of healthcare by close to 25% and improve patient outcomes through predictive modeling. Remember that as we start working with artificial intelligence and machine learning, we are going to transform diagnostics and also treatment. But let's not forget that at the end of the day, we need to percolate this to not only India, but also Bharat. And that's always something that we somehow take a little bit behind, a little slower. Artificial intelligence and machine learning have improved decision making, have enabled personalized treatment plans, and have predicted patient outcomes with incredible precision. Imagine an AI algorithm that is helping to solve the problem of tuberculosis testing across Bharat today. Telemedicine for India is another game changer. In a country as vast as ours, where access to healthcare can be limited, especially in the rural areas, telemedicine and especially the advent of wearable devices is something that has come of age. Doctors are able to consult hundreds of kilometers away, provide timely care, and reduce the burden on urban healthcare. We're also witnessing the rise of robotics. Today, most of the hospitals represented here from Mumbai have some form of robotic technology or the other, whether it's GI surgery or it's orthopedic surgery. Robotic surgery allows for unparalleled precision and control during complex procedures. Automation in hospital, especially one that focuses on reducing waste, is something that's also come of age. With all this innovation, however, ladies and gentlemen, come challenges. The challenges are related to data security. We're already seeing that healthcare institutions are seeing hacks. We recently saw one in the insurance industry. While technology will gallop ahead, we must make sure that the challenges related to human training are also taken care of. CII recently launched the second cohort of women leaders. We in healthcare need to learn a lot. India still needs to ensure that healthcare, especially for women and the work providers of healthcare, women remain safe throughout the journey. And we have had a very bad incident, which CII also needs to wake up and take a call. Remember, ladies and gentlemen, at the end of the day, if we are able to ensure that our workforce is safe, technology is available for them at their fingertips, I'm sure we will be able to help more and more patients and ensure that the human touch from healthcare does not get taken away. As we look into the future, the possibilities are endless. Imagine a world where AI precision allows you to treat patients at a low cost and finally makes access to healthcare equitable for everybody, whether it's in the villages or it's in the cities. Remember, as you go through the 8 sessions over the next couple of days, that these learnings are to be percolated throughout your endeavors, whether it's a startup, whether it's a medical device industry, or whether it's the actual device of healthcare. I see that we are joined by a lot of our colleagues from other countries. We at CII would be happy to constantly learn from them and constantly adopt and adapt things which they already have a mastery on. With that, I wish us well. I wish that the learnings remain and that the CII Hospital Tech sees many, many more additions. Thank you very much, ladies and gentlemen.
Thank you, Dr. Parag. May I now invite Dr. Tarang Gyanchandani, Co-Chair CI Western Region Subcommittee on Healthcare and Group CEO Healthcare Initiatives, CEO Sir H.N. Reliance Foundation Hospital and Research Center for her address.
Thank you for the kind introduction. Good morning, everyone. Respected dignitaries on the dais, esteemed speakers, dignitaries on the dais, off the dais, partners, exhibitors, invited guests, and friends. It's indeed a true privilege to co-chair the 7th edition of the CII Hospital Tech Summit 2024, and we explore a very important and pertinent topic, not only for us as healthcare providers, but also as our country, which is to explore the transformative landscape of the healthcare in India through digitization, artificial intelligence, and analytics. I would like to thank Mr. Joy Chakravarti and Dr. Parag for taking up the healthcare chapter. And I think they are really two people who have held this in a very pivotal way, not only for this year, but for several years. So, really, hats off to both of you, and thank you very, very much. India's healthcare landscape is indeed evolving rapidly, driven by growing demand for quality healthcare systems, increasing awareness for the maintenance of the health, and rising income levels. Everybody wants to be well, everybody wants to be healthy, nobody wants any disease. Well, it's a dream and a target for all of us in healthcare. The Indian hospital market is projected to see a substantial growth, and it's fueled by the expansion of both public and private healthcare facilities. Hospitals are evolving beyond traditional treatments. They now play a growing role in providing comprehensive range of healthcare services, which includes diagnostics, medical testing, patient and also patient care for individuals who require acute care treatment. But I think hospitals need to understand that healthcare is beyond that. In fact, healthcare industry of India needs to evolve thinking that there is healthcare beyond the hospitals. And what will make it possible is the digitization, the technology innovations, and also the integration of these two and usage of analytics. The next 2 days, I think there are a lot of interesting sessions where we will delve with these ideas. And I think the take home, what we need to look at is the target one, how to ensure the well being of the population as healthcare providers, change the way we think. Healthcare is not only hospitals, healthcare is also requires all of us together collectively to focus on how to keep people well. So many times, I know it's looking a little ironical from a person who runs a hospital to speak so, because obviously we are always worried about our EBITDAs, about top lines, bottom lines. But trust me, 5 years from now, if we don't evolve this way in healthcare, somebody else will. So we need to start looking at how healthcare should evolve in keeping people well and coming to the hospitals only when they are really sick. So take the healthcare closer to the patient. And here is where the digital transformation, the analytics, and the telehealth systems, wearable devices will help us to address this. And we need to move towards this direction. So, just taking a pause there, all of us have evolved over a period of time. Earlier, we used to talk about patient safety, patient care, patient experience. I think we have learned a lot, long way, but healthcare is evolving. So, what is the next thing? Next thing came was digitization, artificial intelligence. But at least me as a person, last 2 years I kept on exploring. Okay, fine, digitization, fine, we buy the finest of the machines, we buy the finest of the robots, but then what? But I think now we have a direction. The direction is that we need to use the power of digitization, machine learning, artificial intelligence, which most of us know, and we have experts in the industry, in our hospitals to excel in that. But we need to use, as healthcare providers, use this power to enhance the reach of healthcare, to get better outcomes for the patient, even when the patient is not sitting in your hospital, to enhance the well being of patients, to take the healthcare of a patient on his fingertips, in his hands, in reduce the dependency of population to come to the hospitals all the time for each and everything. We will have enough patients still, but I think we need to explore wellness, and that's where the power of digitization comes into picture. That's where the power of artificial learning comes into the picture, in addition to helping us to run our acute care settings, where Dr. Parag has also mentioned, we have all the robots in the theaters, elsewhere. Now we are also using robots to enhance our operational efficiencies with AGVs and other aspects. We have machine learning system. Again, my machine learning is not only the traditional clinical part of it, which of course we all know. As doctor, I personally feel that's the biggest power we have today, but we need to also explore how artificial intelligence, how the analytics help us to run a sustainable healthcare ecosystem by reducing our cost, enhancing our operational efficiency, enhancing our throughput, which were very big statements for me. I don't know about others, but for me, 2 years back, when I didn't know how to do it, but today, I think we have at least little bit confidence by examples on how we have used this as a help to enhance other aspects of care delivery other than the clinical part, because our machines are very intelligent, our technology in medical is very intelligent. We have got all the Siemens, the Gs, and the Philips of the world have mastered the art of putting AIs within their technology, mastered the art of using how to enhance the efficiency of IoTs to improve the patient care outcomes. But as a CEO, I personally also feel that we need to look at how we can use the analytics part for well being and also for the non clinical part of it to improve the efficiency for running the healthcare systems. So, in addition to the traditional care, as I said, we have the technology playing a key role in transforming the Indian healthcare market. We would not have ever imagined that can we start the treatment of a patient in an ambulance just like the way we will start in our ER. Today it's possible. And we see the demo every day. I'm sure in many hospitals, but at our hospitals with the smart ambulance services, where we have linked the devices with the best of the doctor sitting in any part of his home, whether he's traveling, if he's on call, he can guide the treatment, and we are done. It reduces the crunch on the manpower, because every time you cannot send a trained intensivist in a ambulance. Many of which country can afford it? Forget about India. No country. So that's where I said that, we need to come together to understand what are these ways and means by which we can harness the power of technology and harness the power of digitization to get better outcomes and enhanced efficiencies. Just touching upon briefly, I think the government's vision is also to establish our country as global healthcare hub, and the rising adoption of AI and wearable technologies in the hospitals and healthcare is paving the way for sustained growth and innovation. The National Digital Mission, which was launched by our Honorable Prime Minister, Shri Narendra Modi ji, in 2020 on 15th of August, if we all would know, it has all these principles that we are now breaking into and understanding it. ABHA is one of the features which I think is a necessity for India to have everybody come on the same platform. And likewise, we have other initiatives under this digital mission, which includes also how to automate our facilities, how to digitize our records, and so on and so forth. But there is always two sides of the coin. So while it is interesting, very good, high in efficiency, and as my friend Dr. Parag rightly pointed out, we are worried about the safety. So we need to develop systems which have an inherent way. Now, that is the homework for the next 2 years, how to make our digital systems safe so that we do not get into uh, our data being lost because it is not our data. It is the data of the person who's trusting on us. It's our patient's data. So patient confidentiality breach is one of the most important worry when we have data privacy issues. And according to me, one of the other challenges which we are facing is the fact that all these systems need to talk to each other. So the interoperability as well as the talking of these systems with one system talking to the other, many times, we face, oh, let's get this, let's get that. And then we realize, oh, this does not talks with my native system. So that's where we need to come out with systems which are capable to talk to each other, where integration within the systems is easy so that we can deploy more systems. So, all our healthcare partners who are into digitization and coming out with the digital technologies, let's create something, a, a platform where all the systems can get integrated so that we can actually enhance our efficiency and harness this power of analytics. Over the next 2 days, I would really want all of you to immerse yourself into this and focus on our targets as well as how to do it well without having the issues with data privacy. And I'm sure we will touch upon the areas as to how to get the systems to talk to each other. These discussions will also explore how healthcare can continue to contribute significantly to socio-economic development in coming years, because that's the idea, uh, enhancing the accessibility and ensuring well-being of the people. Thank you very, very much for your patience. And I look forward to insightful conversations and meaningful collaborations with many of you here during this summit. Thank you very much. Namaste.
Thank you, Dr. Tarang. May I now invite Mr. Rahul Guha, Managing Director and CEO, Thyrocare Technologies Limited, for his address.
Good morning. I must confess I'm a bit intimidated after following the doyens of the healthcare industry, Joy, Parag, and then Dr. Tarang. So I'll try to keep it as short as possible and leave you with a few messages and a little bit of imagery as you go into the conference. It is a wonderful time to be in healthcare today. This month marks the 6th year of ABPMJAY, the 6th year. And as you would have read, just this month, the government has extended the scheme to all senior citizens above the age of 70. This was an unaddressed part of the population that greatly needs healthcare. And it definitely underscores the commitment of the government towards ensuring no one gets left behind. And it's wonderful to see the health tech conference being organized to talk about it and go into details of how we can take advantage of this marvelous opportunity that is presented to us. But at the same time, while more and more come under the ambit of healthcare affordability, the disease burden is huge. At Thyrocare, we did a study of roughly about 10 lakh, oh, sorry, for my international colleagues, 1 million people who did an annual health checkup. You'll be surprised to know almost 50% of them were either diabetic or pre-diabetic. That's the healthcare burden that stands in front of us. And it is also the advent of digital. ABDM, as Dr. Tarang also talked about, is scaling up. Today, there are, and my apologies to my international colleagues, I wrote the speech in assuming an Indian audience. So it's 67 crore ABDM cards, or 670 million people now have access to digital health records in India. This integrates the entire healthcare life cycle, leading to a longitudinal view of the patient, allowing all stakeholders to get a 360-degree perspective on the care that they've been delivered. However, healthcare remains the most capacity constrained sector, and therefore technology is the need of the hour. And this health tech conference or hospital tech conference is really the forum where we can think about the force multiplier of technology and how it can really be used to expand the reach of healthcare in India. I would be remiss if I didn't speak a little bit about ThyroCare. I won't take too much time, but I'll spend maybe a minute. At ThyroCare, our name is ThyroCare Technologies Limited. We are more a technology company than a diagnostics company. Every day, 1 lakh samples get transported from 350 cities across India using a technology backbone that has track and trace at every step of the cycle in ensuring both cold chain as well as sample integrity throughout the status. We do 10,000 sample collections a day at home. Again, with full traceability using technology. We don't use AI as much, but using product technology, very simple technology to ensure 100% error-free collection at home. All our labs are digitally enabled. Uh, Today, sitting in our control tower in Mumbai, you can see what's going on in our lab in Patna, in our lab in Jaipur, almost anywhere in the country. And we have models that actually study that data and give recommendations to the technician as well as to the clinician on what's going on with the patient. With a nod to Rizwan, 96% of our samples today are processed in an NABL lab, making us the chain with the largest footprint of NABL. Almost, I think, 26 out of our 30 labs are now NABL accredited. But that's just the technology layer, and I'll stop a little bit on that front. But all of this is an example of how, as Dr. Tarang said, how you can use technology not just to improve clinical outcomes, but actually to improve the experience for the patient, to ensure that the home collection is done on time, you're sure of the sample quality, and it's visible to you throughout the life cycle. You're sure about what technologies it's been processed on, and it gives the patient confidence that the reporting that they're receiving is the right one. We integrate all of this with the customer relationship management system to ensure patients have all their data in one place. And it allows the doctor, when they meet him, to be able to see their health trends over years and be able to interpret the results not only as a point in time, but also across the entire patient life cycle. And as we think about these technologies and how we've integrated it, right? Because we are a specialist in diagnostics, we are able to absorb these technologies, understand them, and deploy them in the right way for the patient. And therefore, I'll leave you with an image as we go forward on the Hospital Tech Conference. I would imagine an orchestra, right? Keep it in your mind as you go through the day, discussions on the day. Imagine an orchestra, and I feel the hospital is the conductor of the orchestra. Gentlemen like Joy, Parag, Dr. Tarang really are the Zubin Mehta of the orchestra, right? And then there are specialists in each and every division of the orchestra. There's someone who knows how to play the violin. There's someone who knows how to play the cello, and they're specialists in their own domain, but at the end of the day, answerable to the conductor so that we can make beautiful music together. And I think that's how you should think about this conference as we go through the day. Think about specialists who can absorb technology, understand it, imbibe it, and really deploy it in a way that it makes sense to the patient, all under the guidance of this tremendous orchestra, which is the hospital, that is at the forefront of treating this patient and working together under that guidance so that that orchestra can make beautiful music and it doesn't become a cacophony. With that, thank you all for the patient hearing.
Thank you, Mr. Guha. May I now invite Ms. Ajita Hatlia, Deputy Director for Trade and UK Exports South Asia for her address.
Thank you very much. Namaste, everyone. Good morning. Lovely to see you all today. I was going to start off with the speech, but actually, I love that image of an orchestra. And I just wanted to say that perhaps this is the part of the speeches where we're talking about how orchestras from different countries come together to create beautiful music in fusion as well. So that's a lovely image that will stay with me for some time. Thank you, Dr. Thank you, Mr. Guha. I just wanted to properly begin now by thanking CII and Mr. Joy Chakrabarty, the chairman of CII Hospital Tech 2024, for extending the invitation for us, the UK, to be a part of such an important knowledge sharing forum. The UK is delighted to be a long-standing country partner at this forum, which has led to a strong positive impact related to our work with India. As most of you will be aware, I hope you're aware, we now have a new government in the UK led by Prime Minister Keir Starmer. And the Prime Minister has clearly stated his intention to continue to build on the strong partnership that already exists between the UK and India. The government has domestically committed to drawing up a 10-year plan for the National Health Service in the UK, and that's going to set out 3 key areas for reform. The transition to a digital NHS, moving more care from hospitals to communities, and focusing efforts on prevention over sickness, themes that I think really resonate with the speeches that we've heard so far. With India specifically, we're going to continue to deliver on the 2030 UK-India roadmap, in which digital health, AI in healthcare, medtech, healthcare services and facilities, hospital supplies, medical devices, and equipment and pharma all play a really important role. I'm just going to say a few words about the future of collaboration. So many of you in the room will know better than I do, because I'm not a doctor, that one urgent issue where our collaboration has gained significant traction is the fight against AMR, antimicrobial resistance. AMR poses one of the greatest threats to global health, with both India and the UK grappling with grappling with rising resistance to antibiotics. And together, the UK and India have initiated research collaborations to develop new treatments, promote the rational use of antibiotics, and strengthen surveillance systems. Joint AMR action plans between India and the UK are helping to advance global policy frameworks and promote responsible antibiotics stewardship. This collective effort is critical to safeguarding the efficacy of life-saving drugs for future generations. In addition to AMR, digital healthcare presents a promising frontier for UK-India collaboration. Both nations are embracing the potential of digital health technologies such as telemedicine, health apps, AI-powered diagnostics, and data-driven public health interventions. India, which as you all know is the world's most populous nation, has a growing digital infrastructure, and it offers a fertile ground for testing and scaling up digital health outcomes. On the other side, the UK's expertise in healthcare data management, cybersecurity, and regulatory frameworks provides valuable support in ensuring these technologies are implemented safely and effectively. The convergence of technology in healthcare promises to democratise access to care, especially in underserved areas, and to provide real-time health solutions to millions. I'd like to share a few examples of some of the recent successes between our 2 countries in healthcare. Spirit Health has signed a deal with Healkin in Mumbai for using Clinitouch, a remote patient monitoring platform that is device agnostic and could help patients be monitored in the comfort of their own homes. Again, tying in very much to the Indian agenda in this space about taking care into the communities. King's College London and Guy's and St Thomas's NHS Foundation Trust with PD Hinduja Hospital and the Hinduja Foundation have established a Health Partners Academy. This strategic partnership will advance training, education, and research capacity building focused on healthcare outcomes. And CMR Surgical, a next-generation surgical robot player, have now set up their base here in Mumbai while delivering their state-of-the-art technology across India. As we look to the future, there is enormous potential for deeper collaboration between our two countries. Climate change, an aging population, and emerging health threats demand innovative solutions that only a collaborative global approach can provide. And the UK and India are well positioned to lead this change. Our partnership is not just about improving health outcomes within our own borders, it's also about how our partnership can support and lead to global solutions to these problems. Together, we can continue to push the boundaries of innovation, improve lives, and build healthier, more equitable futures for all. Just in closing, I'd like to say thank you very much for having us as a partner to this very exciting and innovative event. I wish you all the best of luck in your conversations and discussions over the next couple of days. And hopefully, this will lead to further collaborative partnerships between the UK and India, and not to leave out everybody else on the panel with other missions as well. So thank you all very much.
Thank you, Ms. Ajita. May I now invite Mr. Saki Akcher, Israel Trade Commissioner to Mumbai and West India, Foreign Trade Administration, Ministry of Economy and Industry for Israel.
Thank you. Namaste, Shalom. Good morning, everybody. मेरा नाम सगी हीचर है, इसराइल इकोनॉमिक अटैचे है, मुंबई में 4 साल रहते रहा हूँ, और मेरी पत्नी और मेरी 2 बेटी है, मेरी छोटा बेटी छोटा बाबू है. She was born here in CII Hospital, by the way. So thank you. Thank you very much, ladies and gentlemen, honorable guests. Thank you very much. Thank you very much, Joy. Not only for the invite to be here, part of the CII Health Tech event for the second, the hospital event for the second time, but also for your friendship and your partnership throughout my journey in India. Thank you very much, sir. So, as mentioned, I'm Israel Trade Commissioner operating here out of Bombay, in western part of India. We have in India 3 different missions, one in Bangalore, one in Delhi, and one here. One reason is that Israel sees India and believes that India is one of its biggest and most important partners today in the world. I think there's a very strong partnership and friendship going on between our 2 nations. So what is it we do here? We try to connect, to create these bridges and partnerships and collaborations between any Indian and Israeli entity that we see that can, success together and prevail together. We're sector agnostic. So today we're talking about healthcare. Last week we had a cyber delegation coming here, and 2 weeks ago we had a media delegation. So I met all the Netflix and these guys of the country. It was rather amusing because you sit in a formal business meeting, but you actually watch trailers on the screen all the time. So that was some quite of an experience. So we're sector agnostic. Anything or anybody that we think that we can bring together, we try to do that, from the Adanis and Tatas and Ambanis to the next Chaiwala, or anybody that can just work together. We'll create those connections, working very deeply on healthcare and medical devices and AI in healthcare and insurtech in healthcare, but we also do, as I mentioned, each and every other possible sector. And just to try to, and by the way, all of our services are given completely for free. So all the B2Bs we're doing, all the expeditions, all the visits, all the delegations, all the conferences, we don't charge anything for that from the Indian side or the Israeli side. We're just trying to create these partnerships, as I mentioned, and to create these B2Bs, those meetings. As I'm sure many of you are aware, the Medica event is coming up in Düsseldorf, Germany in next month. This year it's way after Diwali, so no excuses. Everybody can go there and everybody can travel, not like last year. We're going to have 30 plus Israeli companies at a pavilion, at a national pavilion, and we'll love to, again, if anybody's traveling there, anybody from your team is traveling there, please let me know, and we'll have to facilitate any kind of meetings with Israeli companies according to your interest. So that was like who we are, what we do. And if I may relate to a few of the points in the healthcare. So Dr. Tarang, you can be more right. In Israel, we have came to a place, and Israel is a tiny country, okay? I must be honest and say that. Israel is in the size, like India is 152 times bigger than Israel in size, and Pune is bigger than Israel in terms of population. Okay, the city of Pune on its own. So Israel is tiny. Um, and we've managed with years. So roughly 100 years ago, there was this woman in Israel. Her name was Henrietta. Henrietta Sold. And today, if you go in Israel, you see Henrietta Sold name is on the streets, and there's squares and research center. Like, but why? Because she formed probably two of the most important organizations we have in healthcare till date within the country. One of it is the Hadassah Medical and Research Centers, which are all over the place. They are well known all over the world. We receive patients that are coming to get treatment from literally all around the globe. I was born in a Hadassah hospital. My eldest daughter was also born in a Hadassah hospital. So you can understand it's a very, very important institution, and the hospitals are running, as I mentioned, for more than 100 years now. And in parallel to that, she formed something very unique, which is called Tipat Halav, which means literally translates to a drop of milk, dud. So her point was reach out to the community, reach out to young mothers, and educate them about the nutrition of their kids, what's important, have, don't have, etc. Few years later, they started adding the vaccination programs. Vaccinate your kids through a certain, there's a scheme for that and all. So again, my eldest was born in Israel. Whenever she needed vaccination, they used to call us on the phone and tell, hi, you need to come tomorrow to vaccinate her. Youngest, as I mentioned, was born here. So we're coming to Reliance Hospital every few months, HN Reliance. And Dr. Verma, Raul Verma, takes very good care of my youngest daughter. Thank you very much. And she's getting vaccinated. But in Israel, everything just comes through you. And on top of hospitals, and on top of this, children healthcare system or provide children any kind of support they need, we have an HMOs. The HMOs is our health management organizations, which literally goes to the population, through the smallest cities, to the smallest towns, into your neighborhoods, and you can just get medical treatment there for whatever you need, from your blood samples, just to see your physician, your pediatrician, and so on and so forth. Just to share with you a very, very short story. COVID times, we like to forget that, but it happened not too long ago. I was by coincidence in Israel, right? I've been in India for more than 4 years now, but I was in Israel for a very short period of time, and my grandmother, she was above 80, and they need vaccination for COVID. And within less than 4 or 5 hours, we got the appointment done. I took her, we got her vaccinated, the first dose, and I brought her back home, and everything was done freely, free of charge. We didn't pay anything for that because of the healthcare system and its strength and how much it wants to provide to the people, provide to the public, from anybody, from my grandmother, which is above 80, until my youngest, which was just born. Everybody should be covered with healthcare. That goes to anything you can think of: dental healthcare and mental healthcare and specialties and surgeries. Everything is there. When we provide it to the public, everybody is covered on a national insurance scheme, and everybody must pay that. And that's how the system works. And you take that, right? So we started in the 1920s, just post World War I. We started building our healthcare system, and a lot of doctors in the country in any case. And then you add to that the hospitals and the HMOs, and then you create a very, very strong base of healthcare system and healthcare system knowledge. And then comes into the picture doctors and physicians and engineers, software engineers, material engineers, scientists. And there's a very, very good infrastructure to build innovation in healthcare. So the last 2 decades, Israel has been extremely strong in healthcare innovation. Some of the companies already work here in India, and they do very well. They answer to women healthcare, they answer to oncology, they give treatments for diabetes and many other things. Okay. And those companies, again, take all this knowledge from the doctors, take the innovation, which is Israel is known for its innovation for many years. It's no secret, very innovative country. And everything is brought together and we create a very, very strong foothold in innovation, in healthcare innovation. So by any chance and by any means, if you're working for a hospital, a clinic, a healthcare organization, an insurance company which is looking into healthcare policies, remote healthcare, digital healthcare, some things that you are very, very strong in these days. And we take a lot of pride in it, to be very honest. Um, it's no secret that the last year wasn't the best for us, but even with all the challenges, I can share with you very happily that in the last 3 quarters, like let's say the last 9 months, more or less, um, Israel received nearly $9 billion, okay, in terms of FDI, foreign direct investments coming into the country, into the innovative companies, into the startups, which makes Israel the third in the world. So we're just, touching on Silicon Valley and New York were the ones who came above Israel in terms of investments, which again gives you another indication of how strong the country is and how strong the economy is and how strong the industries. Okay, all the innovative companies and the industries that they form. Um, just recently, last June, another Israeli company, which are doing something extremely unique, and now we're going to get into India as well. They do so they use sound waves, which are directed by MRI to see tumors and other things and treat them. I don't know how it works. Don't ask me. That I can tell you. Just secured another investment just recently, so just another taste of how good and well we're doing. So I want to wish all of us very fruitful and good 2 days to come, and let's enjoy it. Thank you very much for your time.
Thank you, Mr. Saki. May now invite Consulate General of Sweden in Mumbai, Mr. Sven Otzberg, for his address, please.
Good morning. Thank you, CII, for inviting me. Ladies and gentlemen, it's an honor to discuss the achievements and future of Sweden's healthcare system and Indo-Swedish cooperation. India has made remarkable strides in healthcare, from eradicating polio to becoming a global leader in generic medicines. Our collaboration aims to build on these successes. An important cornerstone for this is our very successful Indo-Swedish Memorandum of Understanding in the healthcare and public health sector. Sweden is committed to high-quality healthcare for all, and today I will share ongoing innovations. We are open to explore any possible avenues for collaboration, be it in Sweden or in India. Ladies and gentlemen, both Sweden and India share a commitment to providing high-quality healthcare to all citizens. This shared value forms the foundation of our strong partnership. Sweden ensures that healthcare is accessible to all through a universal system. Our network of primary care centers, hospitals, and clinics serves both cities and the countryside. Innovation and technology are central to Sweden's healthcare. We have a history of great medical innovations like the pacemaker and the gamma knife. Sweden also plays a significant role in the Nobel Prize for Medicine. One such recipient was Professor Harry Gobind Khorana. Sweden has been a pioneer in digitizing healthcare services through remote monitoring, telemedicine, and AI-based diagnostics. These innovations can be adapted to address some of India's most pressing challenges, particularly in the countryside. I believe that Swedish technology and Indian innovation offers a perfect ground for collaboration. It could be by establishing joint research centers that focuses on innovation in medical technologies such as AI-driven diagnostics, minimally invasive surgery, and advanced prosthetics. This will help both countries to stay at the forefront of the healthcare evolution. Ladies and gentlemen, sustainability is key to our healthcare system. Sweden is committed to reducing our environmental footprint through energy efficient buildings and renewable energy sources. India's vast healthcare needs require sustainable solutions. By collaborating in reducing waste, energy efficient medical technologies, and sustainable supply chains, India and Sweden can develop approaches that can serve as global models. Patient-centered care is fundamental to the Swedish system. We tailor healthcare to individual needs, involving patients in decisions and providing compassionate, personalized care. By establishing training programs that allow Indian nurses and caregivers to train in Sweden, India can benefit from our advanced expertise in patient-centered care. Collaboration is crucial to our healthcare successes. In Sweden, government agencies, healthcare providers, research institutions, and the private sector work together to develop innovative solutions. By collaborating with Indian universities and medical institutions, Sweden can develop joint medical training programs that blends our strong focus on clinical excellence with India's need to rapidly train and upskill healthcare professionals. I also strongly believe that one area of possible collaboration is joint research on diabetes and cardiovascular diseases, which are prevalent in both countries. Our goals for the future of Swedish healthcare is to include improving accessibility, investing in innovation and technology, prioritizing sustainability, and enhancing patient-centered care. We will also strengthen collaborative effort to drive progress. Ladies and gentlemen, several Swedish-related companies operate in the Indian healthcare sector, including AstraZeneca, Elekta, Medicover, Getinge, SCA, Essity, and Mölnlycke Healthcare. Their operations in India are win-wins for both countries. Looking to the private-public sphere, the consulate is supporting the India-Sweden Healthcare Innovation Center. This is a collaboration between AIIMS hospitals in New Delhi and Jodhpur and Swedish companies. Furthermore, last year, we launched the Swedish Healthcare Consortium, an alliance of companies that together create a value proposition for new and expanding hospital projects in India. Of course, collaboration goes both ways. Therefore, Sweden welcomes Indian investments in our healthcare and pharma sectors, or any other forms of collaboration. Our partnership not only enhances healthcare, but also contributes to economic growth and social development. By creating jobs and fostering innovation, we are building a healthier and more prosperous future together. Ladies and gentlemen, on a more personal note, I have had the privilege of using India's hospitals and have witnessed firsthand the dedication of Indian healthcare professionals. It is truly inspiring and reinforces my commitment to the Indo-Swedish partnership. Thank you for your attention.
Thank you. Thank you, Consul General. May I now invite Mr. Nabil Tauti, Consulate General of the Kingdom of the Netherlands, for his address.
Good morning. Of course, I have notes in front of me. It actually says Speech Netherlands Consul General Mumbai Hospital Tech 2024. So all carefully prepared by my team. But before I will get back to the notes shortly, Priya, no worries. I want to ask you one thing. The esteemed guests on stage, but also the people on the first two rows. Just turn around and have a look at the audience. Please turn around. What I see is the very foundation of why the cooperation between the Netherlands and India is key. Because we are talking about the power of tech, and you will be talking for 2 days about the power of tech, but there's also the power of people. And if I look at this audience, young, knowledgeable, innovative people, male and female, it makes me very proud because basically it's about people to people contacts. And I'm very proud to stand here in front of you also because our two countries are stepping up. Last year, our two prime ministers, both His Excellency, the Prime Minister of India, Mr. Modi, but also our former Prime Minister, Mark Rutte, they met in 2023. And they talked about knowledge and innovation. They talked about facilitating people to people contacts. That's about you guys. So our priorities, we have many priorities in India. The first one is, of course, our economic priorities. And healthcare is at the core of those economic priorities because healthcare is linked to energy transition, sustainability. It's linked to sustainable food production because we are also talking about prevention and healthy food. But it's also linked to our security priorities. So if you want to make sure that you get goods and medical devices from the Netherlands to India and vice versa, you need to make sure, there's a resilient global supply chain. And the Netherlands being a maritime country, you know how important it is. And apart from the economic priorities, security priorities, there's also economic security. And I think all of you know how important it is to have a very safe and secure cybersecurity environment. So economic priorities, security priorities, and also economic security priorities. This is basically what the Netherlands is about in India, but also what India is about in the Netherlands. And everything, knows its foundation on knowledge and innovation. And again, for that, we need you guys, these talented young people going to the Netherlands, coming from the Netherlands to India. So I invite you really to do that. And we are here with my wonderful team in Mumbai, in Delhi, Bangalore, but also other places of this big country, to facilitate that. Back to my notes. Your Excellencies, dear guests, good morning. It is my pleasure to be here today on behalf of the Kingdom of the Netherlands in vibrant Mumbai. Everyone healthy, fit and resilient, that's the motto of my government. And this is the reason why Dutch companies have come to share their knowledge, expertise and networks at Hospital Tech 2024. I'm also joined today by our health counselor, Mr. Nico Schietekatте. Nico, where are you? Over there. He's based out of the Netherlands Embassy in Delhi, and Nico comes with vast expertise in artificial intelligence, public-private partnerships, as well as healthy aging and oncology. And you will meet him, I think, later on in the session on green hospitals for future sustainability in net zero. We also have the Executive Director of the Netherlands Foreign Investment Agency, Mr. Jeroen Bokhoff. He's over there, also from Delhi. Finally, I would like to commend Mr. Joe Chakraborty for his continuous support and inspiring leadership. Thank you for having us. The Netherlands' approach to healthcare ensures that government, industry, and knowledge institutes work closely together to find sustainable and future-savvy solutions for our citizens, not only customers, but also our citizens. Although you should not believe everything you read, international reports claim that the Dutch belong to the happiest and healthiest people on earth. Do you believe it? I'm going to tell you why. Because we take care of each other. Because we focus on cooperation. Because we are entrepreneurial and resourceful. This has resulted in the best healthcare in Europe and the leading life sciences and health sector worldwide. That's us, the Netherlands. But that's also India. Indeed, the Netherlands is home to a vibrant, concentrated life sciences and health cluster of more than 2,200 healthcare companies and research institutes. The Dutch invented the microscope and pioneered in microbiology and oncology. Therefore, it doesn't come as a surprise that we are the world market leader in medical isotopes and host pioneering companies and hospitals that specialize in e-health and personalized medicine. So, life sciences and health is a priority sector for the strategic partnership between the Netherlands and India, including government to government, business to business, and knowledge to knowledge cooperation. We do it all, and we do it together with our Indian partners, particularly when it comes to improving accessibility, availability, and affordability of healthcare services to our citizens. Over the years, we have organized many trade missions on digital health and medtech to India, together with the Netherlands Task Force Healthcare. One healthcare delegation was led by our former Prime Minister Mark Rutte last year. Presently, the Netherlands is actively engaged in public health, curative care, digital healthcare, pharmaceutics, medical technology, and sustainable healthcare. And we also focus more and more on long-term care. Growing market opportunities in India, combined with the Netherlands' strengths in healthcare, create excellent opportunities for partnerships that address shared societal challenges with smart solutions. And then, ladies and gentlemen, there's Mumbai, this beautiful city of dreams, with its dynamic and rapidly growing healthcare sector. Where else could hospital take place? The city's commitment to improving healthcare access and quality resonates with our own values and objectives in the Netherlands. However, the healthcare landscape is evolving rapidly, and as we navigate these changes, collaboration and innovation are more crucial than ever. This trade show is the right platform for exchanging ideas, exploring new technologies, and forging partnerships. It underpins our shared commitment to advancing healthcare infrastructure and improving patient outcomes. Today and tomorrow, we have a number of Dutch companies participating in the Netherlands Pavilion and sharing their insights in panel sessions, including Philips. Is Philips somewhere here? They have a booth outside. Deerns, where is Deerns? Over there. Make sure you find him. Next Health Digital Solutions, over there. And Telecoms, over there. All the way from, you came from Hanoi now, huh? Good. Welcome in Mumbai. And also present are Walter Kluwers and M Robotics. I welcome you to meet them in person. Our companies are open for business. And so is my team at the Consulate General in Mumbai. For that, I want to mention my colleague, Mrs. Priya Anil, over there, the key in Maharashtra to the large diplomatic network of the Netherlands in India for healthcare cooperation. I wish you all a very productive and inspiring conference. Let's work together for a meaningful impact in life sciences and health. And don't forget what I told you at the beginning. It's about people, the power of people. Take care.
Thank you, Consul General. May I now invite Mr. Rizwan Koita, Chairperson, National Accreditation Board for Hospitals and Healthcare Providers, and co-founder Koita Foundation and co-founder CII Tech, for his address, please.
Good afternoon, everyone. Such a pleasure being here today. First of all, I would like to thank the organizers, Dr. Joy, Parag, Dr. Tarang for inviting me here. It's quite a privilege for me. And the fact that it happens to be a block away from my office makes it even more interesting. In terms of what I thought we'll do today is I'll give you a little bit of my background. In an interesting way, I probably have the least background of anybody on the dais here when it comes to healthcare in India. A bulk of my experience has been around essentially starting and running a technology company, CII Tech, which we started in 2005. And that focus of the company is largely on digital health in global markets. So we have lots of customers in US, we have lots of customers in Canada, Europe, and other places. But we actually don't do much work in India. And by virtue of the kind of work that we did, we got the company actually has become quite successful. We had 9,000 professionals globally, building some really sort of state-of-the-art solutions in medical imaging, to med devices, to data, AI, and so on and so forth. So I ran the company from 2005 to end of 2021, so about 16 years. And then, now the company also has private equity investors. I stepped down and I started running a foundation. It's called the Koita Foundation. And we do a lot of work in healthcare in India. So we started first by setting a center at IIT Bombay. It's called the Center for Digital Health at IIT Bombay. We have a similar center in Ashoka. And we work very closely in a couple of different disease areas. So we have a partnership with Tata Memorial. So we have a Center for Digital Oncology. We very recently partnered with India's largest diabetes association called RSSDI. So we are essentially focused on use of digital tools in diabetology and lots of opportunities there. And about just around the time when I was stepping down from my role at Sirius Tech, I was invited by NABH to come and help them really think through what their digital health strategy would be. And it's been outstanding in terms of the amount of progress that we've been able to make in the last 2 years at NABH. And I thought I will sort of spend a few minutes with you all sharing about the successes we've had, but this is a marathon, right? So what we're trying to do in terms of digital transformation in India and even within NABH. And I would say probably in the first 1 or 2 miles of the marathon. So there's a lot we have to, in some ways, progress. But I think there are so many reasons for us to be extremely, comfortable, perhaps even a little proud, and really, really excited about the path forward. So I wanted to share a little bit with you on that. Yeah. So if you look at NABH, it's an 18-year-old organization. Over the course of the last 18 years, it has done a terrific job in setting up basic standards for healthcare in India. We today certify about 20,000 healthcare organizations across the country. It's essentially the default standard for hospitals, both large hospitals. All the sort of hospitals on the dais have been sort of strong proponents of NABH. As well as sort of small hospitals in India. And then there are blood banks, and there are, both allopathic as well as non-allopathic facility and standards around that, and so on and so forth. But if you look at it from a pure growth perspective, we still cover probably about 20% or depending on how you define, probably 10% of the Indian market. So there's a huge opportunity to be able to drive standardization of healthcare in India. And if you have to cover, give or take 100,000 hospitals, it's going to take a long time. While there is definitely a pursuit to continue to expand what I would call the traditional standards of NABH, especially to smaller towns, tier 2, tier 3 cities of India, semi-urban area, there is no question that if you want to think about improving healthcare on a long-term basis, then the use of digital tools become very important. So when I started engaging with NABH, we already had the traditional standard out for about 18 years. We worked with the NABH team. At that time, I was on the board to be able to develop the digital health standards for hospitals. So we launched that in September of 2023, which is about 12 months back. And that has received terrific response from the industry. So we have, in the first year itself, about 300 hospitals across the country have signed up for getting NABH digital health certification. This is completely different from their regular sort of certifications, which focus on clinical and administrative processes and so on and so forth. And 2 weeks back, we actually felicitated the first 100 hospitals in India who were able to get digital health certified. So that is a really big milestone in India, that we have some of the most leading hospitals in India who put up their hand and they actually got themselves certified. So that was a huge milestone. What we did next in the course of the last 12 months was actually said, hey, we have a standard for digital health for hospitals. How about creating digital health standards for software products, especially hospital information system, HIS, as well as electronic medical record systems that run in hospitals. So we had a team, and the team spent a significant amount of time building out what was the first HIS and EMR standards by NABH for India that we launched 2 weeks back. And that I think is a huge step for hospitals in India and the ability to be able to provide high quality care. Because what we've been able to do is essentially take a lot of the clinical protocols, right? We earlier one of the speakers spoke about antimicrobial resistance, and one of the ways to solve for antimicrobial resistance is to make sure that every time an antibiotic gets delivered to a patient, you capture some basic clinical information on the patient so that you have the right set of protocols on how much antibiotic to give, which antibiotic to give, and so on and so forth. And the traditional way that NABH would ensure that hospitals around the country are aligning to the best practices of antimicrobial resistance protocols is to actually send thousands of assessors across the country to check, and that's what we still do. But imagine if you're building a software which is going to be used in hospitals, and if we could encode those guidelines into the electronic medical record system. And the electronic medical record system ensured that whenever antibiotic was suggested or for a patient, then it automatically opens up a pop-up, and the pop-up requires to fill those 5 fields which are required. Then the software itself drives best practices because embedded in the software are the best practices associated with better treatment of care. So our ability to be able to encapsulate a lot of the best practices of NABH, starting with the way you do patient registration, to admits, to transfer to ICU, to managing patients in ICU, managing patients in IPD, managing patients in OPD, emergency department, and so on and so forth, and ensuring that we are building really high quality software which is able to then get implemented in hospitals. We are essentially delivering a lot of the value of the NABH's clinical protocols along with the software. So those standards have gone live now, and we will actually start taking applications by HIS and EMR product companies from 1st December onwards. Yeah. Now, if I step back, I know we have some amazing countries right here in Europe, from Europe and other parts of the world, perhaps in the audience. But I think I can say it with a great degree of pride that India becomes the first country in the world where the EMR and HIS standards of India will be fully integrated with the digital health standards that are applicable for hospitals, which are completely consistent with the clinical guidelines of NABH in the country. And I think that deserves a round of applause for India. So what we've been able to achieve, and again, as I said, I don't want to sort of mislead anyone to think that we have arrived. We are in the first 2 miles of a marathon, right? So we have a humongous amount of stretch still there. What we are really trying to do is just create the right framework around which if we start to walk down those paths, then we will be able to achieve our objectives, okay? Now I'll give you a little bit of a sneak preview of what we are going to be doing at NABH in the future. We haven't mentioned too much of it earlier. So in a sense, you all are hearing it. You'll be one of the first folks to hear it. What we have so far done is built out what I would call the base layer. Okay, so what are the general guidelines for digital solutions like EMR and HIS that hospitals should have? But we know that hospitals are starting to provide more and more specialized care. So you could have a cancer hospital that is providing a lot of deep capabilities around medical oncology and radiation oncology and chemotherapy and surgery and so on and so forth. Then there will be hospitals that are catering to perhaps other diseases, say cardiac care, and there'll be a whole bunch of requirements around how cardiac care needs to be managed. You may have hospitals that are managing diabetes patients and so on and so forth. You may have hospitals that are focused only on OBGY, right? So maternity homes and nursing homes and so on and so forth there. In the next phase of evolution of NABH is to say that, hey, we recognize that a lot of the sophisticated protocols of what needs are the features and functionalities that need to get built into an HIS solution or an EMR solution, the clinical knowledge of that will exist in a specialized body. So, for example, there is an entity called the National Cancer Grid, which is a national body that is uh, uh, essentially an organization and which affiliates to about 300 cancer hospitals across the country. What if NABH could partner with the National Cancer Grid and develop specialized protocols for cancer care? Then what we would be able to do that if you can just visualize this, you already have the base layer of what an EMR standard for hospital needs to have. We will now create a module which is focused on cancer care in collaboration with the National Cancer Grid. We may create a module which is only focused on cardiology and cardiac care in partnership with its trade bodies. We'll create a partnership on diabetes and ensure that specific protocols related with diabetes are done in partnership with the diabetes associations in India. So that way, what NABH should be able to do is fast forward 2, 3, 4 years. Not only do we have a great foundation on what are the digital standards which are applicable to all hospitals, but we also now have a very deep industry partnerships to be able to ensure that there is a common framework around which we are building these specialized models and standards. If we are able to go down that path, then I think it will add a tremendous amount of standardization, and we will be able to drive a tremendous amount of innovation in healthcare driven by digital health. Yeah. So really exciting times for digital health in India. I'm so happy that all of y'all are here. And many times we have to manifest what the future will be. So I go back to one of our previous speakers who said, it's such an amazing crowd here. So I think it's truly great. I think if we can ensure that we are able to believe that this is going to happen, and if we can do our own small bits, I think this is going to be fantastic times ahead. Yeah. And what the standardization of digital tool does, and this is for both the hospitals and the vendors, the moment you have a common vocabulary. So today, without a common vocabulary, every hospital who wants to buy an EMR or a HIS product has to pretty much figure it out for themselves what they want. So each hospital is trying to articulate what is the EMR in their own words. Each vendor is trying to use their own vocabulary to describe what their features are. If every hospital now who wants to buy an EMR or an HIS product simply went to the NABH site, and you can do it even today because the standard's already up. You download the standard and you just put a tick on which of the features or the objective elements of the NABH standard are relevant to you. And you make that to be your requirements document in your RFP. Every vendor, when they are describing their features, could simply look at the NABH objective elements and the standards and say, okay, these are the features and functionalities that we are compliant with. It takes away all the complexity between two parties, the hospital and the vendor, having a conversation. In the past, each was using their own vocabulary to somehow describe the complexity of what they wanted. Now, both sides are using common vocabulary and common templates to describe their requirements and describe their features. It significantly reduces friction in the buying process. Yeah. So I would just encourage that every hospital who's here, if next time you want to buy an HIS or an EMR product, please use the NABH standards as your starting point. You may obviously add a lot more things which are missing there for whatever reason, but use that as the starting point for your procurement process. And if you're a vendor, then please use the NABH standard in the way you describe your features and functionalities. And we will find that there's going to be a massive acceleration in the adoptions of these tools, which then creates a win-win for everybody, including, and most importantly, the patient, who then is able to get the best care driven by not only great people, but just great processes and great technology. Yeah. So with that, I'll just thank everybody for your time, and really exciting times ahead, and let's make it happen. Yeah.
Thank you, Mr. Rizwan. May I now invite Mr. Joy Chakraborty Chairman CII Hospital Tech 2024 and Chief Operating Officer of the PD Hinduja National Hospital and Medical Research Center to give the vote of thanks.
So the discussion has begun, and this vote of thanks is only for the inaugural session. And because we have some distinguished guests here on the dais, I think this discussion will continue in a big way next 2 days. As a part of this vote of thanks, I want to extend my thanks to our uh, health secretary. He is not here today morning. He expressed his apology because of certain cabinet meeting has been called before election, so he didn't come. But he extended his special thanks. So we are thankful to him. For last 2 3 years, he is working very closely with us, and he's part of almost all of our discussions related to government and CII members. My special thanks to our NABA chairman, Mr. Rijan Quetta. In fact, he has taken time, though he is very close to the venue, but I know the schedule what he has. He is almost everywhere in the country and he is propagating the message of digital health and very importantly, what has to be done rightfully. I can tell you in last 2 3 years, the way we have spoken about digital health for last 10 years, but in last 2 3 years, the way it has taken a shape and it has taken a very credible, space, probably not only in India, but globally, there is a lot of that, contributed by him. So we are thankful for that and thanks for being here today. Now we have 4 country partners. I must say that it happened that all of them are from Europe, but we have worked for last several years very closely and very we have very diligently picked up each one of them and requested them to be part of that, and they have become part. For example, to say uh, from Netherlands, they have become part of this exhibition. They have taken stall. Their technology companies have come here, and I can tell you the kind of technological advancement. And in their country, the entire population they have a digital card, so entire health record, everything they have in one card. I think that is something what we should aim for, and there are many other technologies they have brought, introduced, and we are using it. And one of the companies is Philips. I think most of our hospital, if we don't have one, we at least have 2 or 3 of those technologies present here. I go to Sweden, and he mentioned in his speech about Electa. So in our hospital, I think we got the first uh, your gamma knife machine in the Southeast Asia, and I can tell you that is one of the best technologies what somebody can look for. And not only that, very recently the business Sweden they have come and their companies have started working with Indian counterparts. Then I go to my friend from Israel, and Israel is known for their startup companies and their, kind of new innovations they bring. I think we need to keep a pace and momentum with that. And every time I come across, all are very fascinating, technologies what they produce. Then I come to UK. In a personal level, she mentioned about the King's College and Hinduja Hospital collaboration, what you have made formally launched at the beginning of this year. But I can tell you every year, digital companies, they come, they make road shows and they visit Mumbai. And again, we experience their kind of new innovations. They bring educational training institutes and all sorts of, you know, components which should be part of the healthcare ecosystem. They have all ingredients. I think it is the time for us to explore that more and more. Then I have Rahul from Thyrocare. So he is here with vast experience, and Thyrocare has become a major partner for this event in this year. And my friend Tarang and Parag, chairperson and co-chair for the healthcare committee of CII, their extensive support has made this event possible. And all the sponsors, media, they have extended their support, and we are grateful to them. I'll be failing in my duties if I don't mention about the healthcare subcommittee of CII. I think we started 7, 8 years back, and every year we see that we are becoming stronger and stronger, and we are able to deliver some of the nice things. And one of these is this event today. I want to mention about 4, 5 names, and I think they remain always at the backstage, and we normally don't come across to them without any priority, without any seniority. I want to take their names, and they have worked relentlessly for last 3, 4 months. And one of them is Saurabh. He's not here. He lost his father, but he has done the extremely nicely done the background work, and he has set the full concept and theme of this event. We have with us Prakash. He started this, started working with me, and he has been superannuated, but he is here today because that was his commitment, and he has worked very well. We have Ashwin, we have Pankaj. Both of them were like my left hand, right hand, working very closely. They are here today. I don't. He's here. Ashwin is here, and so thanks to all of you, and Mohan from media team. I saw him here, and they are also contributed significantly. So I'm thankful to all of you, and I think it is a great 2 days event, and we'll have so many discussions which are going to contribute to all of us. Thank you very much.
Thank you, Mr. Joy Chakraborty. With this, we come to the closure of the inaugural session. A big round of applause to this esteemed panel of speakers. May I request come together, and we'll just have a group photograph. I'm requesting speakers to please stay back on stage. As a token of our gratitude and appreciation on behalf of CII, we have a few thank you letters that we'd like to share, and I'm requesting Mr. Joy Chakraborty to do the honors. A big round of applause. Requesting Dr. Parag to do the honors for Dr. Joy Chakraborty. A big thank you to all our esteemed speakers. We now quickly have a changeover and move into the first session for today. The first session is on technology and analytics in healthcare. In today's rapidly evolving healthcare landscape, technology and analytics are transforming patient care, operational efficiency, and clinical outcomes. By leveraging advanced data analytics, machine learning, and artificial intelligence, healthcare providers are unlocking insights that drive precision medicine and enhance diagnostic accuracy and personalized treatment plans. This session will explore the evolving landscape and the role of technology and analytics in healthcare. May I request everyone to please continue to remain seated. We will have a short break post this session. We need to quickly move into the first session for the day. I'd like to introduce the esteemed speakers on this panel. Joining us again, Dr. Tarang Gyanchandani, Co-Chairperson of the CII Western Region Subcommittee on Healthcare and Group CEO, Sir H.N. Reliance Foundation Hospital and Research Center. Also joining us, Mr. Mohit Rajpal, founding member of Eka Health.care. Ms. Samriddhi Pandey, founder and CEO, Defy Aerospace. Mr. Nikhil Goyal, Country General Manager, India Cluster for Carestream. Mr. Yadavali Subramaniam, Managing Director and CEO, Health Governance and Analytics for Next Health Digital Solutions BV. Dr. Rajkumar Patil, Medical Director, Bombay Hospital. Mr. Chandrasekhar Sibil, Vice President and HOD of Medical Division, Fujifilm India. And Mr. Gaur Chakraborty, Managing Director of Telecom India Pneumatic Tube Systems LLP. May I request everyone to please come on the dais, our esteemed speakers. This session will be moderated by Mr. Atin Roy, Senior Vice President, Health and Wellness for Ogilvy. A big round of applause, please, for our esteemed speakers. Over to you, Mr. Roy.
Hello. Hi, good morning, everyone. It's fabulous to be here amongst this galaxy of rock stars from the industry. And what a fantastic forum to discuss something as interesting as technology and analytics, right? Uh, Arthur C. Clarke once said that any sufficiently advanced technology is indistinguishable from magic, right? And we are living in magical times where science fiction is being converted into science reality in the healthcare context every day, right? Star Trek used to have those tricorders, if you remember, which used to scan and analyze and diagnose at the same time. We all have those tricorders right now in our pockets and are in front of us, right? So exciting times. And healthcare and hospitals and care has come a long way, where from 1666, when toads used to be hung around patients' necks during the Great Plague in London, to the mRNA vaccines in the COVID pandemic that helped us, right? Great journey. But human beings, I think, haven't changed in the past 40,000 years, and nor has the need of care and treatment for them. So this is where I would want to probably move to Dr. Tarang, right? As a doctor and a leader, right? Care is a very human trait, and it's the primary role of a hospital, right? So what do you feel, or what is your opinion or your vision of how care is going to impact the quality of care, right? Quality of health of people in the coming future, or is doing that right now?
So thank you very much. So I personally feel that, we have all talked and we will be talking a lot about technology, artificial intelligence, machine learning, and the role that it plays in taking care of our patients and taking quality care of the patients. So I think the there are a lot of areas in which today we can very confidently talk about how this whole piece can be woven into uh, a methodology to enhance the care for the patients and also give them a quality care when they visit our hospital or when they don't visit our hospital and they are like normal people at home. So I'll just list down a couple of points and maybe elaborate one, and we'll take up the questions during the Q&A. So one of the key areas which I personally feel is very, very crucial for any healthcare is, which is one of the weak areas also in our healthcare delivery, is research. So how can research help us to enhance the care? Research does not only means clinical research, well, that's also an important part, and that can be done when we have the electronic medical records. The mining of data becomes much simpler. But research is also into how you can give a personalized care. You can do predictive analysis of a patient or a person whose database you are holding and give him something which can provide him a personalized care. For example, how the data of a person is in your system. So once the person actually comes to your hospital by means of your analytics, you should know before the person comes that, okay, this person is probably a visually impaired person. So the care starts from beginning of the patient's visit, or actually before the patient enters the hospital, because if your database points out to you that, okay, this person with whom you have exchanged a dialogue is a visually impaired person, you cannot expect that person to follow certain simple commands that you would be sending through your SMS or WhatsApps or whatever. So you have to have a different process to deal with that person. That's talking about the care part of it. That's talking about the personalized care part of it. Now, coming to enhance the quality of care. So, quality of care, quality is in everything that you do with anyone in a hospital setting or in any healthcare setting. I'm again and again, I'm a firm believer that healthcare is not only hospitals. So, quality is everywhere. So, now the quality is also in standardization of the process, quality is in incident report monitoring systems, risk management, your care management process, and also, most importantly, how you can enhance the patient safety and patient experience. That's all, but not completely what quality is all about. It's much beyond that. But to begin with these building blocks, okay, so we all celebrated 17th September as International World Patient Safety Day. What did it talk about? It talked about the accuracy of diagnostics. So that you get it right and you keep your patient safe. Diagnostics is most important part in which technology can actually not only standardize the processes through which you come out with accurate results, but it can also help you to have standardized systems in which your diagnosis is most accurate as well as it can reach to masses. So, for example, through AI, we are able to look and screen the CTs and the X rays. There was a time we used to only look at tuberculosis, but now we have gone down to much more different things. So, for example, if you are looking at CT or X ray or lab results, you are able to get the diagnosis correctly using the power of artificial intelligence, and that's where the strength comes, that it's not only that you are able to pick up the area which is affected, but you're also able to pick it up with the accuracy so that when you treat the masses, you are treating them safely. We talked, and I'm sure there are sessions for antimicrobial resistance. Again, we need to use technology. on the way we were discussing how do we come out with a way to reduce the antibiotic resistance in our hospital. Let digitally it be controlled. Doctors are very, very nice people. I'm a doctor.
We all agree that.
But very difficult people. Again, I'm the one. So it's very difficult for doctors to change certain ways of practice. And in the world of change management of healthcare leaders, we are always taught that digitization, information technology is a digital or a digital infrastructure is one of the tools for digital for change management. So when you do that, you change the people's thought process. When you have some tool like this, where the tool only will not allow you to put up meropenem for a simple infection. I think that's the way where we need to move towards rather than a poor medical director trying to ask for explanation. Why have you prescribed meropenem? So I think that's where my medical director is sitting here, and she's must be thanking me in the heart that I do acknowledge the crunch that she goes through regularly on these matters. So yes, there we need digitization, we need automation. One of the other areas where I personally feel that we can enhance our quality care through technology and analysis is in the treatment of diabetes mellitus. It's really gone a different level when we talk about AI and technology through the help of wearables, through the help of the devices which can help us to regularly monitor, titrate doses, etc. Same is coming up in chronic liver disease management, chronic kidney disease management, and also, of course, for the ICU where the care can be standardized and also uh, we can ensure that it's a standardized protocol and treatment based treatment which is given to the patients so that we minimize the errors. Another very important area clinically is medication errors, where we can harness the technology and enhance the quality of care to the patients. So there is just too much. It's too much. I mean, I can go on and on, but two areas I want to touch upon before I just pause here is one is how we can use the digitization and technology to enhance the care for our cancer patients, whereby through the genomic sequencing, post analysis through AI, the reports that we generate can actually help the patients to get targeted uh, immunotherapies, targeted chemotherapies, which is the way to future for the cancer. US uses it very regularly. We use it only in certain institutes where we have those kind of flexibilities. But I think that's the way where we need to look at, where we need to have this standardized so that we can even move it for screening and treatment at tier 1, tier 2 levels, and not only certain specific metro hospitals where we have those kind of facilities in our hospitals. Second area which I want to touch upon is preventive analysis, where we can actually feed in the information of the patients and also help them with some personalized standardization, standardized reports, which can actually predict the risk of the patient person for a particular disease so that he can direct his care towards that. So these are some of the important things. One of the things that we have recently used, which is really helping our patients in bringing about the efficiency and accuracy, is usage of a tool which I actually happened to meet a friend in California, and he was working on it as a startup 3 years back. And now it's like something which we will be launching big way through our Geo Health portal also, is a tool which actually works like a junior medical doctor. So when the patients are lining up for waiting for the OPD, this tool, if you fill up the information before you come to the hospital or while you are there, because there are a lot of patients we do realize will not be able to fill up themselves, they need help. If you fill up the information, it's actually like the best history taking that a resident doctor can do. It is based with the tools that can actually give the doctor analysis that, for example, if this is the symptom he's presenting, these are his reports, then these are your differential diagnosis and this is the analysis. Just imagine 100 patients outside your OPD, and if this is done, so when the patient is seen by the doctor, two things can happen if this tool is not there. One, doctor will see the patient for 2 minutes and here you go, you miss the diagnosis, you miss the treatment, bad outcomes. Or you will take hours and hours and hours to see these patients, resulting in cancellation of certain appointments, obviously hit to our PNLs. Now, what this tool achieves is accuracy for the doctor to come to the diagnosis. So he straight on comes to the part of talking about the patient's treatment. And second is we are still able to see 100 patients in that limited time. So this is where the quality meets the care. Thank you.
Fantastic. Great perspective. And I'm sure that was a doctor talking. So, so let me turn to the other doctor here, right? Dr. Patil, ma'am talked about technology, and all new technology costs money, right? And affordability is a big question mark in health, right? So all these technologies will involve costs, trainings, etc. How do you think new tech analytics contribute to the affordability of the healthcare in the hospitals, especially?
Thank you. That's a great question, in fact. At the outset, I would like to thank CII, particularly Mr. Joy Chakravarti, for having me here. From the morning, we have been talking about, digital, a lot of digital things, which, the earlier session was a great session. Of course, Dr. Tarang has answered, a lot. But from the patient perspective, what is it? What is it translates into? How affordable it is for me? How access to healthcare is easier? And as an before the hospitalization also, what Dr. Tarang talked about is about the history, filling the form and just seeing the doctor. So, smarter technologies, we are evolving into smarter hospitals and process efficiencies, workflow efficiencies. If we can make them, make our patients fill up those the things, so our doctors can spend more time on the patients. And of course, before that, carrying a national mission, that is one account, that is Ayushman Bharat Digital Health Mission, ABHA account, one hospital means one central registration, and the hospital person goes to any hospital or any healthcare provider, the same account it is used, and it has the history, the previous treatment. So that becomes a smarter technology for the patient. In fact, before that also, preventive healthcare technologies, these are more in terms of patients, because of these large evolution, the patients can access. And of course, modifying the healthcare lifestyles, the hospitalization cost is reduced. As an outpatient, smarter workflows, earlier diagnosis, and then as an inpatient, of course, with the advent of technology, the length of stay in the hospital becomes less, the use of antibiotics is limited. So all these translates into better affordable healthcare to the patients. And with surgeries also, so with precision robots and all that, the length of stay has come down, and of course hospital, it reduces the cost to the patients. So all these technologies which today we are talking about, AI, everything, of course it should be for the patient. It is like I quote an example of always, there is a buffet which is there. How much the patient can take, that is how much he can digest. He should pick and choose. As in from the hospital administration point of view, each one should have a digital health strategy for the organization, and from that point of view, we will be applying those technologies in our hospital, so that our patients are benefited limitedly. And of course, for the mass population, of course, there have been umpteen number of examples, how to make it affordable, how the healthcare should be affordable for the mass population by preventive screenings, predictive diagnostics. So all those things will translate into affordable healthcare for the population.
Great. Thank you so much, Doctor, for giving this perspective. So now let me just change the direction of the conversation to a very interesting topic. For me, all of us have seen drones, right? Drones flying over these top shots and all that. And I was reading the NHS in UK has just pioneered or piloted delivering oncology chemo drugs to a certain location through drones. So let me ask Ms. Pandey, Samriddhi, you are a leading authority in the field of drones, right? So how do you think, what is your vision of how drones, especially in the hospital segment, how is it going to change, or what are the new things that it's going to do for us in the hospital?
private players for drones to work together in order to set up the infrastructure. There needs to be investment to set up the infrastructure for an aerospace product to ultimately assist the hospitals to provide better healthcare and faster healthcare. So I think that's the vision and that's the application, and that's where we are headed.
Great, fantastic. One small question and weird one maybe. When do you see doctor in your pocket that Dr. Tarang talked about fused with the drone technology and going there? Do you see that in the near future?
Sorry,
Dr. Tarang talked about the junior doctor app, right? Maybe a robotic doctor fused with a drone flying somewhere and providing treatment. When do you think that would happen?
6 months.
Wow. Oh, fabulous. Cool. So my next question is to Nikhil. Mr. Goel, um, uh, Apple watches are now an FDA approved wearable or diagnostic tool, right? And then if you talk about medtech, it is cool right now. But wearables aside, right? What does medtech have to do with in the hospital segment, right? For example, wound management or oncology, right? The serious business of medtech. Can you shed some light on that?
Sure. Uh, First of all, I love the way you make this entire thing so magical. Harry Potterization and Star Wars of MedTech is amazing. And the thing about Apple Watch or Samsung Eye, there's always this conversation in healthcare circles that who's going to disrupt what? Are IT companies going to disrupt MedTech, or are they going to partner? And honestly, it's a 15-year-old conversation. So this is nothing new. We've been hearing this, and I'll just take you a little bit back to my journey and then kind of correlate. So unlike many folks here, I'm a banker turned healthcare. I looked at, I was financing hospitals during the insurance boom that happened during Arogyasri down south, and then moved into first J&J in wound management, did orthopedics, and then got into Indian MedTech Merrill into cardiology outside of India, and currently lead K-Stream, which is into X-ray radiology solutions. So just from what has happened, when I entered into MedTech 15 years back, I was told about 5 Ps and 4 As. I used to think they're all very theoretical, which is physician, patient, provider, policy, payer. 5, 4A being access, adoption, affordability, awareness. And I've been thinking before I came to the session, I thought all of them are still relevant as much. So technology, irrespective of in what form or manner it comes, unless it gravitates or glides through these, it really doesn't create an impact. But going back on wound management, specifically what really happened was that you started seeing the advent of what is called laparoscopic or minimally invasive surgeries. And hospitals in India, as well as companies like us, work together in getting that done. So open surgeries vis-a-vis lab, the benefits, minimally invasive, went from one surgery to another, adoption became easier. I worked a lot on minimally invasive cardiac surgery, which itself was new at one point of time. And when you look at orthopedics, I thought orthopedics moved from different ways of doing surgery to just having more technology about intraoperatively how to make it better. So it was more imaging, more navigation. So you had the advent of C-arms, the U-arms, the O-arms, and all those imaging solutions that work. I think Dr. Joy spoke in the morning about gamma knife. So, all those neo technologies. Look, the technology out there is willing to burst into India at speed unforecasted. So there's immense amount of technology, but not all technologies abroad is there in India. And the reason is the big A of affordability. Uh, you know, you, you know, the country is actually not one India. India is a multitude of countries, and as a result, you will find buyer for all technologies. But what scale any technology brings in is when organizations want to enter India or scale it up, as far as India is concerned. What is currently happening, perhaps at a speed more than ever, is you had the advent of what we used to call as the soft tissue robo. So, broadly, they will come to urology, gynecology, general surgery. Today, you're seeing hard tissue robos. So you're seeing those in orthopedics. You're seeing a lot of robos making their way into what is traditionally different kind of orthopedic surgeries. What you would see is more usage of robotics across many more procedures. So that's where the next level is in terms of surgical intervention. You spoke about devices which are wearables. I have a feeling that wearables will start talking to med technology sooner or later. They have to. There's no point having so many different technologies if they're not talking to each other. So there has to be a way out there, and possibly the back end of that is or it was supposed to be was the digital health mission that the government is pioneering, we should where probably fungibility, interoperability, the ability to use the data at one level, like what Dr. Patil was talking about in terms of the ABA account, is possible. You can actually use the data. Otherwise, you're just creating a multitude of data which is not really getting utilized at any level. So the future is superb. The future is bright. And I think all of the factors that you hear basically in technologies, whether it's artificial intelligence, machine learning, they all have a role to play. But somewhere it's like a storm waiting to unleash itself. It's all there, but it's not coming together at the speed and pace at which you may really
So
want it to come.
there's a tipping point you're saying that will arrive
Yeah,
very soon.
and also there is another angle of what this kind of technology coming in from medtech would do to hospitals. In my view, the collaboration between different specialities will become better or has to happen by default. I was working on a technology or a procedure called TAVI, which is an end state cardiac procedure. By default, cardiac surgeons and cardiologists have to work together. I can assure you both do not naturally talk to each other or work in collaboration. And I'm sure folks like Dr. Tarang and Dr. Patil will have a happy situation trying to manage superstars in both those fields. But that's how the next level of collaboration would be induced by technology, because it will go towards patients and not really be in silos going forward.
Okay, great. Thank you so much for that perspective. So now let me come to Mr. Subramaniam. Subbu, may I call you, right? I overheard a conversation. Subbu, it's never really the data. Nikhil was talking about data, right? We're generating so much of data. We have to talk to each other, right? All this data is happening, but what you do with the data is more important than the data, right? And you've done extensive work in policy framework and governance analytics, right? So just tell us and enlighten the audience as well on how does the analytic framework work in a hospital setting versus a public health policy setting. Just please elaborate on that, can you?
I just need to give a very deep thought process that we went through a couple of years back. All that has been super into the hospital level is what we look at from a critical perspective as a micro point. What we look at from governance is a macro point. So let's say I ask you any investment for the audience here. We understand what's most important. And we also understand what it means to have, let's say, what is security. You also understand what is investment. What's something common to all of them is that they run on the basis of intelligence. There's enormous intelligence that actually drives these processes, right? To have this, does the nation have the intelligence to understand what is happening to its health situation? So that's where we work very closely on what's called health security and governance analytics. So what do we mean by this? It's a very simple use case. I don't know what is talking about, but I understand very clear what is. So in terms of governance analytics, it's very simple use case. Where when this, how many beds should be there? And why should we here and not there? And what's socialization? It's no problem, that topic. And then the kind of impact that it has, the moment you create that kind of system in sensation, the way all the works, that's let's see. We have this problem. I mean, I work almost to the grassroots all the way up because problems are right in the grassroots. You go to the public health center, anyway, the standard concern that you have is we have the service. It's so difficult to understand with all technology that we talk about, supply chain management, that we do not know what medicines required where, at what time it was.
So true, so true.
Right? Is it so difficult? It's not. But this is a problem that needs to be handled at the governance level, where we need to have systems which essentially have the data that right? So in the context as large as India, and probably in several countries that I now work with, we work with all the different countries, some of them in Africa, some of them in Asia, and of course India is a fantastic nation to work. And in almost all these countries, what we see is that there's huge amount of data that is available. And the greatest concern for this data to come up is strategy. So what we usually request is please do not give us individual data, give us anonymized data. And let anonymized data be in open domain. There's open data, published anonymous data, and anybody in the data sets can come up with answers like this. Today, we are in a position to actually give a huge prediction of anything and everything as long as we have the data sets. So what we actually propose most of the time when we talk about governance analytics is let's not talk about exchange protocols because it's very complicated. On the other hand, give a simple standard on public data, open data. Just put the open data out there, and there are enough researchers that are working out there to come up with solutions that can support. And based on this large framework, we are in a position to work with the policy nations, and we talk about what should be done for the next 5 years for the health services. Last but not the least, we have very interesting algorithms which will tell you how to move your health index ranking from wherever you are upward. Which means I can actually say today you are in rank, let's say 140, and those rank countries that I grew, right? And if I have to push it up, let's say 90, 70, what do I do? I have an algorithm, a set of algorithms which can actually today do a prediction saying just work on medical health care and your rank goes up because this is the deep thing in your. So that's kind of analytics that we're talking about. And I think that's the future really.
Fantastic. What a great perspective. In fact, having worked with a large number of consumer organizations, I know that can predict the demand of a chocolate, but I don't know why cannot we predict the demand for medicines. That's something we should think about. Okay, so next question is to Mr. Chakraborty. Yeah, and again, one of my favorite topics, yeah, something to do with science fiction, right? Pneumatic tubes, right?
Yes.
You've done immense work on that,
Quite close.
and I remember seeing them. Perhaps they are a very old technology, 1800s or something, right? 1850s.
Correct.
So how does it fit in the modern technology universe of the hospital today? Can you please tell us?
Actually, pneumatic tube systems is basically networking of tubes throughout the hospitals. It connected one department to another department. It's actually transport the samples up to 5 kg weights. So we already handled almost medicines, pharmacy samples, blood samples, blood bags to one department to another department with a speed of 5 to 6 meter per second. So, for example, I'll just give you one example at SVP Hospital, Sardar Vallabhbhai Patel Hospital, Ahmedabad. Our total tube length is 4.5 kilometer inside the hospital. Weekly transactions is almost 24,000. So per day, this carrier transported almost 600 kilometers throughout the
Wow,
hospital.
600
Yes,
kilometers. That's good for the heart of the
yes,
carrier, right?
we already eliminate. On that sense, hospital can use their manpower in different areas. We are handling this kind of things,
That's
and this
very
is already incorporated with BMS system. Everyone, all technologies, and every weekly we are just analyzing the system.
okay.
These are
Superb, superb. That's very interesting. That's a very innovative way of looking at the entire thing. And so my next question is to Mr. Sibyl, right? Mr. Sibyl, you've been in the diagnostic space for some time, right? In a country like India, late diagnosis is a big problem and it leads to a lot of disease burdens, right? How in this challenging country that we live in, aversion to tech, lack of training staff, infrastructure, geography, how do you implement that in a hospital setting, especially with respect to diagnostics?
Yeah, so as you have correctly said, and many of the speakers, Dr. Patil, Dr. Tarang has already told that late diagnosis or misdiagnosis is a big problem in India. And you can see that I will start with some stats. We have around 1.5 million patients every year we detect for the cancer. And we work basically on the breast cancer. A lot of work is done by Fujifilm on the breast cancer. And approximately 2 lakh patients have been detected for the breast cancer every year. And out of them, 50% of the patient die because they are detected at a late stage.
My God.
Yeah, so basically, if you see the developed countries like US, Europe, there the mortality rate is far less than 5%. So here it is 50%. So the major reason
Disparity.
is the late detection. We are seeing the lumps, and many places there's no awareness actually. So first, what we are trying to do that we have now many vans in 19 districts which are going to the smaller places, and we have tied up with the ANMs and ASHA workers. They are going and educating the patients about the self screening and self this thing. So if some lump is there or those patients can come to the diagnostic centers and they can get their mammography done. And then after that, with the help of the doctors, then we detect it and further go for this thing. And I can tell you that in a smaller places now we are going and we are detecting. And in India, the problem is that at a very young age, we are detecting those patients, which are in US and Europe. They are coming after 50 years or 60 years. Here
Okay.
at 30 years, those cancers are there,
Wow.
breast cancer, especially breast cancer.
My God.
And the similar kind of things are there in the TB. We are working with Government of India in NTB program. We have a portable X-ray machine which goes to smaller districts, and we have 5 to 6 machines which goes in villages or the factories near the factories or areas which are not very good to live. So those areas we go and we screen the patient. We first of all we have to make them aware through nukkad nataks and other things that you should come and get your screening done, because most of the patient doesn't come when we tell them to come. We have to educate them, we have to motivate them to come. And once they are there, we do X-ray. We have portable X-ray, which is very handheld X-ray machines. And with the help of AI, we detect that whether probability of any TB is there or not, and then a gene expert has been done. And then we have found many cases in India. We have almost screened 10 lakh patients now, and we are doing a lot of work. So the major thing which I can feel is the screening programs. There are very less screening programs from Government of India, which should be started for especially the cancer treatment or early detection of the cancers, early detection of TB. TB, we are doing a lot of work now. Complete government machinery is working on the program of NTB. And as well as I think that screening should be started from the school days, and that education should be given to the students, and definitely they can take care of their health. Once we will start from the school, it will help them and habits will be inculcated in them.
Oh, fabulous. What a great perspective, because starting early and starting in school is a great idea. Thank you so much for that perspective. So, Mohit, Mr. Rajpal, right? The last but not the least question to you is, you've done a lot of work in hospitality, right? How can hospitals learn from hospitality? That's a key question, because in hospitality, in travel, over the past few years, we have seen drastic shift. Where it used to be controlled by the travel agent, and now the traveler controls his entire experience, right?
Correct.
How can we do that with patients and caregivers?
Right. So first of all, thank you so much. Thank you, CI. Thank you, Dr. Anjali, for having me. I'd like to also thank Dr. Rizwan, right? F Stressing on that, yes, the health is changing. And at Eka Care, we also feel that, yes, uh, in health, we see a UPI movement. The way fintech has changed, one demonetization has changed. Today, we see that, yes, everybody would like to pay either through a Google Pay, Paytm, etc. Right? The change has happened. Similar way, we see that yes, health is changing. There are close to 660 million patients have registered and created their Aadhaar ID. We know yes, Indian government is focusing that everyone should have an health ID too. And on the other side, we also see the caregivers, right? Basically, the doctors have also registered themselves. They have registered their health facility. We see the numbers reaching to 460K. So coming to your question, that how hospital can improve the experience, right? What I feel that you know The doctor and patient experience should be wow, right? Because it's a one-on-one connect. And to the first, the hospital should adopt that, yes, they should adopt to the ABDM technology, right? Any patient coming to the hospital, first of all, they should have a health ID, because we have seen the trend. The moment the patient comes in, they want to have a second opinion, and second opinion can only happen if the data is stored in a centralized way, so that the another hospital or another hospital, another doctor can see the history. And when you know the history, only then the treatment can be apt, right? So that's what we see. On the other side, we still see a lag that, either booking an appointment or booking a bed, it's still unsolved, right? We don't know that whether hospital has a bed or not. At the emergency, you tend up calling people, taking references, etc. So that should be solved. There has to be an inventory where patient knows that, okay, yes, there is a bed available in the Max,
Right,
Vedanta,
right.
etc. That's very important.
We know
Today,
the plane seats are available, but we don't know the bed seats are available or
that's
not,
right.
right?
So this
What
is
an
what
irony.
we solved in hospitality, right? I remember in 2006, somebody saying that hotel booking cannot be done online. Today, we all know the answers, right? And after spending so much time in travel, we really want to disrupt the healthcare. And at ECA, we are really building exciting stuff, fully focus on that, how we can improve doctor and patient experience. On the other side, yes, to the hospital front, you know, we there has to be a mandate that yes, every doctor should adopt to the digital technology, which is like EMR. The moment you have a right EMR being used in your hospital, then all the department can talk to each other because the data will flow. uh, let's say if I'm an OPD, the nurse can see, and if there is someone in ICU, they can also see. So eventually the data should flow. And with the right data insights, you can give a personalized consent, personalized, things to your patient, like what should be the treatment plan, if there is any wellness thing is required, that can flow. Not only this, the do's and don'ts uh, should be through the digital medium. So think of that, yes, I'm getting discharged and I have some restrictions to be followed or not to be followed. If this can be given through the digital medium to my family, that will create a wow experience. I think this is what we all have to bring it together to stitch this journey so that the patient can get a wow experience. And on the other side, the patient can also get a better treatment. So this is what I feel we should definitely bring it onto the table. Rest, definitely, we are building the same stuff at ECA. And again, repeating it that yes, the focus is that how can we improve the doctor and patient experience. So happy to discuss in length and if anyone wants to have more details on it. Thank you so much.
Great. Thank you, Mohit. Now I would like to open the discussion to the audience. If any of you have a questions for the panel, is there any questions for any of them? No questions? Yes. Yes.
Good afternoon. My question is to Dr. Tarang. So, are you using AI in your hospital, and how is it helping if you are using it?
So we are using AI in many aspects of care, not only for the screening purpose, because as a hospital you do not do screening in those bulks, in masses, but as a part of our Reliance Foundation outreach team, we do screening, and there we use the artificial intelligence for screening. We are using AI more so in integrating the various biomedical equipments. So, like for example, we have all the equipments, most of the equipments, which have their own inbuilt uh, IoTs, the AI system, and through the AI, they give algorithms for the diagnosis, whether it's our the latest MRI machines or the even the open MRI system that we have, which is one of its own kind in the whole of Asia, or the CT scanners or in radiation oncology. So the whole protocol of the patient is basically AI based. It's based on the what is right for this particular patient, especially when we are using our ethos for planning the radiation treatment for our cancer patients. It's all AI based algorithm which is used. So in most of the areas where there is a medical technology, we use AI. We are now starting to use AI more for non-clinical work also, which is in terms of how we can optimize our billing accuracy, how we can do better asset management, how we can demographically or seasonality wise assess which are the times of the years where we have high consumption of which particular consumable medications so that we can manage the stocks accordingly and so on and so forth. Thank you.
Great. Any more questions? No.
Hello. Yeah, I am Kishore Kumar Mistry. We are in healthcare industry since more than 2-3 decades. So I have heard all the DIAS member from the different topic with their specialized individually. Like tubing, then he has come for that data analytics, then drone, then AI and digitals. Then you talk about TB and other disease also and travel in the hospitality and management also. Now the thing is that all these different area where we have a common platform, where we find the solution of the best thing or delivering to the patient's care.
Who are you addressing this question to? I mean,
No, anybody can ask. This is a common platform which we can connect everyone to one platform to give the best delivery to the patients, needed patients.
See, if you have heard my talk, I have always said, keep there is a lot in the this one market which is available, but we have to have a digital health strategy for your own organization, that is for your own institute. You have to pick and choose how much is required. Like for example, the AI which is used in the hospital, which are the areas where you can use the AI. Like I'll give you another example. Like for example, the telehealth services, teleradiology service, telemedicine services, which first visit, which is the patient has to come to the hospital. The doctor will see them physical examination, whatever the tests which are done, they are there. But subsequent visits, they can do it through video consultation. That is one of the platforms. But all these things you have to choose. The institution has to choose itself. That's what my this one was.
Yeah, but sir, in rural area, which is say from metro, it is a 115 kilometers.
Yeah.
Right. From there, if you take the telemedicine there, but the thing is that the concerned person is not that literate for taking that matter to the concerned doctor in the city area.
Correct.
So that is a limitation again right now.
Yeah, I understand that limitation, but that limitation is overcome because of the technology. Here, the person can seek help from the local population. He does not have to come 150 kilometers to the hospital center. Like for example, in Mumbai also, there are there are days wherein Mumbai traffic is very bad. Like for example, today that traffic is very much heavy. People can do that teleconsultation as well. So these things which can be avoided because of technology. So you have to design your own system. It has to be customized to your own needs. So that is what my point is.
So you mean you are talking about the institution which has to take care
Yeah,
for the needed
institution should take the services from all these artificial intelligence, video conferencing, whatever that is. You have to pick and choose. Yeah.
Okay, so we do very regularly tele-ICUs and teleradiology to the remotest parts of the country. So answering your question, you are absolutely right. The people there do not have that much of a knowledge to use the system. So obviously the person this side is very qualified, very trained, but that side also you need a person who could at least gather what you're talking about. So if you are really doing a tele service, whether it's in any area, radiology is actually pretty straightforward because you have to generate the report after looking at the image. But tele ICU can actually be challenging. So in that case, you have to have an infrastructure where you have to go and train those people on how to read your system. Plus the platform that you use, it has to be very simple and something that even a plain, you may not even get an MBBS doctors in those settings. You may actually get a homeopathic doctors, or even, I mean, there's a traditional medicine people. So, first of all, it's the biggest problem that we are facing in such cases is the acceptability of, first of all, tele ICU system. Because if I am trained in traditional medicine, I would like to do it myself. So, you know, if okay, if my if the head of the hospital says no, 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 do the tele ICU treatment, then it becomes a little bit of a catch there. So you have to have regular human to human interaction, because that's always most convincing to the other side. Get a buying in from your stakeholder, train them, put up the infrastructure which is easier at both ends, at this end to give instructions, that end to understand the instructions, and then only you can be successful. So wherever we have done tele ICU, it's almost now 300 beds odd, small number, but at least it's really creating a great impact in the outcomes. And we do regularly teleservice in our outreach, which is at Dharavi or at various other parts of the Mumbai city. Again, the same problem. I think the most important thing is to get a buying in from the community. And all these areas where we have done, we have given an end-to-end solution. Agree. That's why you know in my inaugural speech I said I have only started learning what actually to do with all these things in last 2 years. The concept of AI and all we are talking for the last 1 decade. Then we all used teleconsults very nicely during COVID, and we thought this is AI. This is medical technology. Ho gaya, bas. Digital technology is over with having the video consults. But that we need to understand that the WhatsApp gave us long time back. We were not using it. Now we used it. We created similar platforms. But I think it's much beyond. So I think we are evolving. We are evolving, but at a slower pace. But at least as long as we all understand, we come on the same platform, that what's the power and we understand it, I think it's never too late.
Great. That's a fantastic point to end this discussion. I think till the time technology and analytics can reach the grassroots level and make the life of a human being better, I don't think we have done our jobs, right? So that's that. Thank you so much, panelists, for enlightening us. I think it was a fabulous thing. Thank you so much.
Thank you so much to our esteemed panelists. Thank you, Atin. May I request you to please gather for a group photo? As a token of our gratitude and appreciation, I'm requesting Dr. Tarang to please hand over a token of our appreciation and thank you letters to our esteemed speakers. A big round of applause, please. Requesting everyone to please remain seated. We quickly move into the next session. Thank you, Dr. Tarang. Our next session delves on the role of technology in addressing antimicrobial resistance. Technology, as we know, plays a pivotal role in combating this crisis by enhancing our ability to detect, monitor, and manage resistant infections. By harnessing the power of technology, we can more effectively address AMR and safeguard the efficacy of existing treatments and ensure a healthier future for all. I'd like to introduce the esteemed panel for this panel discussion. Joining us on stage, Professor Dr. Ketan Mehta, consulting physician, cardiopulmonologist, and diabetologist, Health Harmony. Dr. Alok Modi, Medical Director, Dr. Modi's Kevalia Hospital. Professor Dr. S.V. Kulkarni, Senior Consultant Physician, Professor of Medicine, MGM Institute of Healthcare, Navi Mumbai. Dr. Jennifer Benjamin, Regional Customer Success Manager for Walters Kluwer India. Dr. Ashok Mehta, Senior Consultant Cancer Surgeon, Nanavati Max Super Specialty Hospital. Dr. Vasant Nagvekar, Infectious Disease Consultant, Sir H. N. Reliance Foundation Hospital and Leelavati Hospital. The moderator for the session is Dr. Shivkumar S. Utture, Vice President for the Indian Medical Council. Over to you, Dr. Utture.
Yeah, no problem, no problem.
Yeah, good afternoon, everybody. I think this session basically will be in a realm of something which is going to be the future as far as medicine is concerned, though we are going to talk about a very niche aspect of AI in AMR. So basically, antimicrobial resistance. I think this is going to be the next big pandemic after COVID in the future, and which will hit not only the patients but even the medical fraternity in the future. It's going to be a global public health and development threats are there, and it is estimated that AMR will be directly responsible for 1.27 million global deaths and will contribute to 4.95 million deaths in the next decade. So antimicrobial resistance is anticipated to cause around 10 million deaths per year by 2050. This is the huge numbers that we are going to see in the future. And the economic impact of AMR is expected to approach $100 billion during the same period. And what causes this AMR? Basically, it is the misuse and overuse of antimicrobials in humans, in animals, and in plants. And the main drivers in the development of drug resistance is because of these three aspects that we see in future. So using antibiotics when not necessary, overprescription by healthcare providers, and incomplete course of treatment can all contribute to this resistance that is going to be there. So what AI can do as far as mitigating this problem is concerned? So AI's application in healthcare might be unlimited, reducing the time it takes to discover new antimicrobials. You are aware that in the last decade, there are hardly any new antimicrobials which have come up out in the market. Not only that, it will be improving the diagnostic and treatment accuracy and lowering the expenses at the same time. So considering, could artificial intelligence be the future as far as antibiotic resistance prevention is concerned? Yes, it can be. Considering that between 2014 and 19, only 14 new antibiotics were developed and approved. Hence, the implementation of AI and the AI algorithms could accelerate the discovery of new antibiotics also.
So additionally, just to give you an example, today what we are doing is antibiotic susceptibility testing we are doing whenever we want to find the resistance. Of course, this is not completely efficient. It takes a lot of time. So what we are going to depend on in the future is the whole genome sequencing for antimicrobial susceptibility testing. That is what we in short call WSG AST. But for this, it requires a lot of data. And this is what AI will be giving us in the future. And there are estimates and there are papers also which have come out where they have said that the diagnosis of antimicrobial resistance or susceptibility can be done within 3 hours. So imagine today what we are facing, it takes 24 hours and more. So what we do is we start with a antibiotic empirically, a broad spectrum, because we do not know which antibiotic to hit that microbials. But this, if it is reduced to less than 3 hours, it's going to help. And we have a very collection of esteemed speakers over here who are both clinicians and AI experts and who will be taking us in this next 1 hour through this whole aspect of AI and AMR. So we have Dr. Alok Modi, who is the medical director of Modi's Kevalya Hospital. He specializes in critical care and consulting with a focus on diabetes mellitus and febrile illnesses. After finishing his MD, he has pursued critical care training in US. He is affiliated to all the top corporate hospitals in Thane region. That is where he is basically practicing. And his expertise includes managing infectious diseases such as malaria, dengue, pneumonia, in vaccinations, diabetes, clinical cardiology, and critical care. He is a fellow of American College of Physicians, fellow of the Indian Society of Hypertension, fellow of the Indian Association of Clinical Medicine, co-editor of Digital Technology in Clinical Medicine 2023, head of AI Cell of American College of Physicians India chapter, and I think the latest acquisition, he is certified by the American Board of Artificial Intelligence in their advanced course. So he is both a clinician and an AI expert. Then we have Professor Ketan Mehta, consulting physician, cardiopulmonologist, and diabetologist at Health Harmony, and he is practicing medicine since 1995. He is attached to Asian Heart Institute, Suchak Hospital and Research Center, Critical Care Asia Hospital, Nama Healthcare, Nanavati Hospital, SL Raheja Hospital, and Seven Hills Hospital. And he has been on the teaching facility of the KGS Somaya Medical College and Hospital as a postgraduate teacher, delivered more than 1,000 lectures in the past 3 decades, and has got a lot of publications in many of the books. And he has been the principal investigator in several clinical trials. He has been recognized for his contribution to medical education, research, and having received various orations at numerous forums. Welcome, Dr. Ketan. Then we have Dr. Vasant Nagvekar, a big name in infectious diseases. He is the director of infectious diseases at the HN Reliance Hospital, and he is practicing at Lilavati also. Authored more than 23 national and 5 international papers and contributed chapters to 3 international and 16 national books. He is a fellow of the Infectious Disease Society of America and serves as the scientific committee at NIV Pune and advisory committee for the infectious diseases at MUHS. He is a general secretary of Clinical Infectious Disease Society India and a teacher of MUHS ID fellowship and at Lilavati Hospital. So basically, he works in an area which is, I think, maximally hit as far as microbes are concerned. And I think he must be very much bothered of how to tackle in future these microbes. So welcome, Dr. Nagvekar. Then we have Dr. Jennifer Benjamin, Customer Success Manager, Walters Kluwer. Basically, she is the one who will be talking to you as far as the technical aspect is concerned of how to use AI, and especially with the launch of the up-to-date and up-to-date legacy drug. I myself don't know the details, so I'll also be learning from her today of how it will change the life of clinicians in the future whenever they take up these two, aspects. And she basically cherishes her role as a healthcare technology, and it transcends just mere promotion, but fostering relationships and ensuring every member of the care team can perform to the best of their ability. So, welcome, Dr. Benjamin, Jennifer, madam. And then we have Professor Kulkarni, S.V. Kulkarni, again, a very, very big name as far as AI is concerned. He's a senior consultant, physician, and professor of medicine. Welcome, Dr. Ashok Mehta, sir. He is consultant physician and professor of medicine at MGM Healthcare, Navi Mumbai, and has 42 years of experience with significant contributions to the field of medicine, particularly in AI, digital medical technology, and critical care. So basically, he has got multiple fellowships, and he is a founder member of the API Konkan chapter, Raigarh Medical Association, and president of the API Konkan chapter and founder president of API Navi Mumbai. He has been a faculty member at GMC Miraj, DYPMC Nerul, ITM, and MGM Institute, and visiting faculty grand rounds in USA medical colleges. Conducted more than 250 workshops and 500 faculty appearances worldwide. Authored a lot of chapters in various books and principal investigator for various clinical courses. So, welcome, Dr. Professor Kulkarni. And of course, we have a doyen of the oncology segment who has also been my teacher, Dr. Ashok Mehta, sir, senior consultant, cancer surgeon, Nanavati Max Super Specialty Hospital. So, senior consultant, cancer surgeon at Nanavati Hospital with that impressive 58 years of experience in surgical oncology, offering expert diagnosis and treatment for all types of cancer. He holds an MBBS MS degree and focuses completely on surgical oncology. He is known for his comprehensive approach to oncology, which includes the prevention, diagnosis, treatment of various cancers, as well as conditions like iron deficiency anemia, sickle cell anemia, hemophilia, etc., etc. And of course, he is going to talk to us as far as how AI can help as far as microbial resistance is concerned in immunocompromised patients like cancer patients. So welcome, Dr. Ashok Mehta, sir. I know you're very, very busy. You have taken out time to come over here. So basically this session, what we will do is there will be an opening statement made by all the panelists in the beginning, and which would be about 3 to 4 minutes each. And then of course we will take up the question answer session after that. So may I call Dr. Alok Modi to initiate the talk as far as opening statement is concerned. Dr. Modi.
Hello, am I audible? Okay, a very warm good afternoon to everybody. At the outset, I would like to thank Uttari sir, whom I very fondly call as the Amitabh Bachchan of medical industry. He's been the past president of Maharashtra Medical Council, and he's a very well-renowned surgeon and a very well-renowned personality who doesn't need an introduction. And thank you, sir, for such a wonderful introduction for all of us. So now when we're talking of artificial intelligence, now you must be hearing of AI coming in everywhere, and AI is coming in each aspect of life. So I'll just give a small intro of AI. What exactly is AI? Since we give a lot of talks and people are confused about AI, and especially the medical professionals are worried if AI is so intelligent, will it replace doctors? The thing is, I don't call AI as artificial intelligence. I call it additive intelligence or augmented intelligence because it adds to your value. And the main thing is, if you look at the way medical science works, we practice evidence-based medicine. So if we are writing a particular antibiotic for an infection condition, or we are writing a particular therapy for a particular clinical scenario, it has to be supported by research. You just can't prescribe something which you think is right for a patient because that is not appropriate. And that research emanates by doing a lot of trials. And through that, biostatistics happen. And biostatistics tell you that there is evidence to show that this medicine is making a difference to the outcome of the disease. And once that is conclusively proved through statistics, it is applied. Now, you take it one step ahead. What machine learning or what artificial intelligence does it can make predictions beyond biostatistics. Now, for example, for today's scenario, if you're giving a particular antibiotic for a particular scenario, biostatistics will tell you in the last 5 decades, this antibiotic has shown minimum resistance, and this has shown so much of killing rate of so and so bacteria. But whether it will develop resistance in the current ethnical situation, cultural situation, social situation, the antibiotic prescribing trend of the doctors in the area, which influence antibiotic resistance, the number of OTC, off-the-counter prescription, which can create more antibiotic resistance, and the bacteria coming from the agricultural fleet, from the farm stock, that is something we don't consider. How much resistance they are contributing, what kind of ligands are moving. So many variables are very difficult to collate and predict what could happen as a resistance scenario 6 months from now. So that is something that machine learning can do. It can predict through its models, which biostatistics cannot do. So I'll stop here. I won't take a lot of time. But what AI can do is create prediction models which are highly accurate and can beat biostatistics and tell you how the medical science will project from now. So when you apply this kind of logic to a real life situation and an ICU in a hospital, it can create wonders. And I'll wait for the other panelists to tell you how it works in their real life settings.
Yeah, thank you, Alok. Professor Kulkarni, can you just put in your initial thoughts as far as AI in AMR?
Thank you, Dr. Uttare. Thank you, Dr. Alok, for setting up the stage. Friends, antimicrobial resistance is a problem of all of us, not right from the individual place to the whole country, and especially in the lower middle class income group where you get a minor infection, maybe a viral, but if you use the antibiotic, say starting from azithromycin, then the things go on increasing, and with the n number of antibiotics used, when you stop at the antibiotic Z, you develop an infection which is not ready to be tackled by any of the antibiotic which has been given to you. This is exactly antimicrobial resistance. So how the AI is going to come into the way? If I want to develop a drug, I may have to analyze lakh or 10 lakhs of compounds and then find out which way it is going to be effective. And how it is going to be effective? By the sensitivity of the drug. So there are two terminologies. One is called as a generative adversarial network, called as a GAN, and variational autoencoders. These are the two technologies in which I can analyze a molecule. I can see how it fares in the body. That is called as pharmacokinetics and pharmacodynamics. What are the toxicities and what are the advantages? The advantages are the spectrum of antibiotic. Means sometimes it acts on a spectrum called as a gram positive. Sometimes the drug acts on a spectrum called as gram negative. And sometimes there are organisms which are called as anaerobics. So which chemical is going to act on which particular antibiotic and bacterial spectrum, that has been decided by AI. And there is again a situation called as a predictive modeling and computational simulation. In silico simulation. In silico simulation, it will help you understanding the future problems related to the drugs, and AI, machine learning, big data, even unstructured data is going to help all of us in coming up with this problem of antimicrobial resistance, which is going to be a big issue. Almost lakhs of people are dying every year because of infections which are resistant to the routine antimicrobials. This is from my side. Thank you, Dr. Uttara.
Thank you, Professor Kulkarni. Now, Dr. Nagwekar, I think being an infectious specialist, I think day in, day out, he must be worried of how to treat a patient till he gets the sensitivity report. And is he doing the correct treatment or not? So I think his words and his thoughts on this would definitely, open up a new chapter as far as AI and AMR is concerned. So, Dr. Nagwekar.
Thanks, Dr. Uttare, and thanks. Good afternoon, everybody, and thanks for CII for giving me this opportunity. I think Dr. Kulkarni has already said about the misuse of the antibiotics which are happening across, I would say, not only India, across the world, because of not getting a correct diagnosis not only diagnose this correct organism, what we are dealing with, if it's a sepsis shock, and not knowing what is the pattern of resistance. So not knowing, because these organisms, we tend to shoot the patients with left and right with multiple antibiotics. So AI, if is able to identify whether it's a viral, whether it's a fungal or a bacterial disease, along with the pattern of resistance, we will be able to narrow down our spectrum of antibiotic usage and can hit the patient correctly with appropriate antibiotics. I think that is the future of AI. I always feel that all doctors should embrace AI, and you have to keep updating yourself. If AI is not there to replace humans, as Alok said, but if humans do not embrace AIs, AI will replace humans. So you have to go according to the technology. And also for simple, I'll tell you simple example which is happening in the community now. The flavor of the season is chikungunya, which is going on in Mumbai. If I would say 5 to 10 years back, we did not have proper identifications for your dengue, your malaria, or leptospirosis or chikungunya. Now, because of the PCR-based techniques, which are machine learnings and integrated systems, we are able to diagnose this in first 48 hours, and you can restrict the usage of antibiotics. Just because you know that it's a viral infection, simple respiratory biofires, the COVID RT-PCR, so many things which are revolutionized, which was not there 15, 20 years back, has been a game changer. And if you diagnose it early, you can restrict your unnecessary antibiotic or need not use any antibiotics at all for all these viral infections, which we are dealing community acquired infections in and out daily basis. So definitely it has changed the paradigm shift from. But if you do not update yourself, or if you do not embrace this, you're going to get wiped out and you're going to be far behind us. So it's very important that as you're progressing in your career, you have to embrace AI. Otherwise, AI is going to embrace you. That's very important. Second thing is, I think microbiology lab and updating the diagnostics. I think futuristics of artificial intelligence is diagnostics. The whole therapy of your treatment for a patient is going to be diagnosing sepsis, septic shock, whether this patient is going to ahead with septic shock, is he going to land up with multi-organ failure, and whether what is the microbiological data. So I think microbiology and diagnostics is the future of artificial intelligence, and we are really completely relying on that to help us not only to give a correct treatment for the patient, but also to reduce the morbidity and mortality. That's all from my side now.
Yeah, I think Dr. Nagavekar, you said 48 hours today it takes you to come to some diagnosis of what basically is that infection. And as I already said, if that can be done within 3 hours, I think it will go a long way for starting a treatment, or at least not starting a wrong treatment for that patient. And then we have to talk on that Dr. Jennifer Benjamin. Basically, she's from Wolters Kluwer, clinician who has joined this technological platform. And they have got a platform where definitely they can help us out, where they use AI in the clinical diagnosis, microbiology, etc. And she'll just give us an overview of what that can do. Over to you, Dr. Jennifer.
Thank you. So I think I'll just quickly get into it. So Wolters Kluwer, as a platform, we offer different software solutions, and given that AMR is obviously a problem, not just from yesterday, it's continuing. So it's a platform where we offer products through clinical to improve clinical efficiency as well. So that's where we offer UpToDate and UpToDate Lexi drug. So what we do is these are clinical decision support tools for physicians at the point of care. And just like different physicians over here, they have been telling when the residents or doctors in training or anybody in confusion, they are shooting patients with a lot of antibiotics. Is it the right indication? Is it the right place to give? Is it the right duration or the dosage? So these kind of decision questions, which a physician can take, obviously those are being supported by UpToDate, and infectious diseases as a medical specialty has been focused on specifically through UpToDate among the other 25 medical specialties which is available. Now, on the other hand, if why we do this, obviously to improve patient outcomes and keeping in mind, obviously the tried and tested antibiotic stewardship program, we follow the same thing and our expert editors, we have over 7,500 expert editors. These are again physicians. They are all coming in from different specialties, giving their field, giving their share of, expertise, even along with the evidence which is available right now. So among all of these, so we have diagnosis, we have dosage recommendation, which is the right drug in which indication, not only obviously the pharmaceutical, indication, which is why the drug might have been manufactured, but even in cases, even in off-labeled indications, where is it recommended and what is the right duration? Now, also de-escalation. So how to transition between the antibiotics if a patient has to be discharged tomorrow? How do you transition from, de-escalate from an IV to an oral? What is the right dosage? What is the right duration? All these kind of advices which is available at your fingertips at any point of time. Now, again, when evidence is being released, literally around millions of journals and millions of references and everything is being released every year, how do these physicians keep up with such an information and how to make sure that what they're reading is obviously, valid in their field of specialization? This is where, again, our tools would help them. We are editors. They are obviously going through these information, validating it with graded recommendation, which obviously the WHO is following. And along with this information, so the physicians just have to log into their systems, look at what they are, and to just type in what their patient is currently exhibiting, what symptoms they are probably going through. If something is not working, if Dr. Vasant has prescribed something and it is not working for his patient, he has to just go to the next best solution for his patient, which is obviously available in our monographs as well. So I think I can move further. I mean, we can show for more about it. We are obviously available outside in a booth out, and we are obviously available to showcase it to you how it works in detail. So since we are obviously a lot of us, we want to move ahead. So I'll just give Dr. Utreya.
Yeah, thank you, Jennifer. I think technologists is what we require to, hand holding we require as far as, tackling not only in AMR, but in future in every aspect of clinical practice. Then we have Professor Ketan, who is attached to a lot of corporate hospitals. And he has also, as I said, he has served as a principal investigator for various clinical trials. So he will just give us a broad outlook as far as the clinical aspect of using AI in AMR. Over to you, Professor.
Good afternoon, everybody. At the onset, I'd like to thank CII, Dr. Utreya sir, and your friend Alok for inviting me here. Now, as I said by all my other co-panelists, the need of AI in tackling or fighting against CMI is so much important. And you may, from different field, maybe as a clinician, maybe as a corporate managers or any different field, you might think, what is the need to know about it? Now, it reminds me of a beautiful quote from Albert Hoffman, who states that illiterate of the 21st century are not those who cannot read or write, but those who cannot learn, unlearn, and relearn. And we are all here to learn, relearn, and unlearn certain old things from each one of us. Now, talking about antimicrobial resistance, I would add few things. India is really heading as a capital of highest antimicrobial resistance in the world. The reasons have been discussed by all the other panelists. The use, misuse, and abuse of antibiotics have really led to these conditions to the extent that first time in 2017, Ministry of Health and Family Welfare, Government of India took this initiative, and there was a talk show called Man Ki Baat. Our beloved Prime Minister Narendra Modi came in 2017, and that was the first time any Prime Minister talked about antimicrobial resistance concept. And for the first time, there was a National Action Committee which was formed to tackle this antimicrobial resistance. The whole target was given to ICMR to keep a surveillance on that. And what was found in that India is consuming on average 10.7 units of antibiotics per day per thousand population. Imagine the usage of antibiotics which is happening. And we person are not capable to manage or tackle this antimicrobial resistance unless we know take help of AI. Now, AI, when we talk about, which is rightly said by Manoj, it is definitely not just artificial, but it is at the data and it is going to evaluate. So where it will help us in the clinical setting, it is going to conglomerate the host factor, the pathogen, the birth factor, and the environment factor. So the labs will give idea about what the patient factors are. So that is the host factor. The genome early detection from the microbes, which will be helped, of course, by the AI. And what we have the electronic health record. If we combine all three with the help of AI, you will have not only early detection of the birth, but you know the right antibiotic to use as quickly. Right now, we are already having a PCR analysis where we can have reports within 12 hours. But then now with this newer technology, we will be able to have the as like it will be more or less in real time. And what Dr. Jennifer was mentioning, if we start having the advantage of this, we would definitely be able to take care of antimicrobial resistance in a much better way. And that will be not only reducing the burden of the healthcare system, but also the financial burden, because that can have a large impact also. So it's multifactorial importance. And what we are seeing, Dr. Uttari sir mentioned about how new antibiotics are available. We have a limited stock. So we cannot use all our resources at one go. We need to use them wisely when used.
Yeah, thank you, Ketan. And now we come to a person, the doyen of oncosurgery. I think 5 decades he has been in oncosurgery, treating patients with massive surgeries and at the same time who are immunocompromised. So day in, day out, he must be the one thing that scares any oncosurgeon is after doing a good job on that patient, getting rid of his malignancy, he lands up with infection, which is very difficult to treat because his basic immunocompromised status, which is there. So we have our teacher, Dr. Ashok Mehta sir, who will be just giving his views as far as what is AMR in oncosurgery and how AI will help him. Over to you, sir. Thank you, sir. And incidentally, at 86, he is still operating. So he phoned me up. He phoned me up saying that Utture, I'm a little bit delayed because I just finished my surgery, but I'm on the way and I'll definitely come. So thank you, sir, for having. It's a pleasure having you over here. So now we come to a very interesting session as far as I am concerned, because I will be picking their brains by asking them very pointed questions as far as the practical aspects of this AI and AMR is concerned. Dr. Ketan, Professor Ketan, basically, how is AI currently being used to detect and predict antimicrobial resistance patterns?
So, AI right now, whatever the usage which is there is about strength, strength bacteria. That is what we call as CR test, by which it would detect very early. Now, there is a limitation. So, if you see the usage of culture, when you say any culture, be it sputum culture, lab culture, where human organisms are allowed to grow, and then you study the antibiotic resistance by nothing less than 3 to 5 days. Versus by this technique, you are able to get the results as early as 12 months. Only drawback is you don't know the antibiotics will be back there. Now, if we start using, there are different AI-based applications out there by which, if you combine this genome study with EHR, electronic health record of particular hospital setup, it will able to give us not only the organism which we are dealing with, but what would be the most likely drug susceptibility in this factor or this patient, and that would definitely avoid unnecessary usage of broad spectrum antibiotics or multiple antibiotics. Because today, what is happening is, somebody comes with, for example, sepsis with bacterial bacteria, he's being bombarded with all sorts of flu and everything possible burns in that. And which is not reality. You are specifically looking into it. And as a result of which, what the issues are that there are bugs which might have analysis and resistance for spoilers, which is on the rise. And now we have got issues like resistant inflammation or skin inflammation pneumonia, which is also in the rising trend, which we have seen from tertiary center percentage almost 50%. So such aspects, yeah, would have tremendous.
Yeah. Thank you. Dr. Nagavekar, you just touched upon briefly of different type of infections like bacterial, viral, fungal, and the maximum abuse of antibiotics is especially in viral diseases where it is not absolute, it has no role to play. So how can AI differentiate between these bacterial, viral, fungal causes in the initial phases itself so that you can use a proper antibiotic or not use antibiotic so that you can reduce inappropriate antibiotic use and prevent the acceleration of this antimicrobial resistance?
Thank you, Dr. Uttare. So I think to a certain extent, in my previous statement, already I said that diagnosing the common viral infection to a certain extent has been quite successful because of the various rapid tests which are available now. Could be partly because of the artificial intelligence, and we are able to get the results of these PCR based techniques within 2 to 4 hours time. So that has been a major game changer in last 3 to 5 years time, where we are able to diagnose some of these common viral infections. For example, the topical infections which we are there, if you diagnose it, possibly you can restrict your usage of antibiotics. Secondly, the respiratory biofires which are available, that anybody coming with a URT or respiratory tract. So again, diagnosing this also gives you an answer within 2 to 3 hours. So that has, to a certain extent, definitely helped us. And when we get to patients with a very high fever, and first is we screen for all this, and if it is positive, say for dengue or chikungunya, we definitely restrict antibiotics and we do not use. But the major concern is when patients come with a sepsis and septic shock, to identify whether this septic shock is because of a fungal infection like candidiasis, or whether it is a viremic shock, or whether it is a bacterial shock. Most common reason usually is either fungal or bacterial, and I would say more than 95% it is usually bacterial infections, which is the major reason for the sepsis and septic shock. In this condition, I think AI would be able to still here also we have revolutionized again in next last 5 years. If the blood culture comes, whatever blood cultures you send, if it comes positive, we are able to identify the organism again within 2 hours, what is the organism and what is the pattern of resistance. But this itself takes around 12 to 24 hours. What we require is point of care, that is we require to know this time frame of 12 to 24 hours has to be shortened to 2 to 3 hours. I know there are some diagnostics which are coming into the market or already there into the market where the time frame of 12 to 24 hours has come down to 3 to 4 hours, and they have been able to identify these organisms, also giving a pattern of resistance. So it's very important that we require more better diagnostics to early diagnose whether it's a viral or bacterial or fungal, and we don't require to wait for 12 to 24 hours. By then already the damage of we are forced to, because if somebody is coming to shock, we require to know what is the likely organism and what should be the most appropriate therapy. If this time frame of 12 to 24 hours is shortened to 2 hours, I think this would be a major game changer. And I think here your artificial intelligence, whatever the large databases what we feed into the system, it will be able to identify the microbial etiology, it will be able to identify the pattern of resistance, but you require large databases across India or across the world. What is happening in the Western world is not applicable to India. That is first thing we have to remember. We cannot utilize what is the Western data to India. India has got its own problem of resistance, whereas the Western world has got its own pattern of resistance. We require to database our antimicrobial stewardship or antimicrobial resistance to the organisms which are prevalent in India. We are having, for example, we are having a major gram negative resistance, whereas the Western world is dealing with more of gram positive resistance. So there is a huge change. There, the gram negatives, what they're dealing with the Western world to us, to for all you, is more sensitive, whereas what we are dealing with is hardly any antibiotics left, as all of us have mentioned just now. So we require to have our database pertain to India, what is going to be the pattern of resistance, and identifying these would definitely help in reducing the morbidity and mortality. That's what from my side.
Yeah, thank you. We are talking about a huge database which has to be first created for AI to be successful. So, Dr. Alok Modi, can AI be integrated with existing surveillance systems to track and manage AMR more effectively?
Yes, that's where actually AI comes in, and if you look at it, there is no other system which can actually do that. Now, how does thing work? So, see, different clinicians and different hospitals have different EHSs. They have different systems running. It's very difficult for them to talk to each other. So, it's like when you're visiting a foreign country, it's very difficult for you to understand what the dialect is and how do you communicate with the gentleman in the other country. So that's a real life problem. Second problem that we're talking, I'm talking of actual applications which are running in the US and one or two hospitals like Apollo in India. So what's happening here is, so one hospital is having a system and it's got a list of collection of resistance patterns, the antibiotic resistance pattern that you have seen in the last 10 years in that hospital. Now, when you correlate all that, a patient moves from one hospital to the other, takes a transfer from one ICU to the other, then the whole ball game changes, and then clinicians really don't know what to do because here you're getting exposed to a different set of nosocomial infections. Now, we're not spoken about nosocomial infection. That's an entirely different field altogether, and we know how difficult and crucifying that is for the patient and his family. So if you can correlate the patterns across, you get what Dr. Narvika just spoke about is big data. Now that big data, hitting it with the background of the information that you have, the repertoire of information you have, which is called your large language models. So hitting it with the LLM and making logical analysis through statistical tools becomes very difficult. And the only capability that something can do that is artificial intelligence. Now the stop doesn't, I mean the car doesn't stop here. So let's imagine we have a patient admitted under Dr. Vasan Nagvekar in Lilavati Hospital with a suspected pneumonia. So before you send the sample, before you get the antibiotic resistance, before you decide the antibiotic, which would be empiric as per the current guidelines, which you would start as for evidence-based medicine. Now, what AI can do is can pick up from the data that it already has by hitting the LLM that this person hails from this area. This has been the pattern in this village. This is a genetic type of the organism which has been found in this village. And this is the prescription pattern of the general practitioners in the area. This is the prescription pattern of Dr. Nagwekar in this hospital. This is the prescription pattern of other ID specialists in this area. And it is possible that within 3 years, he will go into septic shock and land in the ICU. And this is a reality. And this is something only AI can do. Again, I'm emphasizing prediction is a capability of AI which no other can do. So integrating all this information from different scenarios and making a logical and an accurate prediction, which has been shown to be accurate, is what AI is going to do. And that will actually decrease mortality in the future.
Yeah, thank you. So we are talking about situations where basically in corporate hospitals and ICUs. So Dr. Kulkarni will come back down a little bit. Can AI really help in designing better stewardship programs for antimicrobial use in hospitals and clinics? And especially, can it address the prescription of antibiotics in a OPD settings?
Yes. This is a very pertinent question and a common scenario. We have got something called as a CDSS, Computer Decision Making Support System. Suppose I get a patient of fever for 5 days and I know the pattern, I know the investigation. If there is an inclination that this person is likely to have a viral fever, my electronic health record system will not allow the entry of antibiotic into my prescription. I can see so many young people in this audience, and they must be very much interested in knowing the EHR and different kind of the epidemiological data what Dr. Alok was talking. And the way in which an antibiotic steward should work in any hospital, or it may be in a single person clinic. The stewardship is making an awareness about when to use or when not to use the antibiotic. And if I use some antibiotic like say azithromycin only for upper respiratory infections, amoxicillin for only for lower respiratory, and norfloxacin only for urinary tract infection, it will give me a pattern of how I use, my other colleagues use, and how the hospital in general uses. Dr. Nagwekar must be aware that every hospital has to take the ICU swabs to know what is the resistant population of the organisms in that. So it is a very big role of CDSS as well as antibiotic stewardship in making the right dose, the right drug, and to the right person to avoid antimicrobial resistance. Thank you.
Now we come to Dr. Jennifer, basically, who the practical aspects of using AI in any setup. Madam, how do you aid in hospital settings to combat AMR, and who can use your up-to-date Lexi drug and its implementation?
So I think Dr. Kulkarni already touched upon this. His institution has already subscribed to our CDS solution up to date. So keeping in mind, again, the same antibiotic stewardship program, we have created our content for physicians at the point of care. So now again, not only physicians, patients are obviously being treated. They are being dispensed medicines by pharmacists. They are being administered by nurses, and obviously they are also the gatekeepers of these medications. So they need to have the same standardized information which a physician might be getting through the different references and articles which they might be reading through. So what we are trying to do with these two solutions is to make sure that the content is harmonized. So UpToDate LexiDrug, it's our online drug referential solution, and UpToDate is your go-to CDSS solution. Now, when you have the information harmonized between the two, no matter who is using where, they are able to get the same information, and it is completely evidence-based. Right. So now, how can we do this? Obviously, it is an institution, it's an enterprise level of subscription where the institution, once they have taken it, they can obviously access the information anytime. And now after that, they can use these informations to obviously aid in setting protocols, aid in setting their antibiotic stewardship. Now, like how Dr. Nagvega said, there is obviously how our Indian demographic might not be responding to the same, information which obviously the US or any Western side of research might have showcased. So to have your own protocols, you have to refer so much of databases, so much of data. So where can you get the go-to information which has already been validated by a lot of editors, that you can come to our solutions, look through them, and obviously use that. Now, another set of people we are forgetting is obviously patients. If you try to send them back, if you have, obviously you are the experts and you're telling them, hey, this is only viral infection, and you do not need, obviously you do not need a medication. You can just go home, take care of yourself. Obviously they are not happy with it, they might go to the next person who might give them some kind of a medication, right? So I've seen this happen. I've seen pharmacists just giving them for the sake of it, just an antibiotic, just to get them out of the way. So how do you always have, a set of change, a culture in patients as well? So we have aided patient education leaflets too, just to help them understand what they are going through and what is the right way of getting themselves treated. So we have added those as well. So having all of these consideration, patients along with all of the care teams, we wanted to help them, give the right best of information at their fingertips anywhere.
Yeah, thank you, ma'am. Dr. Ashok Mehta, sir, how can is AI helping you in optimizing antibiotic use in cancer patients, especially those who are on chemotherapy because of their immunosuppressant status? And how can AI-driven data on resistant patterns and infection risks influence the development of new cancer therapies, particularly immunotherapies, which can impact infection susceptibility? Thank you, sir. I think there are a lot of questions still left, which basically I would have learned a lot from these experts, but already I have been given the warning that the time's up. So just while closing, let me give one minute to all the panelists. What take-home messages you would like to take our audience who is sitting over here? Dr. Kulkarni, sir.
Antimicrobial resistance is a global issue, and we should use artificial intelligence right from evaluating our basic individual prescriptions to the hospital data and to the advanced models, which are large language models, so that we come out with a good database of our own country, our own community, give right antibiotic and avoid antibiotic abuse.
Dr. Alok.
I think all the points are very beautifully covered already. I will go on the other side. I'll tell you a little about what's being talked about the ethics and concerns of AI. So I'll elevate the board on that side today. And just invite you guys to read our paper, which is in the press currently, where I've written about that. Couple of things, people who are using ChatGPT and AI very regularly should know that all the LLMs that you're using in AI today are not based on medical database. It's a general LLM taken from Microsoft Azure. So the hits that you're getting on AI is not always right. And that's called in technical jargon as hallucination. So AI does a lot of hallucination. It has been shown by a couple of studies to hallucinate as much as 27% of the time. And a lot depends on the prompt that you give. So people who are trained in prompt engineering are drawing salaries of 15 lakhs today per month. industries are employing them. So if you get the right prompt, you get the right answer. Otherwise, you might change the outcome of the patient because of a wrong outcome. So at the end of the day, I just say one thing that we always insist on any AI talk is it should be a human in the loop and not AI in the loop. So at the end of the day, you might find that this antibiotic won't work, but your experience tells you that this antibiotic has worked for the last 10 days. So forget AI and give it last 10 years. So somewhere you need to know that your clinical acumen is paramount. You're the doctor. You're treating the patient, not the report and not the EHR. So just that word, important word is there. Your clinical acumen is very important. Don't get carried away. But these tools are very important to tackle the nagging problem which is going to face us tomorrow. Thank you.
Yeah, thank you, Alok. I think what you have said is a very important aspect. And that is what we are finding, that don't treat the investigation, treat the patient. That is the most important aspect. Dr. Nagwekar, sir.
Yeah, so AI is there to lot of times to diagnose sepsis, septic shock. But what is going to be the major game changer in the clinical outcome of the patients is the diagnostics. If you have the correct diagnostics, correct organism, correct pattern of resistance, you can hit it correctly and change the tables completely. So I think the futuristics lie in the diagnostics. I think AI in diagnostics is the future for the clinical outcome of the patients.
Dr. Jennifer, madam.
I think I concur with Dr. Alok. With the few prompts, very clever prompts, if you can convince ChatGPT that 2 plus 2 is 5, maybe those are not the right resources at this point of time, but I'm sure along the way, we have to invest, we have to make sure that AI is our next resource to leverage upon, because obviously we as humans, we cannot look at the mass data to get through, information, and AMR is probably a issue which is not going to go away anytime soon unless we have taken the responsibility as physicians, as the care members, to ensure that our patients are rightfully treated. And keeping that in mind, Walters Kluwer, we have also, we are working on a clinical generative AI. I think Dr. Vasant had asked me, isn't up to date already too vast? So when we are trying to give information as comprehensive as possible, even that is vast for physicians at now at present time. So what we are trying to do is a generative AI using the rightful information, which is evidence-based medicine, through the different references, articles which are available. And this is again through up to date. So as responsible as possible, Walters Kluwer keeping in mind, we are trying to leverage upon AI and making sure that it is a responsible act, keeping in mind, obviously it's a healthcare system. We cannot put our patients at risk. So yeah.
Thank you. Professor Ketan, sir.
So AI, which is going to definitely have another future. And what we need to do is, it is not just AI. What we have compared to AMR, antimicrobial resistance, which not only of the government and the sector, not only just medical professional, pharmacists, it will be at each every individual level. The government tends to go across the counter or take the medications or self-medications for a fever. We have to ensure that the presence of fever doesn't mean there is an absence of antibiotic levels in the blood. So that is the most important message we want to get. Thank you.
Dr. Ashok Mehta, sir, your closing remarks. Thank you, sir. So, in short, to sum up the whole thing, AI is extensively used in other professions and other, you say the banking aspect, the marketing aspect, but somehow the healthcare has been very slow to get off that block. And it's high time that we also in healthcare embrace artificial intelligence to help us and augment our judgment as far as how to manage the patient for the future. But for that, as spoken by our panelists, what we require is the Indian data. We cannot rely on the Western data as far as our patients are concerned. And so the first aspect that is going to be is the collection and the uploading of this data, so that tomorrow this huge data which is there, and there is a lot of clinical data which in India we are always somehow or the other we are not coming forward with this data. If we can do that, definitely it's not only in AMR but in all clinical aspects of managing our patients. Definitely AI can help us in better management as far as and give us much more satisfaction in treating our patients in the future. So again, I thank CII. I can see Parag looking at me off and on. Time's up. Parag, I understand that, but we started late, but I've kept up to that 1 hour that you had given me. And thank you very much, all the panelists. They have all been extremely busy, but they have given us a good outlook as far as AI is concerned. Thank you.
Thank you. Thank you, Dr. Uttare and our esteemed panel of speakers. May I request you to come forward for a group photo? Yep.
If I may break the protocol, I would just like to say one line. We would like to thank the panelists on behalf of everybody. Like to thank Utture sir for doing such a wonderful MOC and conducting the program in a wonderful manner.
Dr. Parag Rindani is also going to join this group photo. As a token of our appreciation, on behalf of CII, requesting Dr. Rindani to hand over thank you letters to our esteemed panel and to our moderator. A big round of applause, please, as he hands over the thank you letters. Thank you, Dr. Rindani. We now break for networking lunch. Request you to please gather in the hall back again by 2:20. We will start with the next session at 2:30 sharp. We're running a little behind time, so request everyone to please adhere to the time. The next session will be an interesting one on creating a green hospital for future sustainability. Thank you. Foundation, Mr. Shivam Jumani, manager of the Blended Finance Company, and the moderator for this session, Dr. Shilpa Tatake, Group Chief Operating Officer for Jupiter Hospital in Thane. With a round of applause, can we welcome everyone on stage? Over to you, Dr. Shilpa.
Hello, am I audible? Good afternoon, everybody. And post-lunch session, so we will try not to make it superphoric and rather interesting for each one of us. I have got a wonderful panel of all erudite experts from the industry and especially those who have done tons of work for green healthcare. So it would be my privilege to have interaction with all of them. And without wasting more time, let me come back to the question and the main topic of the session, net zero green hospitals. So with geopolitical tensions rising across, more importantly, nature is also posing a risk for all of us. With floods, with droughts, and all unpredictable phenomenon occurring around, healthcare requires to get geared up for sustainability and green initiatives. All the panelists here have already invested their lifetime in working on that. I will start my question with Dr. Vivek Desai. Sir has a rich experience in terms of planning and designing healthcare projects for many years now. Now, based on your experience, your journey in the healthcare, what you feel are the key considerations you have to take into account while planning the green hospitals?
Okay. Thank you, Dr. Shilpa. If I trace the journey of hospital planning, designing, I think when we began way back 1996, 97, the concept was not existing, right? People were not aware of what it was. But slowly, I mean, probably last decade or so, the people have realized, that this is something that we need to do, and whatever you save adds to your bottom line straight away. The problem still is that people do not take sustainability as something which can really add to their profits, because they always think this is a capex item, all right, which I think we need to change that mindset, of people, that is not so. In fact, through CII, I think about 10 years ago, we did a pan India survey of hospitals in terms of their energy bills. Okay. And surprisingly, it was coming to almost about 600 rupees per bed per day 10 years ago. Just the energy cost per bed per day. When at that time, the general ward probably was costing you that much. You just add to it one meal, I mean, that would cost you at that time $250, and you take some other overheads, you were already spending more than 1,000 rupees per bed, never realizing that electricity alone was 50% of that, right? So I think after that, fair amount of hospitals actually woke up to that in Western region, and we started to look at it more carefully. And then came this, lead certification and those kind of things. The government put its, weight behind it. All public sector, central government hospitals that are to be built today in India needs to be Griha 3 rated. Now, Griha is an Indian system of sustainability. LEED came to us from the United States. Not much difference between the two, but now we have LEED IGBC, which is Indian Green Building Council. And within that council also, we have a separate category for healthcare. So that was something, which was very good. So now there are quite a few hospitals which are platinum rated. We've done a couple of them, Alexis Hospital in Nagpur or Kohinoor, here. So we, as a consulting firm, took it upon ourselves, say about 8 years ago, that we will not design a hospital project which is not capable of getting silver rating. whether the client tells me or not. That's the social responsibility that we take. And I think some things, some initiatives probably can help going forward. Suppose if government gives us some subsidy, if I get green rated, okay, something for silver, something for gold, something for platinum, either in the electrical tariff or property tax, or they may say that we will give you more FAR, or FSI as we call that in Bombay, if you get green rated, something like that. But having said that, whether this happens, doesn't happen, it doesn't matter. I would say that all hospitals should strive to save energy costs. Like I said, it is direct addition to your bottom line without any problem. So I think it's been a long journey, but I think things are now improving quite a bit. Yeah.
Thank you, Dr. Desai. It was quite insightful. My next question is to Mr. Joy Chakravarti. I really would want to know, for a already commissioned hospital, established hospital, what do you think will be the motivational factors for actually driving sustainability in the hospital? And also, what other influential factors, right from government policies, can help to have the momentum sustained?
You have asked the right question to right person. Comes from a 74 years old hospital, and it is already built, and infrastructure is in place. So it becomes, first thing is the challenge from the hospital side. So if you really need to change something within your existing structure, probably you need to phase wise shut down this hospital, and that directly hits your revenue. And any management will think twice or thrice before really taking that bold decision to shut down an area and going ahead with this. But having said that, some of the things what you have done, and Dr. Desai mentioned about 10 years back, but I can tell you it was 2018 when that study was done under HOSMAC and CII banner to see the electricity consumption, and the kind of thing was done. And it was presented in one of these conferences where we saw that electricity consumption is pretty high if you benchmark yourself with your comparable other organization from other sectors. So we have realized that a lot of medical equipments and a lot of areas where you need to have air conditioning in airflow in certain way, you need to maintain certain areas even beyond the working hours, so automatically the consumption goes up. So the first thing what you need to think about is the electricity. How do you manage? So a lot of things came. It came like, you change the accessories, you can save electricity. But I think a lot of things have been done by the other industries in terms of getting the smart hospital concept they call, getting smart hospital. They can measure the electricity consumption area wise, it can shut down if it is not in use. So that kind of things can be adapted, and which is bringing it down. The second thing is very important is your water. Most of the hospitals, when we are located in a metro cities, and population density is high, then automatically that natural resource is constrained for everybody. And when you don't use this meticulously or mindfully, then automatically the resource constraint is there. And the second area is going to be how do you use this water, recycling, and other ways save that. The third, which is part of the electricity, is again your solar energy. How do you use that? How do you get your certain areas under the solar energy? So these are the things what, being a established hospital after having operations for so many years, we can look into, and we have looked into it. Of course, it gave us a lot of stress, and it was like a nightmare that you are going to change these. How will you manage the operation theater? If it is down, how your OT is going, ICU is going to get supply? All this happens. But I still feel and I still think that if we need to bite the bullet, we need to bite one day. And when you bite the bullet, you should take it, in a way that you ultimately don't feel bad, because it is going to give you your sustainability in long run.
Now, your second part of the question was on this, government can support and what government can give. I'm not sure how many of you in this room you know that government, they don't only charge hospitals healthcare for electricity supply at the same rate like any other industries. We expect, being a not-for-profit organization, many of us are here from not-for-profit, our expectation is also further high. We expect that we should be given some sorts of exemptions on things which has not happened so far. So what we look for, that if we do that at least at a subsidized rate, how do we get that electricity in our hospital? A lot of things are now happening in terms of the green initiative, where you have, you invest in a distant location where you help in non-conventional source of energy, and through that you get the benefit. Those concepts are catching up, but I can't say it is, given a very good result for the, at least for the hospitals, and it is yet and a very unexplored area. I think that is something what we should see. The second thing is in terms of water. I'm not going to talk about subsidy, but quality water, if we get, of course, as a hospital, we are bound to ensure the quality of it. But if we get it, and at the same time we remain mindful, and most importantly, in any of these cases, when we do it, if any sorts of incentives are extended by the government, that is going to be big encouragement for the hospitals, and I'm sure that will help hospitals to go further into it.
Thank you. And I'm sure if you decide, you can actually have a lot of influence over the policy making as well. And we can take it up for the next level. Coming back again to planning, my next question is to Dr. Ahmed. And we were just discussing before the session, and he was like, a lot of things are overlapping, but actually, those are overlapping with everybody, not only with HOSMAC. So, coming back, when as an administrator, we think naturally that if I have to go ahead with the green building or green hospital, what is going to have its impact on my PNL? And that time, how do you convince the owner or the founders for actually channelizing the whole resources towards green building?
Uh, Good afternoon, everyone. So when we think about managed question, I think we did how things have evolved in the last 8 to 10 years. Joy talked about operational excellence. I was run a healthcare consulting firm, and I've seen that there is a natural shift happening in people, founders, promoters, who actually are thinking of moving to a green sustainable. Yes, there is going to be a different amount of money. And we're very, very clear with Jala plans that before you embark, do an audit of where you are today. And that comes with something called as mechanical, electrical, and automatic. This is all the three elements mentioned: electricity, water, and mechanical. So when you do an assessment, you know where you stand, you know where you're losing money. If you have to rectify and move towards a green infrastructure, it allows you to make an informed decision of areas that you can shut down and restart. And the obviously again will have to be done in the past analysis. But I will take it a moment. Coming to the buildings or hospitals, the clients today are now wanting to go green buildings. And they are insisting that we do not mind spending a little extra on the capex, but they know that they're going to benefit from the operating asset. And it's proved, and again, it depends on size of the hospital, but there is a proven mathematical formula that applies to hospitals, which shows what the benefit of going for green buildings.
Thank you, Dr. Ahmed. Right from hospitals, if we take a broader perspective now towards the policy making and how governments can actually accelerate the whole sustainability movement, I would like to ask Mr. Niku, we had been talking a lot about healthcare sector as a kind of contributor to the global pollution. It comes to around 5% when it comes to greenhouse gas emission. I would like to understand from you what is this health paradox and what initiatives government of Netherlands have adopted towards reducing carbon footprint from healthcare sector.
Thank you very much, Dr. Shilpa. By the way, with my neighbor, I'm going to talk about that a little bit. So we had our wake-up call in the Netherlands when we realized that 7% of all carbon emissions come from the healthcare sector, and that includes emissions from abroad. 4% of all waste generated in the Netherlands from the healthcare sector, and 13% of all natural resources are being depleted by the healthcare sector. So what did we do? We made a national footprint of the entire healthcare sector in the Netherlands. And there we realized that this 7% of all carbon emissions is broken down into 8% coming from energy consumption in medical buildings, production of medication, and transport movements within the country related to medical visits. Uh, uh, so that is very important to know where you need to focus on. It's measuring is knowing, as we say in Dutch. Probably you have the same in India. But before going to very concrete results, I would like to share with you a short video. It's a video about a graphic artist in the Netherlands. Her name is Maria Roy. She underwent a breast surgery and she was extremely happy to get a new breast at a certain time. At the same time, she realized how much waste was generated by this surgery. Let's have a look at the video. Is there a way? Yes, there is another way. And the way that the Netherlands has chosen to address this rightly by Maria in her personal video is what we call the Green Deal Sustainable Healthcare. So what is this Green Deal Sustainable Healthcare? It is an instrument to accelerate the green transition within the healthcare sector. So it's a kind of an agreement, if you will, between public partners and private partners, where everybody is committed to specific actions and specific targets to accelerate this transition in the healthcare sector. We are now with more than 400 signatories into this Green Deal Healthcare Sector 3.0. And then you have to think about, of course, branch organizations, our National Hospital Organization, young healthcare professionals, banks as well, healthcare insurance companies, and many more knowledge institutes, universities, but also individual medical professions. How did it all start? We started with this instrument in 2015, where our first instrument was in fact a kind of a sustainability measurement for the healthcare sector, which is a kind of environmental thermometer for the healthcare sector. In our second sustainability, in our Green Deal Sustainable Healthcare, it was in 2018, so we renew this every 4 years. In 2018, we had a Green Deal 2.0, where in fact we designed a roadmap on how to reduce carbon emissions in the healthcare sector, first by 49% and towards 2030, which we increased by 55% towards 2030, and we will target carbon neutrality in 2050. That's one of the elements, and all these organizations that have signed up to the Green Deal are committed in playing their parts in these specific targets. And at the end of 2022, we arrived at the Green Deal 3.0, in which we are still right now, and we added two themes, and those are very important to me. The first one is about prevention, and the second one is about education. Sustainable healthcare will be included in all healthcare study programs in the Netherlands. This is extremely important because that will train the medical professionals of the future. Prevention is extremely important because I don't know how it is in India, in my country, in the Netherlands, 18.5% of the disease burden is related to the behavior of all of us. So that gives you a right reason to focus on prevention as well in your Green Deal Sustainable Healthcare. Apart from the fact that technology, like sensor technologies, can play a very important role in order to avoid healthcare after a surgery, at least to reduce healthcare after surgical operations. So some best practices. One of the best practices is our hospital in Rotterdam called the Erasmus Medical Center, where everybody knows in COVID time we saw how much medical waste is being generated in intensive care units. So they aim at a 100% circular intensive care unit in 2030. They also measures that for the production of their medication and for plastics that they use, they need 4 million liters of water. 4 million liters of water. This hospital, the Erasmus Medical Center in Rotterdam, made an entire footprint of their entire hospital. Scope 1, Scope 2, Scope 3, which is indirect emissions, 60% is indirect emissions from their suppliers. So that gives you a right idea where to focus. Talking about focus, my ministry, Ministry of Health in the Netherlands, financed the setting up of the National Network Green Operating Rules, which is working on CO2 neutral care. I don't know how it is in India, but in the Netherlands, operating rooms only take 6% of the service of the hospital, but they are responsible for more than 60% of the carbon emissions in your hospital. So that gives you a good idea where you can focus on, especially energy consumption. This national network, I think it's unique in the world, has 5 targeted themes. I can share them with you. There's documentation in English as well. Energy consumption, obviously, in conformity with our Green Deal Sustainable Healthcare, is one of these themes. And they're focusing especially on air circulation in the operating rooms. Air treatment is responsible for 90% of the energy consumption in operating rooms. So that gives you a very good idea on where to focus on. Another example is hospital in Delft, as close to Rotterdam, it's called the Leeuwenhoek Hospital. In energy consumption, that's very interesting because this hospital is providing residual heating, so the heating that the hospital doesn't need, to more than 350 apartment blocks in the neighborhood of the hospital and to 4 commercial spaces in the neighborhood of the hospital. and that generates a saving of more than 600,000 pounds in CO2. One last example, maybe, and I know that one of the panelists can say more about this, is the CII Hospital. It's the first full electrical hospital in the Netherlands these days that I know. So no more fossil fuels in this hospital. And its horizontal design looks more like a health center instead of a traditional hospital that deals with diseases. Also very much working on a healthy environment, living environment. So you would say they are focusing on an energy neutral hospital. So then maybe you might say, yeah, but Nico, this is more costly to build this hospital, right? Yes, that's right. But it's only 1.2% more costly in the construction. So can you imagine if you achieve energy neutrality, how much money we're going to save? That's amazing, right? Another, and that's a technical example, is the Brabus Hospital that are capable by technologies of capturing, storing, and reusing anesthetic gases. Anesthetic gases are obviously important, right, for surgeries, but they are high polluters, right? Not everybody knows that. So by these technologies, they've been able to save already 450,000 pounds in CO2. It's
Nico, we
equivalent
have 1 minute only now.
It's equivalent of 1.4 million miles by car. I know that India is a lot bigger than the Netherlands, right, in service, but even in India, 1.4 million miles by car is quite a lot if you can save that in CO2 emissions. And that's just one small technology.
Amazing. I really am overwhelmed with these mind-blowing figures. Similarly, what you were quoting about examples of hospital in Netherlands, we have just Look Hospital recently have undertaken redesigning project at a larger scale. Mr. Jitendra, you can brief us about what initiatives you have planned while designing this whole refurbishment. And I'm sure because it being a 50-year-old hospital, there must have been some inherent challenges. How did you tackle it?
Okay, so firstly, I think I would like to compliment the organizers for using the bottled waters. I think it's going well with the theme today. So Jaslok is a 50 years old organization. So we undertook the refurbishment project about 5, 6 years back. And we were obviously conscious of that, we should be environmentally or environment friendly. So we took few initiatives. Obviously, it was not possible to, re-engineer everything, but some of the measures that we took, I would like to share. So we used to earlier have a boiler to heat water at the terrace, right? And we had the underground diesel tank supplying the diesel all the way to the terrace of the 20th floor, okay, on the 20th floor. So we replaced that with the heat pumps. So obviously that has eliminated the diesel exhaust and the possible leakage because of this transportation. Second, we also have started using the double glass UPVC windows, so that and replace the earlier aluminum windows. So that lessens the heat coming in, and therefore the efficient energy or the air conditioning system can be provided to the patients and the occupants. The other is we are also using in the patient sensitive areas the low VOC paint. So that is also it's I mean, otherwise the normal paint, that it's pungent and it's also hazardous, could be hazardous. And in the sensitive areas like IVF, etc., we have to definitely use low VOC paint. So that is something that we are doing. Also, in the for this wall guards, etc., we have reduced the plastic. Earlier, we used to use the plastic wall guards. Now we are using steel wall guards. So that is also one of the initiatives that we've taken. We are also exploring the biodegradable wall claddings as well, as instead of paint and vinyls, we experimented that in one of our floors recently. And there are a few challenges that we're facing, but obviously we'll try and sort it out with the vendors. The other is the digitalization, obviously, is very important. I think it has taken pace after COVID, and we are trying to reduce paper as much as possible. We, in fact, do not give the printouts of the lab reports unless patients insist for. So it's all digital. We also have started now recently the practice of giving the outpatient bills on the mobile. So that is also, I mean, I know, I mean, typical, Indian mind, they do not accept it, especially doctors also, they insist for the printed reports. The old staff, no, 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 I want to see the printed report. The doctor will not accept this digital report and stuff like that. But the brief is that obviously if somebody insists for, obviously we should provide, but our effort should be to promote digital practice as much as is possible. So you have to actually fight within the system. So stakeholders, those who like, we will come out with the ideas, but I think more than the customer, I think the internal stakeholders is what you have to fight with. So, but yes, I think once you explain them, tell them the benefits, I think they, after some efforts, they understand.
Thank you so much. Thank you for taking us with this journey. My next question is to Mr. Edion. You have worked a lot again in the healthcare space when it comes to sustainability. I was actually going through your profile on LinkedIn and I could see something about blue hospitals. Typically we all talk about now green hospitals. I found this concept quite interesting. Can you share what is exactly blue hospital you have in mind and how do you work towards it?
Yes, sure. To my opinion, when we talk about, let's say, the hospitals of the future, we also talk about the next generation hospitals. And to my opinion, the next generation hospital, those are not green hospitals or smart hospitals, but we call it blue hospitals. And I will come back later to that topic. First, about, let's say, our experience over the last 4 years in the Netherlands. Mr. Nico already referred to that. We have now designed about 4 all-electric hospitals, and yeah, what we see is that it is not only about, let's say, sustainability, it's also about reducing cost. It's about reducing the carbon emission, and yeah, we can do it all in once. And I will give you some examples later. Maybe it's also about the Braves Hospital. That is a new hospital which we designed, and many hospitals in the Netherlands, they commit themselves to the Green Deal. And what they actually commit themselves is they want to reduce the carbon emission with 49% in 2030 and 95% in 2050. But most hospitals, they are deciding already now, okay, let's do it in one time, right? So build an all-electric hospital. And the big advantage of having in mind the sustainability is that you also can have a different look at hospital design, because if you design a quite compact, efficient hospital, then you can have a smaller footprint, so you can reduce the carbon emission, but you can also reduce the building costs, and that's an example how you can have a more positive business case. At the end, we believe that there is a strong linkage between sustainability, smartness, well-being. And 1 year ago, we decided within our company to have a different look at designing of hospitals. In the past, it was more a kind of party from the architects. They just make a drawing and what you see is what you get. But now we see that it's so important that we focus on the 6 major aims, what we see in the international healthcare sector. That is first, of course, that is about improving the health outcomes. That's most important, of course. But the second thing is about the patient centrality. Third one is reducing cost. The fourth one is about the well-being of the medical staff. That's so important nowadays. But there are 2 main other items what is so important nowadays. There is sustainability and is digitalization. And it is our task or our commitment as a design firm to take all those 6 aims into account when we design hospitals. And what we have learned over the last years is that you can create synergy in, let's say, having an integrated, holistic design approach. So you can solve some issues in one time. But it's very important to have the users on board during the design of hospitals, but also start with a good program of requirements and look where you can find the the added value of the several stakeholders. So that's what we learned over the last years, and we are committed to, let's say, to develop this further. And it's also about knowledge sharing. And we have, of course, experience in the Netherlands, but we also see huge opportunities here in India. And the combination of sustainability, smartness, I mean, I really see big opportunities here.
Thank you so much. Nothing comes without cost, right? And nothing actually starts without money. So my next question is to Mr. Shivam. When we all discuss about these green hospitals, green buildings, ultimately it requires funding. And precisely we talk about private sector, you know. So what are the obstacles according to you for funding this green economy or the private sector?
Thanks, Dr. Shilpa. So I think as many of my panelists have already sort of covered this, the primary challenge I think is around the cost, as that has been mentioned. So I won't go into that in too much detail, but just to put something in perspective, when we talk about the premiums for green hospitals, we've been talking about new hospitals. We can't forget the existing hospitals that are there. And when we talk about retrofitting those hospitals, there the economic case may not be as strong maybe compared to your new hospitals, right? And then when you take an even more macro perspective on this, the hospitals that may be able to afford your retrofits or even for new hospitals, they are in your urban areas, they are your tier one hospitals. If you look at a more macro perspective and look at it pan India, how do we green the healthcare sector in India? How are we able to create a more economic compelling case for hospitals to do that and convince your CFOs to be able to make that decision, right? And so when it comes to that, I think looking at mechanisms like blended finance is putting it in the right direction. And the whole idea of blended finance is, can we bring philanthropic and government capital into sectors where private money is not going as much as it should be from a social and an environmental perspective? So the idea is not to fully subsidize something using government or philanthropic capital, but to provide just the right incentive to then mobilize private capital to come into the space. So can we use examples like that? So I think Dr. Ahmed, you mentioned the idea of energy audit, and I think the expense to undertake that is quite significant, but it can also be eye-opening when you see the results of something like that, right? So, for example, can you use philanthropic money to create a technical assistance pool that hospitals in your not so urban areas or your tier two, tier three cities can use to fund these types of energy audits or to fund the type of consulting that is required early on to at least pinpoint where you need to invest your money, how you need to invest your money, to be a nudge for these hospitals to consider these types of things. So where do you even start? So that type of assistance can come from places like philanthropic capital. And even looking at government, can you think about performance based incentives, interest subvention when you're talking about undertaking loans for new hospital construction? Can you think of ways in which the interest can be reduced from governments? And then again, Dr. Desai, you mentioned FSI sort of incentives and premiums that can be given. So these are the ways you can look at blended finance as a way to sort of cover some of these costs and help nudge the sector in the right direction when you look at it from a more macro perspective.
Yeah, please.
Not understanding what we said. Doing something and do what is not that is living in this environment. The question comes is when there is a loss of a living. That's the operating cost that is the hospital. Now, if that can be managed well, thought through well, with a good financial tracker for the future, it convinces the founders or the CEOs or the management to go in for the change. Also, you'd be surprised. Tier 2 and Tier 3 are more acceptable. And I think that's a lot of this.
Allowing, yeah.
I've seen it
Great. Good insights. Now, discussing about the cost, and when we see that it looks nearly very difficult or impossible, I would like to ask Dr. Lata, are there any other ways apart from only the cost-driven projects? Are there any other ways which we can actually still undertake some green initiatives? Asking this question in both the perspectives, you as a doctor, as well as you as closely associated with our Nisarga, wherein you are doing community participation leading projects.
Thank you for that question. Before I answer that, I just want to draw the point here that I am representing a practicing doctor myself with a small setup, a daycare center, and an environment background. Now, all these three, if you want to put up, is because last 20 years of my existence as a doctor, do no harm has been taught to us as in our profession. And I see that healthcare and climate is so closely connected that none of the doctors who are practicing can deny the fact that diseases and the way we treat are so interlinked to how we take care of our climate. And in a decade of my existence as an environment person, through our not-for-profit organization, we have done multiple projects in the space of healthcare, which point out direct fingers at how, at an individual level and at a policy level also, we can bring changes by only looking at low-lying fruit where we can address. So buildings, electricity, water, all of these may need have infrastructural challenges and capex and opex and all of that. But what about the small elements like consumables? I'll enumerate only 4 projects in small briefs for people to take back what they can do when they go back. Is during COVID, we saw the way we have consumed PPEs and the consumables. And after COVID, the COVID is past, but we still have continued with this thing. At our NGO, we did a study of what was the amount of waste, the biomedical waste we generated, and were our CBWTF, the biomedical waste treatment facility plants, could they cope up with this? So the answer was just not. They couldn't cope up with the amount of waste which we were creating. Even after learning those lessons, we still are generating the same amount of waste. And source segregation is so poor that the challenges of CBWTF are magnified. And lastly, the items which you are using as consumables no longer fit into even your red, yellow, and people don't know where to discard them. So the whole understanding around biomedical waste needs to be looked up very carefully because do no harm lies high on our minds. Secondly is about the pharmaceutical waste. Now, we as doctors, when we practice, we little do we pay attention of if I have written a ciprofloxacin for 5 days and the pharmacy gives for a strip which lasts for 7 days, there's going to be inevitably wastage. Nobody's going to consume more of this pharma. So we are creating pharmaceutical waste, not even knowing what is available in the market. So such mismatch in the prescription and the availability has been studied by us, and there are multiple antibiotics which we are throwing, which throw up AMR as a big challenge to us. The third one is liquid waste. So we do talk about liquid, use, but primarily as Indians, the ethos here, and as a practicing doctor and a hospital owner, we are frugal in our approaches. We are inbuilt in sustainability in sense that we aptly and judiciously use consumables. Now, when I say this, it's the same goes that let's do reduction rather than treatments. So when I'm talking about liquid waste, we did a study across 400 hospitals, small nursing homes, less than 25 bedded in Maharashtra. And we found out that the daily liquid waste is almost equal to domestic water consumption, that little. But only the OT washings, which qualifies for 10% of your liquid waste which you're generating, is the problem statement for which smaller hospitals have to put an ETP. Now, infrastructurally and economically, you cannot sustain these clauses because you just cannot put a ETP in a mixed occupied building. So instead, if we can focus on environment-friendly disinfectants which biodegrade without need of an ETP plant, promoting those things if you reflect on those kind of initiatives, I think we can have a long way in doing small steps in mitigating the climate. Last is about food. So healthcare and planet is connected, like I mentioned. Most of our illnesses is because what we consume on our plate. So all our lifestyle diseases, say type 2 diabetes to cardiovascular illness, even autoimmune and cancer, is so closely related to what we feeding. Look up at our own canteens and our doctors and our provide what we are providing to our patients when they are IPDs. We are not giving an alternative of whole food plant-based diet, which will go a long way in mitigating the climate changes. So if somebody is interested in this aspect, they should look up at Eat by Lancet, which says that in the coming 2050, if we want to give a balanced diet to 10 billion people living on the planet, then the first change has to be a switch to a whole food plant-based diet. And that is how we are going to reinvent the entire thing. So I believe menstrual waste, pharmaceutical waste, liquid waste, these are very, very low hanging, and any setup can try to manage and have an outreach in the community by practicing and spreading the word. Small steps like this will take us to a longer path in pushing a greener practice. Thank you.
Thank you. Really good and helpful insights. Considering the time, we will be now closing our panel discussion, and I thank CII, Mr. Joy Chakrabarti, for organizing and giving this apt topic today for panel discussion. Any questions? If anybody has to ask, we have a couple of minutes left.
Good afternoon, everybody. I just wanted to ask what is the difference between green hospitals and blue hospitals as mentioned earlier?
That's a question for me. Well, a green hospital is fully focused on, let's say, sustainability in reducing the carbon footprint. A blue hospital also take into account other important aspects like patient safety, like well-being of the medical staff, the cost. And it's important that if we make certain design decisions, it should be in an integrated way. And of course, sometimes I use the Rubik cube as an example to explain it, because it's like a Rubik cube. If you want to solve the puzzle, you have to understand how it works. And everything is related. For example, if you want to design an operating theater, we can, for example, combine the operating program with the air handling unit. And we can also combine it with reducing the energy cost, or combine it with a way of how we can use smart technologies to see how we can avoid that the patient will get an infection during the operation. And that is the blue hospital design approach. It is just a name, but what I try to say with the blue hospital is that it is an integrated way of designing. It's not only sustainability, it is much more than that. It's actually all the 6 aspects of what we believe, which is important for a good functioning hospitals.
Any further questions? Now, considering couple of minutes we have in hand, my last questions basically, as a take-home message, can we think something of healthcare today in India, wherein we talk about green hospitals? Do you think any concrete measures will help, and is it possible in coming this decade, by 2030, can we reach to some level wherein we can call that India at least has started its journey towards the green hospital?
So, yeah. So I think government did the right thing, to begin with, because they sit on the highest number of beds, so they have made it mandatory for all their hospitals to be Griha rated, 3. So that is a very good, beginning. The other thing is, bodies like CII or any other which are there are ASSOCHAM, there is FICCI, should bring pressure on the government, to incentivize in some way that people otherwise don't take it up, right? In some countries, like say go to the UAE, if they make it mandatory, nobody can say no. But in India, that is difficult, in the private sector at least. So if you give them some incentives, I think I'm sure people will come forward and do it. The capex bit of it is not very high. Nico said it's about 1.8. In India, probably slightly higher than that. But it's just simple things like orienting a building, in north-south direction or east-west will make a lot of impact on the energy that you consume. And air conditioning, if you plan your air conditioning proper, that will take care of your, energy in a very big way, because more than 50% of your energy cost is there.
So, you know, we know what we can do to get a green building, what we can do to save electricity, but challenge what I feel is it is limited and restricted to certain number of hospitals who are progressive and looking for it. If I go back 18 years, in 2006, when NABH came, some people they thought it is meant for all the others and I need not to come under that ambit because I may not be able to fulfill that and it is a very difficult one to do. So in the similar line, I think the awareness has to come. And secondly, I feel from a hospital, as a hospital administrator, that what we are lacking is a knowledge. Today, our knowledge is limited to electricity, water, and all. But when you talk about net zero, there are so many other things involved. What I should use, what I should not use, from where I can get it, what is the right advice. I think that awareness government can bring in a significant way, and industry bodies like us, we should make that kind of guideline available for everybody. So if somebody wants to pick up, they should pick up that and they can work towards that rather than getting, wrongly directed in different directions and ultimately not achieving what they intend to achieve.
And one last thing, I think we should also publicize people like him. You need that capital to do those kind of audits. I think that's a very good thing that he brought out. I never knew that there is something like that. Yeah.
Thank you once again. And here we come to an end of the panel discussion.
Thank you, Dr. Shilpa and esteemed panelists. A big round of applause, please. May I request you to come ahead on stage for a group photo? As a token of our appreciation to our esteemed panel, may I request Dr. Shilpa to present a thank you letter to each of our panelists. And Mr. Joy Chakraborty to do the honors to Dr. Shilpa. A big round of applause, please, to our esteemed panel. And thank you so much, Dr. Shilpa. Thank you. We now move into session 4 for today. This one is on the artificial intelligence and medtech devices. The session explores how AI and medtech devices are revolutionizing the healthcare landscape by enhancing diagnostic accuracy, personalizing treatment, and improving patient outcomes. By integrating AI with medtech innovations, healthcare providers can deliver more efficient, effective, and responsive care, ultimately transforming the patient's experience and advancing medical practice. May I invite the panel to join on stage Mr. Sunil Kumar Madikdala, founder and CEO of the Blue Semi R&D Private Limited, Mr. M.A. Maluk Mohammed, co-founder, Vice President Research, Head India for Twin Health, Mr. Anand Madana Gopal, founder and CEO, Cardiac Design Labs, Mr. Brajesh Singh, Business Head, Imaging, Indian Subcontinent, Philips Healthcare, Mr. Ankur Jain, co-founder, Chivi AI, Mr. Rajendra Kumar Mohata, Head Customer Service, Government and Corporate Sales for Samsung India Electronics Private Limited, Mr. Krishnan V, Chairman for the CII Western Region Innovation and Healthcare and Hospital Technology Awards and COO of Ramana Wheel Private Limited, Mr. Vijay Gaikwad, Senior Vice President Sales and International Business for Midmark India Private Limited. The moderator for the session is Mr. Kumar Bagrodia, founder Neuroleap and Acne Photo BioLife. A big round of applause. Over to you, Mr. Bagrodia.
Thank you. Thank you to all our panelists for being here. Thank you, CII. It's a great platform. There's enough that has been said every day almost in the press, whether in print or digital. Every influencer is talking about how AI will change our lives. Has anybody had any experience of using AI for a medical health or wellness outcome? Anyone? Right? I think it's only the service providers right now in the room, right? I don't see consumers using their hands. But hopefully with this panel, we'll change that. And we've got a really illustrious panel of people who are creating AI products, services, digital tech, who've been veterans in the industry. Mr. Krishnan is here, Mr. Mohta, Mr. Brajesh Singh. They have been in the industry for several decades now, in the main devices. And now, of course, they are looking at integrating AI and deep tech in those devices. And here we've got, some amazing startups who've got some really cool technology. Instead of talking too much, and I'm not an expert on AI, so why don't we see some quick demos of AI? Before we come to that, I'm going to ask Ankur Jain. Ankur, just a quick intro to what your company is, what you're doing, and then we'll get your demo video up.
Hi, my name is Ankur Jain. I am the CEO and co-founder of GV AI. GV is basically building AI assistants for both patients as well as doctors. So patient, it acts as a AI health companion, which you can use it for when you are sick or to prevent your disease. And for doctors, it acts as a co-pilot, which will help doctors in diagnosis and administrative work. So we will see a product demo, and that will give you an idea of all the things that we are working on.
Meet GV, your AI-powered health companion. Whether you're managing your health or consulting with a specialist, GV has you covered. Share your symptoms and medical history with Dr. GV.
Yes, I have fever.
Get AI-powered, personalized health observations. GV can do much more. Analyze your blood reports, answer any health query, or give you medical second opinion accurately. Download GV app today. Visit gv.ai. Meet GV's co-pilot for doctors.
How have you been lately since your last visit?
Doctor, I have been okay. I have been experiencing frequent migraines lately. हफ्ते में 3-4 बार होता है.
Get suggested questions and diagnosis in real time. Autofilling of clinical note. Connect with patient online. Make use of the best-in-class mind map. Generate clinical note and prescription with just a click and instantly share with patient. Get in touch today. Visit gv.ai.
Thank you.
Hey, that's really cool. Should the doctors in the room be worried at all?
No, we want to be the best friends of the doctors. I come from a family of doctors, so I'm building product for them. And doctors will definitely help. Right now, what we see is that the doctors are overburdened. So anything that can help them in to reduce the burden will help the patients eventually.
Nice. Krishnan, you've been, in the industry, you've been on the medical devices side. What is the big opportunity you see? I mean, we've just seen a pretty cool demo, and I think there's more to come there. But what are some of the sort of the pie in the sky ideas that you're seeing, the large players in the industry when it comes to AI and deep tech? Where do you see some of the big opportunities?
So first up, I think thank you. Good. Yeah, it's almost evening and afternoon, but pleasure to be here. I think good stalwarts around, and that's a very difficult question. I was actually thinking, I'm attending a session which is called artificial intelligence. It's an irony. People don't like something which is artificial, and intelligence is very hard to find. Now, having said that, and if you step back into what the medtech sector needs, and if you just step back more towards what India and Bharat need, I think I was outside during the students and looking at their ideas of what artificial intelligence could do for us and what medtech needs. I think one of the biggest impediments that India today has is lack of innovation. There are companies which are doing it. And I know at least one of them, or three of them who will be there probably today evening. But by and far, as a country, we haven't leveraged our engineering resource, our human resource. One element which comes to my mind, there's something called as the country of origin effect that most marketeers would talk about. From a tech perspective, I think maybe we are there. But from a med tech perspective, I don't think we are there. And this is my personal opinion. Please don't beat me down on that. From a healthcare perspective, yes, our surgeons, our clinicians have made a lot of mark. And what I see today from a workflow, just that what I saw from GV, I think it's a absolute unmet need. A rural doctor having, I stay in Chembur. So I had viral infection. I walked into the clinic. It was a walk-in. And there were about 30 waiting patients. Obviously, the doctor will not spend more than 2 to 3 minutes. So I asked him, how many patients in a day? Is it 100? And he's an MBBS guy. It's Chembur. I'm not talking any rural Maharashtra. So imagine the amount of workload there is, the amount of people like me who still believe in a family physician, right? I don't know how many believe in that, but I still believe in that. So there are solutions around the workflow. There are solutions around care plans. Do we need to go to a physical doctor to sort of get a medicine? So there are many areas which probably can get addressed in this piece.
I think that's a very valid point, that we have to not only see it as a solution, but as an enabler for things which we have not yet thought about, right? What more can the doctor do then, right? Not just in terms of volume or efficiency, but can be used as experience and expertise to do something else.
Also, it's like stents, catheters. There are so many care areas where it's all on the judgment of the person who's giving that care.
Correct.
Is there any information which can give them? So, for example, if it's a geriatric vein, which catheter needle should you use? The nurse has to come up with an experience. Imagine a fresh nurse who's sitting in a rural India who knows this kind of a vein, this is the needle to be used. At least your medication errors go down.
Absolutely. I think that's a very valid point. Maluk, I'll come to you. You've done some tremendous work now in reversing chronic diseases. Am I right? And why don't you give a quick insight into that, and then we'll play the video that you have for us.
First of kind in the world, called the whole world initiative, which were able to remission any chronic disease, diabetes, hypertension, fatty liver, PCOS. We are the first company in the world who had proved that the microvascular complication can be reversed. Neuropathy, retinopathy, nephropathy can be reversed. We were awarded by the American Heart Association twice for proving that the heart health can be normalized. It's revolutionary. We are present both in India and US. We have raised over 50 million. We are rated as the fastest growing company in the world. We are presently commercially available in India and US. To talk about the credibility of what we are doing in US, we get paid based on what we deliver. We reduce the A1 by 1%, we get $1,000 paid. We reduce the prescription cost by $100, we get $30 paid. We reverse fatty liver, we get $2,500 paid. So we are paid by the payers based on what we deliver. We talk about the credibility of what we have. That's a quick update about
That's phenomenal. I think that is an amazing way to empower people to say, we will only pay you if you deliver an outcome which is measurable and where the impact is at scale, right? The way India is going with the government spending on healthcare, set to rise every year, I think there will be a point in time where the government in India will also say, hey, why should I keep sending patients to XYZ hospitals or clinics or doctors if they are just on a treadmill? Why don't we get Maluk, and instead of 250 million, we give him another 2 billion or whatever it is, right? By the way, he didn't tell me earlier he's raised 250 million. Otherwise, I would have told him to sponsor the whole damn event, right? Next event, right? But can we play Maluk's video?
Your body predicting and preventing chronic diseases. Twin Health, a Silicon Valley startup, aims to revolutionize health with their whole body digital twin service. Using data from wearable sensors and clinical tests, they create a virtual model of your metabolism. This provides real-time, personalized health recommendations through a smartphone app and personal health coach. Studies show significant improvements in HbA1c levels, your blood sugar control, and other metabolic markers, transforming diabetes management. Imagine personalized digital twins for everyone, predicting treatment reactions and disease risks with precise, real-time data analysis and tailored interventions. Could digital twin technology be the key to a healthier future? Subscribe to Agents of Tech to find out more.
Great. I want to come to Mr. Rajesh Singh. You've been with Philips for more than a decade now. So you've actually seen a huge, journey in that entire one generation with, Philips. What are some of the key areas you're seeing in terms of AI and now deep tech, going into your devices?
So if you see imaging as a modality, we have been using AI for long, right? So many people are aware of AI, especially outside this room, common population after Chat GPT, which is last 2 years. But imaging goes by pattern detection. So when we say a pattern detection, AI can play a key role. And as Mr. Krishnan was saying, that two areas where it's playing key role. One is the clinical decision support. Second is the workflow efficiency. Of course, the with Gen AI coming, it's also disrupting the AI that we can offer, because now what can happen that doctor can talk to the patient record, right? Rather than talking to the patient, because there is a patient record, and if you apply Gen AI on that, the patient can also ask his record, whereas doctor can also ask questions to patient record rather than asking to a patient himself. So 2-3 things that we are doing, Kumar. One is that how to make systems more efficient without changing the workflow. So you can automate the process. You can also do something like quantification, few menial thing, right? What we are saying that AI will augment the expertise of the physicians. So there are few mundane things, or you can say that low priority things, which can be prioritizing the patient, doing the quantification, segmentation, that can be done by the visualization tools. Then it comes to applying AI on something to predict something. This is where we are seeing the transformation. While we already had automation on the quantification and segmentation, where we changing AI is that AI will tell that what the clinician should look at, the predictive value of the AI, and that we are seeing in the diagnosis as well as the system maintenance. Because earlier we used to maintain system when system was down. Then we enter the preventive maintenance, that we are checking the system quarterly, half yearly, and making the system up. Now we are saying that can we predict the when system can go down? So if I look from vendor side, we are making the system more efficient. We are augmenting the expertise of physicians. We are also making sure that can system uptime be improved in a way the system can be utilized more. Yeah, that's the only way you can make healthcare more sustainable. We have more number of patients, we have complexity of disease increasing, and doctor to patient ratio is not improving, right? And the only way the healthcare can be sustainable when you make it more efficient, and that's what we are trying to drive.
Very interesting. So, do you see a time where the sensors, the hardware will not be, as important for you as the software, the AI, the machine learning, which is perhaps not even sitting in that laboratory or in that hospital. It's somewhere in the cloud, and the hardware will be inconsequential.
Yeah, so it's all, we are already seeing that when we used to go and sell our technology earlier, right? The focus was more on the physics of the equipment. We ourselves being engineers, many times we used to talk on the hardware, what the hardware can do. Now the focus is more on the outcome, that how what will the outcome of this thing. And since we are also seeing chronic disease increasing, right? And when we say chronic disease, is also involves active patient engagement. So what we are seeing, so basically the AI that we are developing is working more on the human experience now. And when I say human experience, to empower patient more to take care of their health, and empower the users more to focus more on the patient than the machine. So the discussion is already shifting more from the like 7 Tesla MRI or 10 Tesla MRI or 3 Tesla MRI. We are saying that you can scan the stroke patient in 2.5 minutes now. We are saying that you can see this image resolution twice at the one third time. So discussion is now focused more on the outcome.
Interesting. Mr. Mota, at Samsung, you were mentioning Samsung is investing really heavily into AI. And so, as part of the medical devices business of Samsung, where do you see the AI opportunity?
So, Samsung has been investing in AI from 2010. So, I mean, we are working on AI for a very long time now, and it's been a long way. And what we have seen is that AI should help, not replace the doctor. It should help the doctors in doing faster diagnosis, accurate diagnosis, and it should help patients also in doing the right treatment, taking the right treatment, taking the right medication, managing the patient care, those kind of things. So it helps as an assistant doctor as well as patient, and to a great extent to the relatives also. Just by, I mean, having a timely medicine makes a lot of difference. If your parents are living here and you are living somewhere outside, you want to ensure that okay, they take medicine all the time. So a reminder through AI can do wonders for you. It's a very, very basic small tool which helps. So in Samsung, what we're doing right now is that in our imaging devices side, we are helping clinicians to have faster diagnosis, accurate diagnosis using AI tools. So we are moving towards even live AI support. Most of the imaging modalities are doing AI as a post-processing. But what we are doing now is we are moving towards live AI, which means when the doctor is doing the scan, performing the scan, the AI will help him in doing the diagnosis, AI will help in doing the measurements, stuff like that, to the next level. Of on the patient side, we are moving towards like X-ray machines. One click, one scan, you get 5 different type of images, and it does like kind of a primary level diagnosis also. Okay. These are kind of productivity tools which is working, but that's what I feel is just the beginning.
Sure, sure. Mr. Gaikwad, as a medtech device company, you've also got not just devices, but full-fledged equipments, etc., for hospitals. What is the role of AI you're seeing, and what are some of the cutting-edge areas you all are working on?
So thanks, Sia and Kumar, for having me here. Probably I'm an outlier in this group because we make hospital beds, we make medical furniture. We are the largest in India, probably in South Asia. I would like to split this question into two parts. Okay, one is on the manufacturing side. We do a lot of simulation, and nowadays you get a lot of CAD designs, okay, which embodies machine learning. So we use is not artificial intelligence; is part of machine learning. We use to create lot of failure modes, which can be avoided in practical sense. On the actual manufacturing, we use a lot of robotics. And that robotics has advancements in recent year. We use closed loop robotics, not the open loop. So more advancements will be expected that will increase the preciseness further and reduce the wastage of sort. Now things become bit interesting when we go on the front end, when the products are delivered to the hospital. And if you take the roadmap, if you see the roadmap of hospital where the actions are actually happening, you'll observe that the heat roadmap is maximum around the bed, then probably in the OTs, and then in the daycare. So around 15 to 20 procedures are happening on the bed. Patient spends about 80% plus time in the hospital when the patient is actually admitted to the hospital. So what we are consciously looking at is that how do we improve the efficiency? Because hospital beds are different than other devices where the outcome is not tangible. I cannot say that a patient lies on a particular hospital bed, he will get recovered faster. So what we are doing at how do we introduce tangibility and support outcomes? So we actually worked with a startup in India a couple of years back. They independently do it, but now we have beds which can actually measure vital signs, and this data is actionable. We are looking at simple parameters like wetness. If we can monitor the wetness, for example, as simple as that, nurses can take swift action. So what we are looking at is that we can integrate the things around the bed onto the bed, which can improve the efficiency and effectiveness. We are also looking at real-time location services wherein we can track the assets, and with the help of here the artificial learning, we can define the workflows much better. So that's what all we are
That's very interesting. I mean, the way you say it, one realizes that the bed is almost like the thankless back office, right? Nobody's making it sound cool and happening as a product, right? But here you are trying to give it its due credit then. But great. Let me come to you, Anand. You've sort of made some very interesting devices in the cardiac care, and you've got a demo for us on how you're doing remote monitoring. But why don't you give us like a 30-second sort of insight into what it is, and then we'll look at the demo.
Okay, so we are a company that builds hardware, works at sensors, algorithms, and the delivery, which is the reporting. So when we look at diagnostics, unlike what some of the sections of the industry are talking about, we are seeing reinventions of the way the hardware is used. Some of the ideal pickup points or signals on the body are being redefined. So there is a lot of work that we do which enables advanced cardiac diagnostics from a rhythm monitoring, where we have a patch. So the section is about how do you pick up signal without intruding too much onto the patient and report it really effectively, give the burden of the disease very well. So when we say that, it's about how much time the technician spends in front of the data to produce a report. That is where algorithms come in. So we have cardiac monitoring one side, and then we're bringing out a product on vitals monitoring. This is another area which a lot of manual work gets done in a hospital. Every time a patient gets off the ICU, before he or she goes home, the reason the patient is going to go home is the nurse collecting the vitals of the patient at regular intervals and plotting it correctly. The next day, the consultant comes in. You get to see the trend of how the patient is by looking at how the vitals have progressed during the day. This work is still manual and error prone. You can imagine the amount of time she or she actually collects the data. This is another area we realize we can have actually effective devices that pick up data not at a generic level but at ICU quality, but also be able to collect some data without, which is difficult. For instance, example is the BP. BP requires a cuff these days, and it requires inflation, deflation. We've reinvented that, and that is where AI has fitted very well. So what happens is we don't give the exact BP, at least we give the trend of how the BP is going. We pick it up simply off the photoplethysmography, which is the SpO2. It looks very simple, but a lot of work has gone in behind it to produce very accurate data. So that's what I have here as a demo.
Sure. Can we have Anand's demo on?
Yes.
Run us through it.
Yeah. So what you're seeing is a dashboard of a remote monitoring of actual ICU at 2 hospitals in Bangalore. I thought I'll get you the live feed. This is actually a patient. The patient is anonymized for you so that you don't get to see. So this patient is one of the ICUs. The device he or she is wearing is only 65 grams. Okay. And is absolutely producing all the values of the ICU there. There is a full study to show how these match a standard GE or a Philips bedside ICU monitor. It's coming off a simple wearable. It has a whole load of algorithms, which has math, logic, and deep learning. So that BP that you see down there is coming off the SpO2, and it's actually trained with over 2 million beats of the PPG wave. Its pulse volume, pulse pressure, extrapolated blood pressure is working very well. This is the foundations of what tomorrow AI get into critical care as well, apart from the other examples that you're seeing today. Thank you.
Hey, well done. So this is real sort of Atmanirbhar Bharat stuff, yeah, which will make us into Viksit Bharat.
No, so the whole work that you saw there was all indigenously built here. All IP belongs to Cardiac Design Labs. It's taken us over 10 years to get to where we are today.
Congratulations. Sunil, you've got a really amazing device. Please tell us all about it. I think you're the only one which is measuring blood glucose non-invasively. So please tell us.
Yeah, thanks for that, Kumar. So, I'm proud to say we are the only brand in the world that could measure non-invasive blood glucose and 5 other vitals by just touching it. You don't need to prick, you don't need blood out. All that you'll do is switch on the gadget and place your fingers on the gadget. And it gives your cardiovascular health, metabolic health, and respiratory health in 60 seconds. So to spice this up a little more, what we also did is that we are about to show here is a lot of our users that have been using the gadget across India also asked us, hey, not every time I want to bug my doctor at midnight that I couldn't sleep and I can't call my doctor all the time, right? So they just wanted some system, some digital system to tell them what might be going wrong with their body because we already own their data within the product. So can your product look at my data and tell me on why I couldn't sleep in the night, or can your product tell me if I should have coffee right now? So we built a generative AI model based on the unique data that Ava collects from the users. So the entire advice or the recommendations are hyper personalized. I can be here, Kumar can be here. We can ask the same question, but the response that I get is purely dependent on what my body looks like. Similarly is for Kumar. So we are going ahead and making this form factor much smaller and much sexier. We are trying to bring it onto the hand of a person so that they doesn't need to discreetly understand their health, but it's more like a health coach on your body all the time, silently monitoring you, silently taking care of you. So if you play the video, please.
Yeah, that's
Yep. So there you can even ask all the even more silly questions possible. Hey, I couldn't sleep. Can you help me? Why I couldn't sleep? Or I want to have samosa. What kind of impact will it have on my body? And it tells you.
very interesting. And I think usually it's doctors are getting more silly questions, right? So you perhaps have to train your model not on so much the medical questions, but on the silly stuff, right? Um, Krishan, we've obviously seen now on the panel some really amazing innovations, and some of them have great promise, right? Some of them need to be tested more, etc. Um, you've been in the industry for long, you've seen it sort of evolve. What do you see as the key pitfalls that patients, doctors, clinicians should be wary of, as we get onto this journey about deep tech and AI?
I think fundamentally, the moment you name artificial intelligence, the pitfall itself is there. The name itself spells it. Obviously, not find a way to over rely. Then there is data privacy, data accuracy. So you need a specialist, a trained specialist to sort of decipher the whole thing. So you mentioned mental health. I'm also an organizational psychologist. So if I look at my own artificial intelligence, SPSS and statistics has already saved me at a 99% accuracy. So there are only two probabilities. It has to be 99% accurate or 95%. Below that, it's a big cross. Now the question that we have to answer is we don't know where it is going to reach. Honestly, we don't know which way it's going to swing. But just being wary of the fact that get your clinical trials right. Again, that's something which can be done in India. We need policies around it. Right now, we don't have much, and I'm sure the startup friends would agree to that. That's one space. If India wants to progress, we are actually clinical trials. We do a lot of clinical trials for people abroad. A lot of countries come here to do because we have a population which has got en masse. So how do we sort of leverage that, produce a lot of credible papers, and based on that, evidence based, you leverage the intelligence and make it grow. I think for a country like India, which is divided between India and Bharat, this is definitely a boon in disguise.
You're absolutely right. I think, especially for a country like India, like you said about Bharat, I think the bang for the buck will require these sort of solutions. We don't have that kind of funding, neither in private, neither in public, to be able to solve, for a 1.4 billion people otherwise. Mr. Mohta, tell us a little bit about at Samsung, what are then some of the areas where you all have seen early challenges, and how are you all planning for that, at the clinician level or even at the patient level?
So, one challenge which we feel is the accuracy of the data, the authenticity of the data. You feed the data into the system will process, use artificial intelligence, and give you a but
will totally depend on the data. So the crux lies in the quality of the data. And that's where the biggest challenge comes. India has a lot of population, a lot of manpower available to you to collect data. Fortunately, unfortunately, there is no strict regulations in data collection. Yes, government is making some, but then the quality is the concern. If you feed garbage, there is garbage. So that's one big point to see. Number two is that how the technology gets integrated with that data. How are we going to? So there are a lot of wearable devices which are coming in the market. There are a lot of here itself we have seen a lot of devices coming in. Now, overall, for a patient or for a doctor, he needs a solution, and there are multiple solutions available to him. Which one is the right? Which one is wrong? Which one is the optimum for him? So those kind of decisions, how everything gets integrated and we look at the end-to-end solution. That's what where I feel the major challenge lies right now. How we can make the overall model say more predictable. But say more predictable in which way the doctor or the patient or the patient sitting at home can the the guidance of the doctor and the patient sitting at home can get the in then we reduce the load of primary physicians. The doctors is necessary there. The ratio between a patient and doctor is very important. So how do we reduce the load of a senior doctor and use it for the secondary instead of giving primary care to patients? So that's the kind of solutions we need to do. And that's where probably the real benefit of AI lies.
Right. So it's not AI for the doctor, not AI for the patient. It's AI for everyone, basically. Right. Maluk, your solution, you use something called as a whole body digital twin. Tell us a bit more about it.
So before I answer your question, I want to the question was pointing out what happens at the because we did a clinical trials in India. We are doing 3 years, and we wanted to ensure that we get the data published. This we started NBT and Lancet. The biggest challenge what we thought and saw was all these top journals were reluctant in accepting Indian data. That's the kind of credibility we get built, which is scary. We fought because we were cautioned ahead of time with people like Professor Shashank Joshi and other people like that. The kind of outcome that they are going to show, someone is not going to believe. Have proof for everything. So we cannot believe even the blood sample which we had drawn, we had sorted, we had frozen and we had kept it. And we went so deep, and that's where we were able to crack and make people agree on it. So we have gotten to that we found very, very difficult. That's number one. And related to the chapter what most of us find very, very accuracy, right? Very proud to share that we have built a solution where if people give a wrong data, the system can understand and tell that the data is wrong. Right? We call it tags. Because body is unique. Each body responds uniquely. And the correlation is very interesting. So it goes to say that sometimes something is fishy points on the data. Right? Still, technology is so powerful that we are able to trace that. Now, going to the question we asked, what do I say? The truth is, the biology of every human is unique. The behavior of every individual is unique. We cannot have a common solution which can work for all. That's where we came up with this simple innovative solution. Very interesting, the Genesis company, what I done as part of the PhD work, and what Dr. Jagiri has done with Tesla. The Tesla readiness was possible because of the extension of the car. Even a point per question element of the car, right? So, yes. And Boeing selection of Boeing's was from Jasper. So those two genesis was what Goldberg mission was right? So what we understood is all these chronic diseases are not related. Diabetes, hypertension, cholesterol, all these are related diseases. They are condition. They are symptoms. The actual root cause of these problems is dysfunctional metabolism. Metabolism is nothing but thousand that makes it human body every instant of time. God's made so beautiful that no two human has the same metabolism. We ourselves don't have the same metabolism. What we are telling is that what we have now. It's completely complex and linear. So if you want to solve the problem, can we build a technology to precise measure the metabolism? If you ever do it, nobody was going to do it in the top three in the world in the next coming years. And why we thought why not we? We started to work on it and very proud we did that. So we this human metabolism, three sets of data, sensor data, blood diets, and the modern stuff, the medical activities, and the cost data. What I can express and move my energy, right? With these sets of data, we build a distribution of our body, and a few years as the person travels in the journey of the treatment, the sensors goes on. He needs to just kind of watch it. The other sensors which are not required. Because by this time, the distributors learn substantially and they never go on the right path. How? If you go pick up my distributor, it will let me know what is distributed at this point of time. I'm not trying to see right? My blood glucose level. It does not my diet. That's the power of the technology what we are doing. And we created it and we proved the science companies both in India and the technology. So with these pieces of data, what was all this data, we are able to understand precisely the metabolism of the body and the treatment factors are precision nutrition activity and sleep. When you are born, we know only four things: mom fed us. We were doing activities, they were moving our legs and hands. Is that clear? And you are breathing. The body is only these four, right? And we pick up all those four and make a sound. When I meant precision nutrition, just not enter the diet. It's not like you have everybody needs what you need. So the digital lets me know what I want to eat, depending on my metabolic condition. It lets me know what activity I need to do. Should I 10,000 steps or 12,000 steps, right? And it's not the hours of sleep, it's the quality of sleep that matters. And that's what we're into. The digital lets me know by which we need to offer. And it's a treatment offered by doctors. We are an Indian of the doctors. We are not replacing the doctor, we are enabling the doctor to offer solution. So even a non-chronic person has to be paid off because the data has to be paid off. Sorry, it took a long time.
No, no, absolutely good. I'm just amazed at what you're doing with this whole digital twin. And yes, you're the first company, as you say, to do it, but I think you've still not cracked the holy grail. Please let us know, when will the digital twin help the person manage their spouse, understand and manage their spouse? Forget about managing themselves.
That's a mental health
Crack that,
question.
then we'll talk. Then we'll give you a full 1 hour, at CII on national stage. Yeah. He will be the number one, absolutely. I think he already has that technology. He's just using it for himself. He's like, why should I give it to others? But that's where Ankur comes in. So with GV.ai, Ankur, we saw a quick, snapshot of what you can do. Tell us a little bit about, what could be the challenge for an individual, right? Forget about the language challenge. I think you've already solved for it. It's multilingual. You showed us a demo in Marathi as well, and you said it speaks Russian, French, etc. But in terms of accuracy, in terms of misinformation, in terms of a particular school of thought on how to treat a disease, like how are you solving for that?
See, there are two main challenges that I could see, right? One is the accuracy, right? If people are not sharing the right symptoms to AI, it will not give the right output, right? If you go to a doctor's clinic, as soon as you enter the doctor's clinic, the doctor will analyze using his eyes and understand what's going on, right? So that is the biggest challenge that we see. The second is the acceptance, right? Means even from a different, everybody has a different style of treating a patient, right? For example, if it is a diabetic patient, 10 doctors, 10 different treatments. AI has its own mind, right? So you can nudge the AI to think in a particular way, but you can't mimic a particular doctor, right? These are the two challenges that we are working on right now, right? We are hoping that in next few months we will be able to solve is basically building a digital twin of a doctor, right? And then it's a holy grail is that a doc if I can go to a doctor and say that, hey, this is your digital twin. You can give your digital twin to a patient. That digital twin will do the triaging, and then once it has all the information, it will enter your clinic. So these are the challenges that we are working on. Hopefully, we will be able to solve these in few months' time.
That's interesting. So you're saying that the triaging will be at such a accurate level that will enable the doctor to make a quicker and more effective diagnosis.
Absolutely quicker, correct, and effective diagnosis.
Great. Anand, your solutions already being used in some great hospitals across the country. Where do you see this, grow from here in terms of what you said at the, ICU level? Do you see this getting into people's homes, where they could be using it and connecting to, Ankur's digital twin and then get help from Maluk's digital twin, and probably use some tech from Philips and some from Samsung, and Aiva will do something, and Krishnan will sit there and say, "Ha, ye galat ho raha hai, ye sahi ho raha hai, this is fine, let's get it all going." Do you see this happening?
Yeah, so a good thing you pointed out. So one of the rails of the train we're running is cost. Cost is a big factor. Now, while we're talking about ICU and the advanced cardiac diagnostics, is primarily looking at key problems that are getting substandard care today. So that's the aim at which these solutions are put, while the costs have to be low. So when we built, that's why I said hardware will not become irrelevant, because the higher the accuracy you hit, it is simple for people to take costly sensors to go in to produce that solution. But that's not going to solve your problem. It has to be cost effective as well. So when you actually build the right piece of hardware, like the way we've been pushing hard, you also get the bill of material down, which means it can be put onto everybody's hand easily. So the vitals monitor that you saw there is actually going to cost you less than a rupee an hour. That's about it. Okay, we still see everybody making profit in that, and people be able to provide care. Now, what you're saying is this can be actually put to any patient which has a chronic disease, who needs to otherwise come at a regular point. So today, India is happy to treat the acute. You collapse and everybody pounces on you. We're saying, can we change that? Can we change such a way that before it got acute, somebody can identify and say, hey, there is a potential case for you to look at before he or she lands up in the ICU. Can people intervene? That is where I think real healthcare impact is going to happen, and carefully blended with AI. Again, I see a issue of AI being used too aggressively. What happens is, if you can't get the predictive clear outcome every time, then you're sitting with a dangerous knife. So like the US has said, if you introduce a new data into your training set, you recertify the device, because now you don't know what its outcomes are going to be. You can't say, I just put in one small delta. That
Sure.
delta could undo the whole thing. So there's going to be a balance of where you can use AI, where you use traditional methods, but be able to complement such that skilled people can look at real patients quickly. I think that is where the solution in healthcare is.
Sure. Brajesh, where do you see Philips on that journey?
Yeah.
A lot has been said on the panel, but what is your take there?
So I think what all panelists also said, that insights that you get will be as good as the data that you are feeding into system, right? So biggest challenge which we had, that when AI started, digital transformation, we got more data than insight. So our journey has been from data to information to insight. That's the first thing we need to do, because there's an overload of data also, right? Finally, doctors don't need to play with data, but they need to take care of the patient. So first thing is how you can ensure that you have relevant data and you have contextual data so that the training set of the AI that you are using is also relevant for the patient population. Fortunately for us, our AI headquarters is Philips Innovation Campus, Bangalore. So we are partnering with the clinical partners in India, and that we are doing across the globe to ensure that the training data set reflects the diversity of the population that we have, right? We also need to see that so many data getting generated from so many different systems, how it will come together. So how vendors can create the ecosystem. So we are trying to create the ecosystem where we have like something called AI manager, where customers can also choose other company, other vendors AI solutions as well. So it's not about winning individually, but I think how we can win together, because there are so many different AI solutions we are seeing, how it can come together to offer better care for the patient. I think that's the journey we need to travel.
This is fantastic. Look, I don't understand AI too much. I'm just a neuroscientist. I don't understand artificial intelligence. I'm more concerned about natural intelligence, natural stupidity. That's what I'm concerned about when I look at a client's brain. But I think the opportunity here is all of you guys are creating amazing AI deep tech products. I'll just create a super app and I'll say, do you want to go to Ankur? Do you want to go to Maluk? Do you want to go to this guy? Right? And
marketplace.
Yeah, we'll just do that. Yeah, this is fantastic. Sunil, where do you see the journey now, given that you've got a sensor-led data acquisition system, so you're not really relying on manual data, etc. So how has your journey been, and where do you see it from here?
See, I see two things happening in the near future. The first and foremost thing is I'd like to rename artificial intelligence as assistive intelligence. It is not gonna replace decision making by doctors anytime in near future. It's more or less like how we get these robotic surgeries that are happening under the supervision of doctors. That's how AI is gonna play a role as a as a as a bridge between the doctor and the patient going forward. And with the sensors being integrated, it's more like human body. You have your eyes, skin, and ears, and then everything's happening in the brain. So that's the AI, and all these sensors are here. So going forward, I don't think there's gonna be some generic standards across the globe around thresholds of vitals that WHO publishes, but I think it's going to be more of a hyper personalized thresholds. A person living in US at 40 age will have very different thresholds based on the environmental conditions that they are in compared to a person with a similar body type in India.
Got it. We're almost at the end of the session. We have just 5 minutes left, so maybe one or two questions we can take. Anyone? Okay. On the first table here, gentleman in the blue shirt.
Hi, my question is in terms of the validating any AI solutions, right? Because hospitals and especially the doctors, they get a lot of newer technologies coming in and being demoed to them, and they get very excited about it, saying that it will solve their problem. But when it is implemented at scale, they fail, right? The validation is a biggest challenge, and Anand talked about it, Moto talked about it. So how we like, are there any solutions that are you guys anything, especially from the Samsung side or the Philips side? Are we working on some solution where we can validate the models on the India data set?
Sure. Sure.
Work is going on the data set from India. Every demographic have different kind of patients, different kind of physiology. So the data set will be very different. So to make a model which is we can say a company like Samsung product kind of product, you need all kind of demographic all. So we are running, there are a lot of hospitals, there are a lot of doctors which are on panel with us, who are doing projects with us, who are doing clinical studies with us, and we are taking data from it. So when you see a product from Samsung, there is a data set which is there from you also. So yes, there are a lot of times, there are a lot of white papers which are being published based on data used by us and connected in India.
So one thing is that while you are training the AI, you train with a diversity of data, right? As much as possible. But now also there are AI solutions which will learn also when they are installed. So while it's trained on a data, it will also learn when it's being used in the actual real setting. So that's happening.
One last question. The second table there, the lady with a hand up there. Yeah.
Hi, this is Manini Puranik. I run a technology firm. We work on the data side for all kinds of healthcare apps and platforms. But originally, I come from the retail manufacturing background, like building technologies and platforms there. And there's been a question in my head for a long time, and this session was very insightful there. Many panelists talked about the quality of data that is needed to actually train valuable models. Now, if you look at financial sector or retail or manufacturing, the quality of data is very high because I think they hopped onto MDM bus, say 20 years back, master data management. I wanted to understand the role of master data management systems in your individual organizations. Have you installed some? Have they helped you in streamlining your AI initiatives?
Anyone?
So you're looking at who qualifies the data before it goes in, right? Is that the question?
I think she's just talking about master data
Question
management.
is, do you have systems in place to do that? Data platform systems like master data management systems.
Okay. So unfortunately, I will say from the devices per se, your outcomes cannot be erratic. So once programmed in, they have to be very, very predictable as to how they land in somewhere. So in our case, the data is not system driven, but manually driven.
Okay.
So even if it is 2 million beats, these were all hand picked to be going into the system because you want to make sure when it does output a value, there is that scenario of it may be right, may not be right. Scenario is not there. It is bang on. So that's a very important criteria. But on generic use cases, it may be possible where you can actually use systems to put in and you have some level of error going in. Right.
Yeah.
I think when you look at data sets management, the way tech companies work is very different from what devices companies work. Devices company, you cannot launch a product without data. Fundamentally, that's how regulations work in India. Forget India, anywhere in the globe. So by that logic, the device sector is already regulated heavily. There is no way you could launch a substandard product without a good product market fit, without a clinical trial, with efficiency of data and so on and so forth. Now coming back to your AI question, I think that's something which will come in the future. We've just in the anvil of creating a national repository of our diseases. There's a national register being built, and CoWIN and so on and so forth. We're the advent of that. Maybe at some time in the future we will see that getting published because ABHA. There's so many other elements that are coming into play. The insurance is now doing an interplay of diseases. So I think over the next 10 years you will see the Ayushman Bharat evolve with the disease burden of the individuals, and accordingly the data sets will get managed is my hypothesis.
Sure.
I might be wrong.
I'll also request Vijay to respond to that because, like you mentioned, your data is coming from somebody lying on your device, so to say, the bed.
So we put the data on the top of the hardware. So here I heard about devices, hardware being different, software being different. So we follow the same philosophy. While our prowess is in hardware, so we make the hardware which is ready to accept and align the sensors and the data. And to her question, I think it's quite apt. The challenges which we face, and I'll take back a little because that will answer probably her question, is that the user willingness and the motivation of using the technology. Okay, for example, when we took one technology which can detect patient turning, okay, with a supine or something, which can help reduce the incidences of pressure ulcer. Okay, there was unwillingness from the end users because it also puts the end user in the spot. Okay, so these are some of the challenges. Willingness of the user, okay, to use technology would come from the search. I mean, so the discovery, the reports, the continuous trials that we are putting. We don't do it. We work with our partners who have that model, and they have hospitals on the panel like Samsung, which they did, who can validate that data on that part.
Just I think in your case, your device, there's no unwillingness, right? I mean, वो तो बेचारा patient bed पे पड़ा हुआ है. Where is the question of willingness to,
Yeah,
give the data or not? You're getting the data.
You're right. For the platform per se, it's not a problem. Okay, so the problem is, when we put the technology and we present it to the customers as an integrated service. Say, for example, vital signs. Okay, for example, detection of wetness. For example, detection of patient turning. There is a willingness has to come in to check and to accept. That is what I'm talking about.
Thank you. A big thank you to all our panelists. We've run out of time, but thank you so much. A big round of applause for each of our panelists, please. They've spoken very candidly and some great insights from each one of them. Thank you so much. Thank you, CII. Thank you, Joy. Joy is here. Thank you. Big round of applause for Joy. He's put this. This is really a labor of love and passion for somebody to put together this 2-day mega event.
Thank you. Thank you, Mr. Bagrodia, and thank you to our esteemed panel. Can I ask you to step forward for a group photo? I'm requesting panelists to please stay back on stage. So as a token of our appreciation, uh, we have a few thank you letters to be given, and I'm requesting Kumar to do the honors. Hmm. So that's a mutual exchange now, and requesting Mr. Krishnan to also uh, hand over a token of appreciation to Mr. Bagrodia. Thank you. Thank you so much. We now break for some tea and coffee, and request you to please assemble back by 4:55 p.m. Our next session will be on the National Health Exchange and Digital Health Accreditation Standards. Please join us back in this hall at 4:55 p.m., please.
वाटते की आवडलेलं वाटते की
1895, when modern engineering was just beginning its journey in India. 5 engineering companies came together to form the Engineering and Iron Trades Association in Kolkata. When the first Indian steel plant started production, the EITA evolved into the Indian Engineering Association. Successfully steering Indian industry after independence, it combined with the Engineering Association of India in a historic merger in 1974 to form the Association of Indian Engineering Industry, shifting its base from Kolkata to the capital city, New Delhi. AIEI was rechristened the Confederation of Engineering Industry in 1986, and in 1992, it took on its current name, the Confederation of Indian Industry, or CII. Always ahead of the curve, CII has since then adeptly navigated industry through the era of economic liberalization and globalization. Today, CII represents a large number of enterprises from private as well as public sectors, including SMEs and MNCs. National, regional, and sectoral industry associations find a platform in their affiliation with CII. CII is the voice of Indian industry. As a nodal point for industry, nationally and globally, CII represents all sectors: manufacturing, infrastructure, services, and agri. It reaches out to a broad base of member companies and indirect members through a geographically diversified network of offices in India and overseas. Through constant realignment with the new challenges being faced by business and industry, proactive interventions in volatile times, the ability to build synergies and create stepping stones, and through intellectually sound change management capabilities, CII has retained its relevance and its premier position in India's business landscape. CII services rest on four broad pillars: policy advocacy and international business development services, developing competitiveness solutions, and connecting with society. For policy advocacy, CII focuses on the creation of a facilitative environment for Indian industry to constantly strengthen its role in national development. CII partners with the central government and state governments in drafting and implementing policies for inclusive and sustainable growth. Drawing on the collective experience of its large member base in the form of expert councils, committees, and task forces, CII brings formidable perspectives for evolving solutions to complex issues. In the area of international business development, CII facilitates access to enormous domestic and international business opportunities by organizing business fairs, conferences and seminars, buyer-seller meets, and trade and business missions. Landmark events in this area include the IETF, XCon, Auto Expo, IMME, IREE, and Agrotech, to name just a few. Every year, CII organizes intellectual forums in India and overseas, including the Indian delegation to Davos. CII plays a key role in creating international business opportunities by facilitating access to overseas markets, showcasing India's capabilities through trade fairs, creating B2B and B2G platforms, and engaging with MOU partners and international institutions across the world. CII works with the Indian government, including Ministries of External Affairs and Commerce and Industry, to develop strategies for trade, investment, technology transfer, and joint ventures. It enjoys high level of interaction with international government leaders, academic institutions, and embassies, crafting a multi-dimensional agenda to deepen Indian industry's overseas footprint. In the competitiveness arena, CII assumed the mantle of lead catalyst in helping Indian companies to face the challenges of globalization and competitiveness. Establishing the National Committee for Quality as early as 1986, it has emerged today as a leader in competitiveness solutions for firms. CII's pioneering cluster format for shared learning is a unique platform for MSMEs seeking to drive success. Adoption of industry-specific best practices, establishment of CII technology development centers, creation of skill development councils and training hubs, and the pioneering initiative of setting up specialized centers of excellence offering a wide spectrum of training interventions, consultancy services, and advisory programs. Taken together, these services aim continually at the expansion of the knowledge base and the development of best practices among Indian enterprises. CII reaches out to society at large through the CII Foundation, which works to facilitate inclusive development by bridging the divide between marginalized communities and donors, in particular corporate donors. The social interventions of the foundation span a wide range of areas like education, livelihood, gender equality, women's empowerment and safety, environment, public health and sanitation, and disaster management. The foundation's activities are implemented in partnership with the government and a large number of partner NGOs. In the areas of corporate governance and affirmative action, CII has drafted voluntary guidelines which have become industry standards. The Affirmative Action Program helps provide new opportunities to thousands of people from underprivileged sections of society. Other path-breaking CII initiatives include India at 75, aligned with the paradigm-shifting vision of the late Professor C.K. Prahalad. Young Indians, to bring Gen Next into the Indian development ambit. Indian Women's Network, for expanding the role of women in corporate India. The Visionary Leaders for Manufacturing program, for developing new techno-managerial expertise, and the CII Family Business Network, to help family businesses evolve. CII has also instituted the National Foundation for Corporate Governance to inculcate corporate values. Pioneering initiatives for industry engagement in environmental sustainability include the institution of Green Building Certification and Green Company Rating, benchmarking excellence. And as a digital outreach platform for industry, CII has launched My CII, an exclusive interactive social media space offering end-to-end knowledge services. This is CII today, an ardent interlocutor for Indian industry, a far-sighted activist for developmental issues, a passionate evangelist for global competitiveness, a knowledge leader, a catalyst for inclusive growth, a partner for industry.
At the core of India's vitality, vibrancy and energy is health, the foundation that keeps India thriving. Since 1996, ThyroCare has been on a mission to make trustworthy and affordable diagnostic services accessible to patients, doctors, polyclinics, diagnostic laboratories, hospitals, the government, and medical and health tech platforms across India. Our reach is unparalleled. With 29 state-of-the-art labs, over 7,500 franchisees covering 570 districts, and thousands of last-mile executives and blood collection technicians, we are ensuring that anyone, anywhere in India should be able to rely on us for quality healthcare. Every day, in thousands of homes across India, a ThyroCare technician pays a visit, starting a journey of health and care. We are very serious about our commitment of being on time to deliver an excellent customer experience. We have a 98% on-time sample collection rate. Once collected, each sample begins its crucial journey. In our temperature-controlled logistics, we preserve the integrity of every sample, ensuring safe transport to our labs. Our labs are where the magic happens. Up to 95% of all samples we receive are processed in NABL accredited laboratories, where precision meets technology. Each sample is treated with the utmost care, reflecting our dedication to healthcare excellence.
We started our journey in 1996. Now, we're proud to say that we are at the forefront of diagnostics and testing. Precision and trust define our work. Our commitment is reflected in our high standard and our certification like ISO, NABL, and CAP. Our state-of-the-art technologies like CLIA, LCMS, ICP-MS, histopathology, and real-time PCR set us apart in India's healthcare landscape. We're constantly pushing the boundaries in diagnostics. Our commitment to adopting the latest technologies and customizing healthcare solutions is what makes us stand out in meeting India's healthcare needs.
98% of our reports are released within 6 hours of sample reaching the lab. Our rigorous process involving inspection of our fully automated machines, stringent quality control measures, double rechecking of doctors' trust. Accurate and reliable.
Our pursuit of excellence drives us to adopt the latest in diagnostics. We're not just keeping up. Expanding our reach globally. Arogyam is a popular preventive care brand having a range of packages at different price points, loaded with crucial parameters for a full body health checkup. Chanch is our newly launched brand that contains specialized doctor curated packages targeted towards specific health concerns such as heart health, diabetes, cancer, women's reproductive health, thyroid, PCOD, skin and hair problems. Check is a brand that provides 360-degree care check for every phase of women's life with an extensive range of packages for women's reproductive health issues.
Our strength lies in our people. Each employee plays a pivotal role in Thyrocare's journey by working endlessly towards making India healthier. Their passion and commitment drive Thyrocare's mission and vision, making a substantial difference in the lives of millions across India. Join us on this journey of trust, innovation and care. Thyrocare is your trusted partner in health every step of the way. Together, we are making India healthier.
In 1895, when modern engineering was just beginning its journey in India, 5 engineering companies came together to form the Engineering and Iron Trades Association in Kolkata. When the first Indian steel plant started production, the EITA evolved into the Indian Engineering Association. Successfully steering Indian industry after independence, it combined with the Engineering Association of India in a historic merger in 1974 to form the Association of Indian Engineering Industry, shifting its base from Kolkata to the capital city, New Delhi. AIEI was rechristened the Confederation of Engineering Industry in 1986, and in 1992 it took on its current name, the Confederation of Indian Industry, or CII. Always ahead of the curve, CII has since then adeptly navigated industry through the era of economic liberalization and globalization. Today, CII represents a large number of enterprises from private as well as public sectors, including SMEs and MNCs. National, regional, and sectoral industry associations find a platform in their affiliation with CII. CII is the voice of Indian industry. As a nodal point for industry, nationally and globally, CII represents all sectors: manufacturing, infrastructure, services, and agri. It reaches out to a broad base of member companies and indirect members through a geographically diversified network of offices in India and overseas. Through constant realignment with the new challenges being faced by business and industry, proactive interventions in volatile times, the ability to build synergies and create stepping stones, and through intellectually sound change management capabilities, CII has retained its relevance and its premier position in India's business landscape. CII services rest on four broad pillars: policy advocacy and international business development services, developing competitiveness solutions, and connecting with society. For policy advocacy, CII focuses on the creation of a facilitative environment for Indian industry to constantly strengthen its role in national development. CII partners with the central government and state governments in drafting and implementing policies for inclusive and sustainable growth. Drawing on the collective experience of its large member base in the form of expert councils, committees, and task forces, CII brings formidable perspectives for evolving solutions to complex issues. In the area of international business development, CII facilitates access to enormous domestic and international business opportunities by organizing business fairs, conferences and seminars, buyer-seller meets, and trade and business missions. Landmark events in this area include the IETF, XCon, Auto Expo, IMME, IREE, and Agrotech, to name just a few. Every year, CII organizes intellectual forums in India and overseas, including the Indian delegation to Davos. CII plays a key role in creating international business opportunities by facilitating access to overseas markets, showcasing India's capabilities through trade fairs, creating B2B and B2G platforms, and engaging with MOU partners and international institutions across the world. CII works with the Indian government, including Ministries of External Affairs and Commerce and Industry, to develop strategies for trade, investment, technology transfer, and joint ventures. It enjoys high level of interaction with international government leaders, academic institutions, and embassies, crafting a multi-dimensional agenda to deepen Indian industry's overseas footprint. In the competitiveness arena, CII assumed the mantle of lead catalyst in helping Indian companies to face the challenges of globalization and competitiveness. Establishing the National Committee for Quality as early as 1986, it has emerged today as a leader in competitiveness solutions for firms. CII's pioneering cluster format for shared learning is a unique platform for MSMEs seeking to drive success. Adoption of industry-specific best practices, establishment of CII technology development centers, creation of skill development councils and training hubs, and the pioneering initiative of setting up specialized centers of excellence offering a wide spectrum of training interventions, consultancy services, and advisory programs. Taken together, these services aim continually at the expansion of the knowledge base and the development of best practices among Indian enterprises. CII reaches out to society at large through the CII Foundation, which works to facilitate inclusive development by bridging the divide between marginalized communities and donors, in particular corporate donors. The social interventions of the Foundation span a wide range of areas like education, livelihood, gender equality, women's empowerment and safety, environment, public health and sanitation, and disaster management. The Foundation's activities are implemented in partnership with the government and a large number of partner NGOs. In the areas of corporate governance and affirmative action, CII has drafted voluntary guidelines which have become industry standards. The Affirmative Action Program helps provide new opportunities to thousands of people from underprivileged sections of society. Other path-breaking CII initiatives include India at 75, aligned with the paradigm-shifting vision of the late Professor C.K. Prahalad. Young Indians, to bring Gen Next into the Indian development ambit. Indian Women's Network, for expanding the role of women in corporate India. The Visionary Leaders for Manufacturing program for developing new techno-managerial expertise, and the CII Family Business Network to help family businesses evolve. CII has also instituted the National Foundation for Corporate Governance to inculcate corporate values. Pioneering initiatives for industry engagement in environmental sustainability include the institution of Green Building Certification and Green Company Rating, benchmarking excellence. And as a digital outreach platform for industry, CII has launched My CII, an exclusive interactive social media space offering end-to-end knowledge services. This is CII today, an ardent interlocutor for Indian industry, a far-sighted activist for developmental issues, a passionate evangelist for global competitiveness, a knowledge leader, a catalyst for inclusive growth, a partner for industry.
May I request everyone to please take your seats? We will start with session number 5 for today. Please settle down. Good evening, everyone, and welcome back. The session is on National Health Exchange and Digital Health Accreditation Standards. Our speakers will be here shortly. Request you to please settle down in your seats. The session of the National Health Exchange and the Digital Health Accreditation Standards explores how these frameworks are transforming healthcare. The session will provide valuable perspectives on improving healthcare delivery, fostering trust in digital solutions, and driving innovation for a more efficient and secure healthcare future. May I invite the panelists to join us on stage? Dr. Nain Shah, Founder and Managing Director, Paramount Health Services and Insurance TPA Private Limited. Dr. Abhijit Ghosh, Chief Medical Officer and Director, Volo Health TPA. Mr. Ganesh Kumar, Director, Provider Business, IHX Private Limited. Mr. Vishwanath Swaroop, Chief Operating Officer, Bharat Serums and Vaccines. Mr. Jigs Barasara, Founder and Chief Executive Officer, Alpha MD, and the moderator for the session, Dr. Manoj Gandhi, Secretary for the Bombay Nursing Homes Association and Director, Dr. Gandhi's Nursing Home Private Limited. A big round of applause to our esteemed panelists. Over to you, Dr. Gandhi.
Good evening, everybody. We'll start our session on NHCX. As everybody knows that NHCX is a National Health Claim Exchange, which the government of India and the insurance sector is pushing across to the hospitals to adopt for better management of the patients. We have with us the esteemed panel, whom most of them I know personally also. And without wasting much time, I would like to start with Dr. Nayan Shah, who will give us a brief on what is NHCX, will it work, how do the hospitals need to comply, and how do the digital data for the future of insurance be managed. So 3-4 questions. We begin with Dr. Nayan Shah.
Good evening, everyone. Thank you, Manoj Bhai, for inviting me to this August gathering. National Health Claims Exchange is one of the ambitious project of Government of India and National Health Authority. NHA is actively doing this, and the idea is that if we are going digital in every era or every vertical in our country, then why not in healthcare? So in NHCX, the patient journey in insurance industry or whenever insurance claim has to happen, then the patient goes to the hospital. Hospital sends a pre-authorization request to either a TPA or an insurance company if they are doing it in-house. Then hospitals are informed by TPA or this insurance companies who are doing it in-house that yes, we are approving, or if we have any questions regarding treatment. So then to and fro exchange of information happens. This is the first level of pre-authorization. Second level is if there are any additional money required or additional info required, then that exchange takes place. And third is the final discharge time. So what was happening and what industry saw that there were a lot of delays happening, and the regulator also had lot of grievances coming to them that either insurer is not working properly or TPA is not working properly or hospital is delaying the sending of the request, etc., etc. So IRDA and National Health Authority decided to monitor all this. In Ayushman Bharat, they had already created a platform. Ayushman Bharat was mainly package deals, and they had created a flow process. They wanted to put this flow process for insurance industry as well. So initial work started on this, but it had lot of pain points for hospital, for insurance companies, and for TPAs as well. So there were a lot of deliberations which went on. It has taken 1.5 to almost 2 years now that this thing has started, but it is now falling in place. Initially, they started with retail policies, individual policies, but they did not have any wherewithal for group policies. So now they have come out with corrections and corrections in the flow process. They have also reduced the pain points for the hospitals. For example, hospital has to just create or ask the patient to create a ABA-ID and then go on to portal as they are doing it today. And the rest will be done by the TPA or the insurance companies. So there are a lot of new changes coming up. In next 10 to 15 days, another workshop is going to happen in Delhi, where all the stakeholders will be asked and the flow process will be described and demonstrated. Idea is that government wants to know what is happening in the country where. For example, in one state there is a pocket where there are a lot of malaria cases coming or dengue cases coming. Then they want to take proactive measures to reach out to those areas and give some kind of assistance in healthcare. Same thing, what they also want to do is they want to monitor what is happening, and eventually we in India have adopted SNOMED as our technology partner or so-called uh, partner for instead of ICD, we are going towards SNOMED. That is the government decision. So a lot of hospitals will have to change or put this into their HMIS and give proper information. Today, what is happening in India is that we don't know how many hospitals are there. There is no finite number that India has so many hospitals. So now with digital era coming in, government wants to have good statistics, proper statistics, and what is happening where. What kind of medicines are being used or are being abused. All this they want to see. So tomorrow, today, the NHCX or National Health Claims Exchange will act as a postman. So whatever provider uploads will be relayed to the TPA or to the in-house insurance company. And TPA or in-house insurance company will convey the decision which will go back to the hospital. But tomorrow, this platform will digitize everything, will have proper analytics going on. They will understand almost everything, and then this analytics can help in nations healthcare in a big way. Sorry, I took a long time,
No, you're
but
fine.
yeah.
Anyway, thank you, Dr. Nayan Shah, for this elaboration in how NH is going to go forward. I move on to Mr. Ganesh. Uh, he's been handling the IHX portal, and I would like to ask him what are the key technological barriers to achieve seamless interoperability across various healthcare providers and insurance? How do you standardize the data, and what application programming integration would you achieve?
Great. So thank you, Dr. Gandhi, for the opportunity. Privileged to share the podium with you guys. So Dr. Nayan has tried to bridge what NHCX is going to do or the impact it will bring into payers' life, providers' life, and even the patients at the end of the day. I just would like to step back and draw parallel with the other sectors, right? So when you talk about NHCX, the way UPI has changed our lives, right, in the financial sector, that's what the NHCX would bring in. While doing so, UPI, I would say rather it was a simpler way to solve it because IMPS was there as a base. But when you compare with healthcare, right, there's no base out there and it's difficult, right? So there are a lot of permutation combinations out there in healthcare versus a financial system. You could adopt it very easily, and there was Geo coming in with low internet, and then there was a demonetization which helped UPI to adopt. That is one of the challenge which we will see in NHCX because there's a lot of combinations here. There are 32 plus payers, insurance plus TPA. And there are thousands of hospitals wherein the standardization is missing. That's what NHCX is trying to bring in. Now, to answer your question, Dr. Gandhi, if you see our current technology, which is highly adopted in any hospital to solve their in-house problem, is HIS. right? Or to run the show. If you see, there are 400 plus companies, every corner, the HIS is different. There's no standard platform. So what NHCX would impact is how do we standardize the data internally in the hospital itself? That was the first question to be answered. Second, is the HIS companies going to help the providers to meet the HL7, FHIR, SNOMED, the way Dr. Shah mentioned? Will they be able to bring that and bridge it for the hospitals? At what cost? That is again a bigger question the providers will ask, that is it going to take a higher investment to run that entire show on their own, or rather than going for an aggregator like IHX or other 2 3 players out there? So I hope I could answer your question.
Yeah. Now, here I would like to add that when the cost implications come into play, all these things like NABH, NHCX, one by one things are coming onto the hospitals, and the costings of the hospitals are increasing by leaps and bounds. Ultimately, that is going to fall on the patients also. So there is a difference in how all these bodies can approach a major corporate hospital and a smaller hospital. So the costings have to vary between the two ends. It cannot be a copy paste from what one is being adopted for a major corporate hospital to a smaller hospital. So the systems have to be in place. In fact, HIMS at a smaller hospital, even in urban areas like Bombay, is difficult. Most of them don't have it in place also. So you need to have an HIMS which is very economical for a smaller hospital than what is applicable for a major hospital. And then the integration would not be difficult. So you have few innovations, few softwares where you can, modify those softwares at a lower cost, have an HMS in place for the smaller hospitals, and then NHCX integration would not be difficult. As far as NHCX integration is considered, ultimately, as Dr. Nayan Shah also said, that there is an initial level of pre-authorization, then there is an initial approval, then there is a final approval, and then there is the payment. So I don't think the softwares, it is difficult that these 3 4 levels cannot be integrated in any of the software which is used in any of the hospitals. So it's not difficult, but the costings for using all these things has to come down. Now I move on to Dr. Abhijit Ghosh, that will NHCX reduce the claim processing time eventually? What will it be monitored in real time? And the most important thing is, will it be like Ola Ubers, where there is only a support, or will there be a communication with the hospitals eventually if the NHCX is in place? Because communication on both sides has to be important, which currently is quite lacking as far as the providers are concerned.
Now, how does the request come? It's a scan part of the PWOT thing. Now, the PWOT form in Excel has certain pages along with the policy. Many of the TPA just scan the policy documents along with KYC and all. So it becomes a very heavy email. 10 MB, 20 MB, 30 MB, and so on. Many times, data loss also happens because the email can be very huge. And this all starts the issue, like whether the email has been sent or not. So the customer is not aware, the insurance company is not aware, team is not aware, hospital is not aware. All they know is email has been sent. Similarly, if you don't have an answer, then how will you communicate? So the broker communication properly in the form of NHCS, we are on the opinion that at least that part of the problem is solved because everything is getting exchanged to the broker. In the 6.8, we are in the scan office, but coming on a portal in phase 2, as more and more EHR or HR, this all happens there, like digitally, at least data is coming in the format that is needed, you have proper consent. Integration of this portal with the insurance company or legal system means that many things can be done automatically. So again, go back to the policy, email has some entries. Now the second part is somebody has to key the email details into the claim process software. Again, the verification happen. How? Somebody would have forwarded the email. Somebody would have opened the email but forwarded to the delivery and so on. And that also results in lack of communication. So the hospital team, when we get response, customer patient will keep on calling the call center and say, email has been sent, where is the approval, and so on. But if you have a portal, you do direct communication, so the escalation can happen. The moment a claim gets notified in the software of the claim processing system, then it becomes super easy because insurance companies and TPAs have very analytical checks and balances to know the speed, the duration, the process of a case once it comes. And there are handled alerts to this. So if it happens, obviously all these issues of communication, whether it is approved, rejected query, if query, what is the result of the query, if approved, how much amount is approved, everything can come as a case study to the it can be given to the hospital in the form of voter access, and the person managing that can get to know what is the final outcome of the case. So in terms of that. Now the second question was that will it reduce the time? Absolutely. Because when we have discussed so many processes, I think now you also can understand how we reduce time. Time to key and make the email to be presented to the center. That is the first reduction in our time. Second reduction in our time is to identify the email as served, whether it is a single email or multiple. So all those type of identification is reduced. Third and most important is the data because this way auto identification. So I believe it will mark a significant reduction in the time to manage a case, will prevent misuse, thus improving the communication channel, the outcome of the case to all the stakeholders, hospitals, customer, relatives, broker, TPA, and so on. And at the end, as you know, the regulator already has put time restrictions, 1 hour for initial and 3 hours for discharge. So all this coming in the picture, I'm sure that as an industry, we will be able to meet those aggressive timelines in a proper way for a better customer outcome.
I agree with Dr. Abhijit that I've been using at my hospital at least most of the portals which are now very user friendly. If all that is now integrated in NHCX, in fact, I've been associated with Paramount TPA for last 20 years almost, and they have got various insurance companies' data of the patients. So uploading of the documents saves definitely a lot of time for the hospitals also. Even the IHX portal, which we have been using. So most of the portals are pretty streamlined. If all those things get integrated in NHCX in a better way, then the time for everybody will decrease. The only hitch over here is that when the data is already uploaded and the replies are not going to the hospital due to technical glitches of the portal, then there is a lot of time wastage. That is number one. And number two, that in spite of uploading everything properly, repeated unnecessary queries being raised. So if we say that the portals are good enough, agreed, it is good, but then the repeated queries for the same things should not be raised, and that will definitely reduce the hospital time also. Third thing, when there is a query or when there is a verification, the TAT time is 24 hours to 48 hours. Now, you may have a patient who needs to be discharged in a day or two. If there is a query, how can the TAT time be 48 hours? It cannot be. With the modern medicines, with the patient's expectation, a lot of patients are getting discharged faster, especially the surgical patients. So my take over here is that if we are going to have this integration, then this wastage of time for all ends should be reduced appreciably. Obviously, with the portal in use, it does make a lot of difference for the hospitals. Second thing, the pre-authorization form, it should be completely digital. We are filling the pre-authorization form and then we are again filling the same data in the digital format. So with this integration, if the digital format of pre-authorization is accepted in the NHCX platform for all the hospitals, life will become smoother for everybody. Now I move on to my next question to Mr. Vishwanath. What will be the implication on the quality of care with the NHCX? And how digital and big data capabilities can help with personalized, customized healthcare and improve outcomes?
Sure. So I'll break this into two parts, right? One, I think we've talked a lot about how this will reduce time. Of course, it will reduce time because less amount of data input would be required. The accuracy of the data will improve. Those points have been made. But I think there are comparisons to UPI and things like those. But I think the differences are very stark. When you talk about UPI, you had the government coming in and saying, I'm going to provide this for free. Yeah, I think a couple of days ago only we read medical inflation is running at 14%. Adding more cost to hospitals or to the entire process to gain time is not really a value proposition today that our system can take. Now, having said that, I think over a period of time, there will be low cost solutions which will be required to make this work. It's not just going to be a plug and play or a simple UPI equivalent kind of thing. And if UPI transaction fails or something, nobody dies, right? We are talking about life and death situations here, right? So I think there are parallels, but I think this has to be a much more different level of sensitivity, privacy, etc. Now, bring in privacy. I think a lot of points have been made about the number of times that the data has to be entered. We are talking about very sensitive, personalized patient data. That data is getting into the hands of about 4 or 5 individuals. Now, I don't want to make a statement around the ethical point around that, but I think as soon as we can reduce the human touch points in the system, by default you will get a benefit on the privacy side because the data can be encrypted, etc., etc. Having said that, you do open up to mass attacks, etc., from that angle. I think these are very, very important things to consider as we're thinking about this exchange. I think the mid to longer term impact of this is much bigger than just saving time. I think, quite frankly, this will be a quick win if it is done. Post that, I think when you start, I think the point was made around, the government can get a sense of what outbreak is happening where. I come from a pharma background, so of course, for us, it will be very important to understand if there is an outbreak happening and we need to ensure enough supplies of medicines in that area, right? So I think
getting that transparency throughout the system will help all players involved in this ecosystem. So that's very, very important. Secondly, I think when we start talking about, I mean, we are the hub for big data, etc., etc. But I think the other day we were talking about, computing capacity. So if I compare India as a country versus Facebook, Facebook has anywhere between half a million, and I could be off by a order of magnitude, GPU capacity. As India, we have only, and I'm comparing a company to a country. Please be mindful of that. Anywhere between 20 to 50,000 GPUs. So we have a long way to go in terms of building our capability there. We are on the right track, and I am a eternal optimist there. But having said that, when you pull so much data in, what are you going to do with this data? I think as a population, we need to start having more predictive analytics, more predictive interventions by the government. We are all debating around insurance, etc. But let's be clear today, and if you take out government insurance, the health insurance penetration is still less than 10% in India. So what are we talking about? We are talking about optimizing something for less than 10% of the population. Yes, it's okay. We need to start somewhere. I get that. But I think it's really, we should not get lost in the mid to short term gains. We need to have an eye on how this will enable the long term benefit for a majority of our population. So I think uh, I'm both saying, it's difficult to implement, it'll have implications, but where we are at a GDP per capita, this is probably the right time for our country to undertake this exercise. And we should invest both public and private resources around this, because the gains are not just short term and medium term, the gains are very, very good in the long term, right? And I think that's the point I wanted to make around this.
Thank you, Vishwanath. When NABH had come into picture, there was a big driving force by the government that we would get better rates, the hospitals would get better flow of patients. But I feel nothing like this happened actually. Similarly, in NHCX, if we think that our clinical outcomes and patient safety should improve with the data being protected, then we all should move in that direction, which obviously is going to be a long-term prospect, that finally our aim should be the patient-centric aim, which is going to be his data protection and his cure. I move on to Mr. Jigs. What type of health assessment framework are being developed by countries to standardize accreditations? And what is the change in role of safety officers in the hospital, and how all this standardization will help the hospitals? Basically, I am going to ask everything related to hospital because we look at patients. So if anything is in process, then ultimately it has to be patient centric.
No, absolutely. In fact, we all spoke about health exchange, data exchange, and one of the biggest piece, the missing piece, we always forget the patient. And patient centricity becomes a very, very important part. With the patient centricity and patient safety, when it comes to hospital, comes how do you manage their data. The data is very, very important. We all know GDPR, HIPAA, the new GDPR coming from the government, but we think that if we are GDPR compliant as a platform, or if we are HIPAA compliant as a platform, we have achieved and we are protected. But no, there is something called as digital health assessment framework, which runs with five basic principles. One is clinical safety. Second is technical security. Third is interoperability, data protection, and then usability and accessibility. When it comes to GDPR, HIPAA, DPDP Act, it is all about technical security, data protection, but we forget the clinical safety, we forget the usability and accessibility, we forget the interoperability. Now, with the NHCX coming in, interoperability is going to be a very big part. That is where we need to set standards. Because if you have standards set for hospitals in terms of the assessment framework for digital health, it is very simple to assess. If there's a new platform which you are looking at, or if you are looking at your older platform which has come to renewal, it will be very easy to access that, assess that, okay, they are into the framework, it is good to go, and it is very easy to then say that, okay, are we going on the same platform, we need to change. So these principles, which are basic principles of digital health, when it comes to creating standardized framework, I think is very, very important. And with the clinical safety coming in, the clinical safety officer of the hospital also has a bigger role to play when it comes to the data side of the picture. Because now, if data is going to gain importance, the clinical safety officer also has a role, along with the data protection officer, to make sure that it is clinically safe. The platforms are there to help them, get into the NNCX, not isolate them.
As far as standardization is concerned, this I would like to ask Dr. Nayan Shah that how will NHCX help in standardization of the hospital? Because even in a place like Bombay, it is difficult to standardize hospitals. And if you go to places beyond, the center of Mumbai, then it is even more difficult. So standardization, if we are expecting that the hospitals have to be standardized, then NSCS will probably have to integrate with a standardizing agency like NABH so that the level of standards are similar in most of the hospitals.
I can say that there are two kinds of standardization which are likely to happen. One is standardization of documents or standardization of how you write your prescription or how you write your notes in the hospital or how you standardize bill or how you standardize the investigations reports, etc., etc. So if these documents are standardized, analytics becomes very easy. So this is first standardization which ideally should happen. Government is trying some sporadic efforts, but unfortunately in our country, health is not a federal subject. It is a state subject. And that is where we are missing out. There is no standardization coming in. Before some time, there was a request for a health regulator, but this has not moved ahead. But eventually, some kind of regulations will come in. So standardization of documents is uh, can happen very fast. Insurance industry, where we hear that at least 50 to 60% of occupancy rate of hospitals is through insured patients, then insurance industry can come out with some kind of standardized documents in consultation with CII or FICI or hospital federation associations, etc., etc. But this kind of standardization is a must. Second thing which needs to be standardized is standardized clinical protocols. And this standardization of clinical protocols is not an easy subject. Uh, as insurance industry, we see, and I can say this that after a fracture tibia fibula, plaster was done, but the surgeon was visiting the patient 4 times a day when he was in the hospital. This was picked up by the data analytics. Now, all these things will happen, and eventually, insurance industry and government will come out with certain basic clinical protocols. And if there are any deviations on those protocols, then reasons will have to be given, justifiable, that okay, there were some complications or something happened, some secondary infection took place and length of stay increased. All those things will eventually come. This is already there in the world. We don't have it here, but we are going towards that. So transparency in all the standards will have to come, but I don't know how long it will take.
Okay. Dr. Abhijit, the communication with hospitals, we need to touch upon this very delicate point that the insurance industry, the TPAs, need to have proper channel of communication opened with hospitals. Currently, most of the hospitals find very difficult to get across certain things when there is a problem. Hospitals basically need only three open communication channels, and one is related to, whether it is empanelment, provider network, or accepting the tariff. Second is during the cashless processing, and third is during the payment processing. So if these three escalation metrics are pretty well defined in the NHCX portal for each insurance company or TPA, then eventually the entire process becomes quite easy.
is it justified or unjustified? Because majority of times what you see, especially in the mid-range and the smaller nursing home, there's only one staff which deals with many things. And they may not be aware what is the question. And due to Chinese whispers, indirect message goes to the owner, due to which lot of issues happen. And same with the insurance company. When you have limited skill sets, many times they cannot understand that why the service is being needed. So that is more of a discipline. Unless there is a standard guideline, this interpretation wrong questioning is or questions being asked not being addressed properly. So that may still be there, but will have, that is not going to do anything with the concept of NHCX. Because the concept of NHCX is number one, from email move to portal. Number two, from portal move to standard document so that rework doesn't need to be done. Number three, less and less data loss to happen. So more data privacy, more ownership of the data because once it goes to API, it is more secure. And the third part is obviously at the end whether what payment is being done. So proper dashboards being formed so that whatever payment is released, whether my UPR numbers are being captured properly, detection reasons being absolutely to the point being provided. And with now the way the digitalization is happening, more and more clarity is coming because what kind of detection happens in a insurance case? Majority are related to non-medical expenses, which with good data digitalization partner that is not automated, and the other part is policy related. Now that also many of the insurance companies and TPS have taken a step forward in using NLPs. They are trying to standardize those deductions. For example, four is the most common standard deduction, so which is being followed. That is more or less automated in majority of the organizations. Other is related to certificates and all. So focus goes back to what was the coding done. India, unfortunately, is still now dependent on coding being done at the insurance company or TPS side. Now, if the coding is being done from the initiating part, that is the hospital or clinic or nursing home, I think 50, 60 or 70% of the problem will get addressed because the hospital will know what ICD or what SOMAT code I have code. And this is when all the classification of the rate, tagging, and all can happen. The problem happens when the insurance company starts coding or the teacher starts coding. And in the initial phase, for example, you get what fever, later on it goes to be malaria or PUO or typhoid. So the cost may vary. So few of the, I would say, inputs have to be at the hospital side so that when these two merge, the insurance company and the hospital, the more and more clarity can be given in terms of proper communication about the case, its end result, and reason for that stay. And once that happens, I think it will be win again for all of us.
Thank you, Abhijit. We've got good 6 minutes to go. So I will divide 2 minutes to three speakers. First, I would like to ask Mr. Ganesh, who is having his IHX portal, if he can quickly summarize in 2, 3 minutes the entire discussion and how his IHX portal is moving towards NHCX.
Great, thanks, Dr. Gandhi. Uh, see, everyone touched upon what NH6 would do, the transparency, reliability, accuracy of data, TAT improvements, and even the interportability, right? So I would like to summarize saying that we would we would have a day wherein everything is transforming or transferring. The data is transferring completely digital. So touch upon one of the point raised was, can pre-auth be digital? Right? So your the desk DPA desk person writes a lot of things on behalf of patient, and that document goes to the payer. They also digitize it and then come back. Right? Can we digitize that at the very first place is a question which NHCX would or would not. We need to see will it answer. I would like to add a point here is that it may look that okay, there is a push from the NHA IRDA to go live, but there's a lot of resistance from the hospital. There's a resistance from the users level to transition to the new technology. Moreover, there are, because we have done being IHX as an aggregator for provider and payer, we would have done almost 20 plus hospitals doing NHCX transaction as a pilot. What we've realized is the biggest challenge is ABHA linking. Can ABHA linking be made easier? As Dr. Nayan said that earlier the challenge was only retail was available, group was not available. Now that has been covered. Similarly, can we make ABHA linking easier for all the patients, right? We see the data on LinkedIn saying that 60 crore people have ABHA linking, but on ground, the people who are opting for insurance in a hospital, the ABHA linking is still missing. Awareness of ABHA. There are digital incentives to it, but I think it doesn't excite providers at this point in time because there's a lot of awareness gap. So a long way to go. I believe we're just at a very infant stage of bringing a digital revolution in healthcare. The end impact is both payer provider would end up spending less to run this show versus what they are doing now in in line to ensure that patient experience is taken care of, better visibility. So I would like to, so just to add one more point, sorry, you touched upon what role IHX plays, right? So we've been in this business for 3 years. We provide solutions to payers, we provide solutions to providers as well. What do we do is we basically bring in technology, your AI, ML, the digital transaction platform in between the payer and provider, which allows them to have maximum possible digital record available to talk to each other. One of it is digital pre-auth, your, I would say, scanning or bill digitization, those things from the both the parties, which allows them to have better visibility of data, their time spent is less. So that's the role we play.
Thank you, Mr. Ganesh. Now, in the end, rather than me summarizing the entire discussion, I would request Dr. Nayan Shah, who's been a pioneer right from 1996 in this entire insurance industry, and I would request him to summarize the entire discussion related to this NHCX platform, how easy it is going to be for hospitals, and how patient-centric it is going to be in terms of their safety and data protection.
I was not expecting this. Uh, but I think we have discussed a lot of stuff on NHCX. We are starting our baby steps as Ganesh was talking about, and a lot of our colleagues also here has they have mentioned a lot of stuff. This is a concept towards getting digital in healthcare, and with government coming into it and transparency coming into it, we'll learn a lot more what is happening, where the money is going, whether the treatment given is appropriate or not. So analytics will throw out a lot of stuff, and let us hope that this experiment becomes successful. I don't see why it should not, but it will have its own pings and difficulties. But I think we are headed towards the right direction, and it will bring a lot of difficulties or initial challenges in provider industry. What we understand is that the providers in India uh, have to graduate to a larger extent. For example, a lot of things will eventually come in. For example, today, all the TPAs and insurance company, they all talk about provider network of say 30,000 hospitals. But each hospital, what kind of surgeries are done? What kind of safety measures are available? What kind of antibiotic policy they are having? All this are going to be asked to providers in very near future, and data exchange also will become very crucial. Clinical protocols will have to come in. Lot of tertiary care hospitals have their protocols, but are they advertised? Are they shared with payers? See, all this are the things which are going to come in, and we as a healthcare industry will have to be ready for these changes. And the faster we move towards it, the end customer is going to be benefited in a much better way. So I think we better buck up ourselves and be ready for the changes which are going to come in. Digital era has already come. India is in the forefront of digital era, and a lot of things are going to change because of this. The speed will become important. Speed will become faster, and eventually the consumer will be happier. Will have transparency when they go to provider. They will know what is going to happen to them. There will be healthcare management guidelines which will be given to them if they are getting hospitalized. So a lot of changes are likely to come in, and this is going to be driven by NHA and NHCX. I think this is what I would like to say.
Thank you, Dr. Nayan Shah. We are winding up our session on time, and I thank all my panelists to be pertaining to their time for what they spoke. And there has been a lot of clarity in how the government and NSCS is going to progress towards digitization of healthcare records. But ultimately, as a provider, I would have to say only one thing, that the patient-centric approach has to be there. This is how I would like to sum up the entire discussion over here. And thank you all the panelists.
Thank you to our esteemed panel, and thank you, Dr. Gandhi. May I request you to just step forward for a group photo? As a token of our gratitude and appreciation on behalf of CII, may I request that Dr. Gandhi hand over a thank you letter each to our panelists? And Mr. Vishwanath Swaroop to please do the honors and hand over a letter to Dr. Gandhi. A big round of applause, please, to our esteemed panel. Thank you so much. The evening is not over yet, so please remain seated. We now have a power-packed CEOs panel discussion. The session will see industry leaders from the healthcare sector coming together to address the most pressing challenges and opportunities in modern healthcare. This high-level discussion will focus on strategic insights, innovative solutions, and best practices for driving organizational success in a rapidly evolving landscape. Ladies and gentlemen, please join me in welcoming this power-packed and exclusive healthcare CEOs panel, inviting on stage Dr. Parag Rindani, Chairman CII Western Region Subcommittee on Healthcare and CEO of Wokhad Hospitals, Padma Shri Dr. Ramakant Deshpande, Executive Chairman, Asian Cancer Institute, Kambala Hill Hospital, Mr. Behram Khodaiji, Group Chief Executive Officer of the Grant Medical Foundation, Ruby Hall Clinic, Dr. Sameer Kulkarni, Chief Executive Officer, Dr. L.H. Hiranandani Hospital, Lieutenant Colonel Dr. L.C. Verma, Chief Executive Officer, Godrej Memorial Hospital, Dr. Anand Pandhare, Trustee of the Dr. Hegdevar Hospital, Dr. Baba Saheb Ambedkar Vaidyakiya Pratishthan, Dr. Ravindra Karanjekar, Group Chief Executive Officer, Kiran Hospital. And the moderator for the session is Mr. Joy Chakrabarti, Chairman of CII Hospital Tech 2024 and COO of the PDG Hinduja National Hospital and Medical Research Center. A big round of applause, please.
Good evening, and once again, at the fag end of the day, we have the most exciting session. We have the leaders, the seniors, the CEOs of this industry who are participating in a very, I must say, interesting session where we'll have a lot of opportunities to interact with all of you at the end of the session. So the session has been, designed in this way that since today morning we have multiple sessions and tomorrow we are going to have few sessions. So here we are going to take thoughts, we are going to take the feedback, we are going to take responses from the leaders here on some of these areas. As we spoke in the morning, we spoke that why do we need technology, digital health? We need to have all this kind of integrated in our delivery. The reason is we need to create access for our huge population. Many of them don't have access. So how do you create access? And we know a few years back, the government of India introduced that PMJY insurance scheme, which made this healthcare accessible for many. In reality, what is happening, some of you may know, some of you may not know, but there is a lot of expectation, ambitions, as well as in terms of delivery going on in this country. So we are going to ask first to Dr. Karanjekar, who has huge first-hand experience in terms of managing this scheme. And I'm going to ask him that what is your experience about the success of this PMJY from the perspective of making healthcare accessible for the population who are either below the poverty line or maybe just above that.
Thank you, Joy. Thank you, CII, for inviting me here. PMJY at my hospital, that is a Kiran Hospital. I also work for Asian Oncology Institute, Mumbai. Multiple places I work, but my primary experience at Kiran Hospital, which is a 1200 bed hospital, we run the PMJY scheme and we run to the full. In the sense, I have almost 5,000 to 7,000 patients a month in PMJY scheme, where we have taken almost all clusters. And all these clusters we are running profitably. So the PMJY scheme per se, which is being perceived by the at the center Delhi, is a profitable scheme if we run it properly. If you don't run it properly, I don't think you will make the money. The problem in the PMJY scheme is the getting money back. You spend the money, you spend on consumables, you spend on doctors, and government doesn't pay you within 3 months or within 6 months or within 9 months. And so much so that after a period of time, all hospitals come together, protest, there is a strike, and then government releases 300 crore, 400 crore, like that. The once that cycle sets in properly, there is no scheme in the world as good as PMJY. This is the best scheme in the world, and now in government of Maharashtra as well as central government have given it for the 70-year age. Above that, you have 5 lakh rupees medical treatment free available. In Maharashtra, it is available irrespective of your financial status. And a day is not far away. Let me tell you, a day is not far away. Next 2 to 3 years, 80% or 90% of the population of the country will be under the PMJY. And 60% of the good hospitals will be paneling for that. Offhand, let me tell you, today there are so many large hospitals are trying to apply and get empaneled for this. There is a huge rush. It takes months together now to get empaneled. And why? I don't have to do the marketing for my hospital. I don't have to do marketing for my consultants. I don't have to do marketing for any of the things. What patient asks, is this hospital empaneled? Do I get a free treatment for my disease here? And will I be okay? Patient goes home. Today I get patients across Madhya Pradesh, full Madhya Pradesh, Rajasthan, and the border cities of Maharashtra to Surat, where my hospital is. And there is a huge number of patients sitting day in and out there. And all of them feel that if I come to this hospital, I'll get better. Hospital is also good. For them, there is no problem. But the accessibility to the healthcare, as Joy has asked, is so easy now. You have a hospital empaneled here at the corner. Go, show the card, get your pre-approval, get the treatment done. Nobody will ask you a single question. So, from that angle, for a poor patient who was not having the money, or you have to get the debt, going into the debt, borrowing the money to get the medical treatment done for bypass. Today, the number of patients which I treat for oncology, radiotherapy, surgery, medical oncology are almost to the tune of 5,000 to 7,000 a month on daycare and inpatient. Otherwise, they would have found it difficult to lead the life. So, from that angle, it has been a boon to the people who had been taking the treatment. My experience with other hospitals also, who had come to me for all these things, that you have to manage the scheme well. Then you will be profitable. Otherwise, it will be little difficult for you to manage the whole thing. So, PMJY is a boon to the country. It is a basic right for every Indian to have a good health and health treatment available. Government is providing that. As a hospital, we should respond it to that. As a government, they should respond to hospital needs and expectations of payment. That is the main thing.
Yeah. Thank you, Dr. Karanjekar. I think in a very practical way, you have shared that how, though many of us we feel the scheme is not going to help us, but how it can make meaningful contribution to the hospital. So, in one hand, when Dr. Karanjekar spoke, he spoke about the treatment, care, and mostly it is related to curative care part of it. So, I move on to Dr. Deshpande. And the other, if I look at the spectrum, the extreme other end is your preventive health, which can significantly reduce your disease burden or the healthcare expenses. And at the same time, you have pretty much your personalized medicine, that when you have certain particular disease, you can use the personalized medicine and which can contribute. So my question to Dr. Deshpande is, what do you see as a future or even present, and how we are marching towards the future in terms of promoting the preventive and personalized medicine?
Thank you, Joy. Thank you very much for having me here. There is an old saying, a stitch in time saves nine. So everything which is concentrated on treatment is like all those nine stitches, and preventive is basically that one stitch which actually, if it taken to its extreme, can actually save a substantial amount of effort, expenditure, suffering, and improve the overall health of the entire society as such. The purpose of a preventive health efforts is essentially to it goes from absolute prevention, which means that by education of the society, improving their habits, improving their diet, making them aware of the disease, exposures, etc., to actually actively intervening and then finding out what exactly is happening to the people and removing those causative factors from the life, or helping them remove the causative factors. So this is in the broad way just to describe. Now each has one component. So for example, you must understand what are the problems with which the society is entirely affected. Mind you, preventive health efforts are normally done by organizations like the government, by healthcare workers, by associations, and so on and so forth. An individual can actually put those efforts in action, but that is not a societal kind of a preventive health effort. So when a government or when a large organization gets into this kind of an effect, you need to have the data first. What are the common ailments which are there? So there comes the role of a big data analysis. So when you're looking at a big data analysis, why exactly things take place, the way they take place, there also comes a role of artificial intelligence. So you can actually identify that so and so. Now we have about whatever number of states, 28, 29 states, what we have, and centrally administered territories, etc., for the population of approximately 135 crore Indians, maybe 3 crore Bangladeshis, 1 crore Rohingyas, and so on and so forth, to whom we are actually offering healthcare. So all of them, till the time where national register of the citizens comes, our healthcare is being actually distributed with the help of only our Aadhaar card. Like what Dr. Karanjekar said, the PMJ is going to be distributed by this side. So we need to take the same guideline and to identify what are the various types of diseases in every state. So when you realize that these are the things, then you identify what are the various stages at which they are actually identified. Now, from any disease, from whether be it infective, be it degenerative, be it metabolic or malignancy, it takes time to progress into an advanced phase. As the disease advances into an advanced phase, the whatever efforts we put in towards mitigating that particular problem, the returns are actually on a diminishing return, which means that if you prevent that particular thing at a very small cost, you can actually save a lot of money. But whereas if somebody comes with a stage 4 disease, your results are not going to be good, your expenditure is going to be very large. For example, a stage 1 cancer of breast has got a 97% 5-year cure or complete cure kind of a rate. So if you have a preventive kind of a program for these kind of a things, your results are definitely going to be better. Your healthcare budget itself will actually come down. So it makes a financial sense also. So how do we really go about it? You have very nicely devised programs which need to reach the people. So there is a component of healthcare education. That is also equally important. Healthcare education could go through printed media, could go through audiovisual media, could go through school lessons, college lessons, and also the public advertisement through TV or even cinema theaters, etc. Simplest example, the advertisements which come on even on cigarette packets, that smoking is dangerous to life. With all those 80% surface of that, you have got a photograph of a person suffering from cancer. Same way, actually, you can really identify every possible disease and you can try and reduce it. Very small example I will give you. Before 1916, lung cancer was not a common disease in humankind. It's not that it didn't happen, but the incidence was not very high. When the First World War started, simultaneously tobacco came into use in a very large form in America and in developed disease. India did not really have much of a problem at that time. But those days, the cigarettes were rolled by their hands. So, it was quite troublesome, messy, it could smell and all that. This happened during the First World War. So, actually, over a period of in the 1930s, they started identifying that there could be an association. So on and so forth. Very good. The Second World War, which happened in the 1940s, by that time, mechanization had taken root. So you could roll the cigarettes using machines. So millions of cigarettes being rolled out, so the incidence of smoking went up. When the incidence of smoking went up, incidence of cancer went up. So this is exactly how progress in the society also keeps in pace with diseases whichever are there. So education also started. Now, whenever the Surgeon General would advertise for a period of time, 2 years, 3 years, 4 years, incidence of smoking and thereby cancer would come down. And when he stopped that particular thing by pressure of these tobacco companies, the incidence of cancer would go up again. So there's a direct relation between education or a preventive health efforts and the ailment that what you're looking at. Then there are diseases like, there are some cancers which can actually be prevented by simple thing like a vaccination. For example, the human papilloma virus is a cause for about 60% of cancer of cervix. 60%. Mind you, cancer of cervix till few years back, till 5-10 years back, used to be the commonest cancer in a woman with a great suffering, great cost of treatment. And then people realized that HPV is the causative organism, easily controlled or prevented by HPV vaccination. And that actually prompted our finance minister to put that thing into our budget. Just imagine, something which was not even known 20 years back comes into the budget of a nationally a third largest country, the third most powerful country in the world, in the national budget, that they are going to actually incorporate that into your complete yearly budget. So that is the kind of effect preventive methodology of diseases can actually come into. So that the vaccinations are there. So from big data analysis to people's education to organize programs of anti-smoking or vaccination, etc. That is what can happen. Now, next thing what happens is you know that these are the mechanical things which are in your life which are there. But to be forewarned is to be forearmed. Now, Joy beautifully brought out that the genetic reasons. There are certain genetic problems which can actually work as predisposing causes for cancers. So one of the things is, for example, there is abnormality of a gene in women called BRCA1 and BRCA2, which can cause cancer of breast in women in almost 80% till the age of 50, and ovarian cancer in about 40 to 50% by the age of 50. If you identify that during childhood, and there are various guidelines which are there. There could be a family history, and then if you put all these people into a preventive kind of a program. For example, now today, if we get a patient of 35 years or below with a breast cancer, if we get a patient of any age who has got a bilateral cancer, or if you have any patient who has got a family history of at least 3 members with a breast or ovarian or any kind of a cancer, then we test them for BRCA1, BRCA2. There used to be a time when this test used to cost 1,50,000 rupees. Today, you can do this particular thing in some labs in about only 15,000 rupees. Now, everything, as I mentioned, is a cost, is a matter of cost. So almost most of the breast cancer patients today are undergoing these kind of testing, which are genetic predisposition, and there are various malignancies, etc., which you can do that. And same thing goes on for metabolic disorders, so on and so forth. So preventive oncology program today is come here to stay. It will help us improve the overall health of the overall population, reduce our healthcare budget, make our population more healthy, and save us from a lot of suffering. Thank you.
Thank you, Dr. Deshpande, for putting this entire thing in a very nice way and in a systemic manner. And couple of things which are coming out from your talk is the data, the number of population and all, and how it can bring down the cost and involvement of technology. So my two next speakers, one is going to talk on medtech, but before that, I'm going to ask Dr. Samir Kulkarni, CEO of Hiranandani Hospital, that this how do you manage this big data when we have so much of challenge in terms of the data, threat from the data uh, getting lost, leaked, misused, abused, and at the same time maintaining that data. And secondly, how technology can play important role in getting this entire thing gets stitched and deliver what we are looking for.
Yeah. So technology and data analytics have a tremendous from CEO. It has captured every aspect of hospital management, right from marketing to accessibility to the way we analyze things. So the supply chain is managed. Everything is data. Even HR analytics is there where you have a connected manpower, attrition, you have a continue with you. So data is everywhere, technology is everywhere. How to use it is up to us. So filtering the data and understanding what we actually want is most important thing. In terms of marketing, the many variants decisions used was whatever experience was there. We were not very sure whether this is good experience, whether we are ROI or not. But with this digital marketing, we can have a good ROI. We can the accessibility issue is complete and we can reach n number of population, n number of area. We can understand which how many patients are coming from which area, how most of the strategies are. So from that point, it is in terms of service, we patients nowadays performance have how is better and they can give them a form. They can come to hospital for appointment and everything. This everything they can order the drug. So everything is seamless for them. So from that point of view, in terms of supply chain management, we now actually know that we can have doctor procedure is cost wise analysis, right? What kind of same certain different doctors are doing different diagnosis there, different so data analysis does give us idea what kind of what the difference in the process that we doctors are doing and variation also available. It is the how it is the cost. The cost is a major concern. There is a patient that can be done to data analysis, so that is also giving us and it for variation also this is technology like we understand technology gives us human eye is so that is also tremendous advantage. We used to use technology like scan to ancient time we are using it, but nowadays technology is changing a lot and we have to be adaptable to technology. Predictive analytics is one thing that is tremendous. We can understand and predict what will be the outcome and how we can, what are the actionables, what intervention that we can do to change the outcome. So all those things have there is tremendous scope and tremendous possibilities in technology, and we are looking at decisions like this are very important. They help us keep operation related, have in the market, and bring us to the current. So,
Thank you, Dr. Samir. And I move on to our Dr. Colonel Varma. And for you specifically, it is the medtech. We aspire to reach a level. We are in a certain position. In other hand, we have Atmanirbhar Bharat. On the other hand, we have dependency on importing medical technologies. So when we have so much of dynamics going on, what do you think is the future of medtech devices and how it can contribute to achieve our aspiration? And if you can add part of artificial intelligence, its contribution too.
Good evening, everyone. At the outset, I place on the highest record my sincere thanks and compliments to CII and the Western region and the organizers for putting up such a splendid show. It's a privilege It's a privilege to be part of this panel discussion. My earlier speakers have already spoken about so many applications of the newer age technologies. Sir, I'll start adding something to what Dr. Ramakant had said. In preventive healthcare technology, especially the AI-based platforms, if we can devise, we can curate, I think they are going to revolutionize the preventive healthcare. At the Godrej, in collaboration with the IITB Haystack Analytics, that is the startup ventured at IITB, last year we launched preventive healthcare that is based on whole exome sequencing. So that is revolutionary because that is quite comprehensive, that can handle up to 150 genetic disorders and genomic related disorders, also the metabolic disorders, NCDs, hypertension, cardiac, thyroid, pancreas, diabetes, uh, and the mental issues, along with the some sort of physical and strain and sprain of the muscles. We have got very good response to this, and that is based on some bioinformatics panel on ACMG guidelines. And this is something like I really wanted to share what Sir has mentioned. There are going to be so many applications of cutting edge technologies and innovations, AI, machine learning, deep learning, robotics, 3D printing, and genome based sequencing. These are not the buzzwords, they are going to be reality. And healthcare industry, I think, taking steady stride towards this. And only issue, if I may bring out, that is the adoption rate, because it comes with the gestation phase. So if we can reduce the gestation phase, if we can be more practical in adopting these devices, especially the wearable devices and the remote monitoring devices, then I think it is going to revolutionize the preventive healthcare as well as the curative healthcare. But again, it is a two-way sword. So I am taking it forward what Dr. Sameer has said. It is again the two-way sword, because this data is the new oil. And I'm remembering my IIM Ahmedabad's professor's one line: in the God we trust, everybody must bring data. So the data is coming, but how to apply it? Because it comes with ethical consideration. The judiciary has already taken a stand on this right to privacy, that includes data also, and the government has recently come up with the proposal, the DPDP Act, and we have to be very careful about using these data. We have to maintain the privacy of the individuals who are dependent on us, and we have to use data for ethical consideration and for the interest of the society and for the industry.
Thank you, Colonel Varma, and you touched upon the privacy, data, and the technology bit of it, which is very important. But from there, I'll completely switch on to the other area, probably, which is very much in focus as of now, is that how do you ensure sustainability? How do you ensure green, and how do you make your organization sustainable for future? So with that, I move on to my next panelist, Dr. Behram Khodaiji, and I'm going to ask him that our PM has a goal of making net zero by 2070. I'm not sure whether that will happen. None of us are going to be there at that time. But the way we are progressing, if you can share some of your thoughts in terms of what has been done by some of the hospitals, what can be done, and what should be done to ensure this sustainability for healthcare organizations.
Thank you, Joy. Thank you, CII, also for inviting me to be on this very distinguished panel. Good evening, everyone over here. I think that's a very important question which needs to be addressed, really. The sustainability and how to make everything green. I mean, it is not only hospitals. I think the entire world should now be sustainable, be green, and make sure that our Mother Earth is, nurtured more carefully. But just to start with the hospitals, and I can also quote what we have done in Ruby Hall Clinic, the the will, the vision, it starts with the will and the vision. You must have the will and the vision to make sure that your hospital is green, to make sure that your hospital is sustainable, that there is a negative carbon footprint or at least a neutral carbon footprint on this, on this planet. And there are now registries, to measure all that. So there are many, many ways, of course, which we can do this. One of the prime reasons is, of course, if you're starting, if you're lucky enough to start a new hospital, to start with, eco-friendly building materials, have, LED lightings, the HVACs can be, more carbon neutral, can be more sustainable. There are many, many ways, rainwater harvesting is also another. I agree that for old hospitals or legacy hospitals, it becomes very difficult. But at least for new hospitals, these things should be mandatory now to be incorporated into that. And I think the government is also taking adequate steps to do that. How you treat your waste, your biomedical waste, there are many eco-friendly ways of doing it. How you treat your waste water which is coming out, how you can recycle it. How do you, for example, solar panels and all that, which is of course there. I'll give you a very brief example. I mean, even if you start, and you make sure that there is telemedicine at least, and it's going on in a proper way, then think of the saving in terms of energy saving, which happens by preventing that patient to come to the hospital, go back. All that thing also adds up. It all adds up to your energy saving and being energy sufficient. Very recently, and I'm giving you a very good example in this. Very recently, we in Ruby Hall, we've taken a plot and we've tied up with a company which deals in all this. We've taken up a plot in rural Solapur. We put in acres and acres of solar panels over there. The energy which is generated, the power which is generated over there is fed into the grid, the local grid. We feed it to the local grid, to the government, and in turn, the government gives us very, very subsidized power in our various hospitals. And we are doing it for all our various hospitals. We got 3 units in Pune now, a fourth one is also coming, and we are doing it for all. It is not only saving energy for everyone, it is also saving us a lot of money. And money, when I say a lot of money, in literally multiple lakhs every month. So as I'm saying, and as the question is also there, it is not only obligatory for us, I think we have no choice. We have to do it. Every hospital should go in for that. And definitely, if there is a new hospital which is being planned, certainly put in all the green efforts which are there for us. You can go in for certification. That's another area. I mean, there is a LEED certification, which actually means that your hospital is energy sustainable, energy sufficient. And also there are regular audits, regular service, which make sure that this is happening on a regular basis. So the question is, of course, that how to adopt it. I think the will and the vision of the hospital managers, the hospital owners, is very, very important in this. Thank you.
Thank you. And probably this topic is going to be in next couple of years the most sought after topic for any industry. How do you remain sustainable in this challenging time? I move on to my last panelist, but before that, I want to tell this audience that keep your questions ready because after his answer, I'll be asking you to ask question to the esteemed panelists who are present here. So be prepared. I'll be giving a chance for maybe 5-7 minutes. And with this, I move on to Dr. Parag, the chairman of CII Western Region Healthcare Committee and CEO of Oakheart Hospital. And the question is going to be from his basic of microbiology, and that is related to antimicrobial resistance. So I kept it for him the last. So Dr. Parag, you know, though we came across COVID, I can't say it is a microbiology related challenge, but we came across. But very soon, what you are anticipating that because of unnecessary or misuse or abuse of whether it is antibiotics or practices, we are going to have a huge threat from this particular area. So, what do you foresee in terms of antimicrobial resistance? What we should do? How technology can be used to partner with that, and how we can overcome this challenge?
That's an excellent question. I can do a whole session on this in the afternoon. Uh, I think at the end of the day, one must put in a very, very clear and step-by-step approach to ensure the rollout of these hospitals because it's very difficult to get the masses at the first level. One, with all clear strategy in place as to exactly how you're going to percolate this down to your own clinicians within the hospital, right? So you do your antimicrobial stewardship program, you wrote out your reserve antibiotics, and then you put your foot down irrespective of who is actually asking and however big he is in your, Brahma, Vishnu, Mahesh kind of an hierarchy of gods, where he's a cardiac surgeon, neurosurgeon, and so on and so forth. So that's point number one. Point number two, all of us in culture eat strategy for breakfast. So you need to get a cultural buy-in from your consultants that they actually understand why you're doing this. Now, I work for a group of hospitals who sell in companies, a pharma company. And over 40 years, it took us to evolve a new class of antibacterial compounds. This is not a new antibiotic, it's a new class of antibacterial compounds. So we know the pains that it takes for this country and for the world to develop a new class of antibacterial compounds. And our mothers and fathers are happy to just go and take tablets which are left over from the previous trip. So I think the second thing is that if within the organization there is a decent handle on vancomycin not being used for elective surgeries, and meropenem is not being given for community acquired pneumonias, that is more rhyme or reason, then itself is half the battle. The second part of the strategy has to be using technology to reach out to the common man. Today, everybody is able to log in and create an OTP-based password for his own banking transactions, buying shares. Even if you're a fourth standard pass, you know how to buy a share of your stock market. You have a demat account, so you understand OTP. Okay, my driver has an OTP. He has a bank account, and he transacts on the stock market. Okay, doesn't mean I'm paying too well, but nonetheless. Point being that if you're able to create at some stage through the Sidesco and through the Food and Drug Administration of inside, they were able to create a one-time password-based trigger whenever an antibiotic is being used or some sort of mechanism that puts a check and balance in place. I think that's the only one example to tell them to Dr. Deshpande's area. There is never been a single chemotherapy order that has been given verbally in any of the institutions represented on the stage. Because we have a verbal order which clearly defines that chemotherapy medication should not be given on the telephone. That's a clear no-no because we are aware of the toxic effects of a wrongly administered chemotherapy therapeutic medication. Similarly, if you're able to respond people that antibiotics are not as simple as you think that they are, then it takes decades to come up with a class of antibiotics. It takes just a few years to evolve antimicrobial crowding and resistance. I think that's going to be really bad. Our problem, unfortunately, is that while we have the same pharma industry that on one hand pushes for antimicrobial stewardship, we have the not so scrupulous agents, the representatives at the grassroots level, to push for more and more usage. So if they want to sort of safeguard their product, once in my mouth, I would report to Jai. We will have to put some sort of judicial sense into all this. It's not going to work. So to my mind, artificial intelligence is merely a tool. If we decide, it's like smoking. If we decide that we don't want to use an antibiotic for no reason, we will not take that antibiotic. But if we are given to taking whatever we want to do, third part of the strategy is education of our doctors and nurses. Let's accept it. Pharmacological education in our medical colleges, nursing colleges needs to be strengthened so that EMR is addressed at that level. If an Ayush doctor or an MBBS doctor who's coming to medical college does not understand that a viral infection does not need an antibiotic, okay, then I think so. I think it's a three-pronged approach. Hospital-based strategy. Second one is an education strategy towards the nation, and the third one is an education strategy in terms of our medical workers. Thank you.
Thank you, Dr. Parag, for a very clear thoughts and propose suggestion in terms of how do you manage the situation. So I'm going to close this session and I'll open for the audience to ask question. But one thing is very clear. I have asked 5 different aspects related to our healthcare delivery to all the speakers here. So they know what to be done. That means the leadership is aware. The positive thing is we know what to be done. Probably all of us are not doing that.
we know how to be done. Probably all of us are not following that. So the answer is going to remain that how soon all of us are going to embrace these changes, good practices, and probably looking at the patients who are the center of all of our activities and going to ensure that they get the best. So with this note, I want to conclude this session, and panelists have done a wonderful job. So a big round of applause for them. So I have exactly 6 minutes and I can open up for few questions. You can introduce and ask whom you want to ask, and then you can ask a question.
Good evening to everybody. This question is to all CEO. Since last a decade, many hospitals have consolidated and changing their hand from one person to another person. And many corporate has a backward integration to set up an hospital, like pharmaceutical company who is manufacturing certain medicine, and they have gone to the corporate hospitals like Zydus Cadila, and there are other also. In past also, individual doctor has come up with a polyclinic, and now they are selling and giving to the private stakeholders. So in future, as a CEO, what you look, whether the corporate will be coming up to take the responsibility of the hospital, or other stakeholder from the outsider will come and join in the hand of the development of the hospital.
So though your question is for all the CEOs, but I'll allow only one CEO to answer.
Okay, no problem, sir. Carry on.
Yeah.
What you're saying is, should the corporates put up the hospital or individuals should put up the hospital? Is it? Should the corporates be putting up the hospitals or should individuals supported by the corporates be putting up
He's
hospitals?
asking about the consolidation, what is happening under that. Corporates are taking away most of the time. So what is going to be the future?
See, okay, now you will let us see. See, there's a promoting agency, be it corporate or individuals, and there's a final product, a hospital. What do you want in your hospital is one thing. You want a hospital with all the departments or very specialized hospitals. No matter what it is, it has to have very competent people. HR has to be very strong, human resources, very strong. It has to have a very good technology, okay, and it has to be absolutely state of the art and science, right? These are the characters what you would like to have in a hospital to which you would like to go. Now, who is actually going to be capable of putting that particular thing is something which is very important to realize. Hospitals are being put by organizations, be it pharmaceutical or big corporates today, big time industrialists is there. So their ability to invest in technology or in support of the professionals is extremely strong. But what is very important for them is to identify good people who are good leaders. This is extremely important. The ethical consideration, the compassion, the helping nature, and to see the thing through, to carry the view. Quite often the stated goals and practiced goals are quite different in organizations. That cannot happen in a hospital. If you are going to follow a motto, then a compassionate kind of a care at an affordable cost has to be the thing, and it has to be practiced. So that is possible only if you have very good people at the helm of affairs. Now, whether the whole thing is started by doctors or professionals or whatever it is, and they are backed up by corporates, or the entire thing is started by the corporates, is really immaterial. But see, I'm a doctor. I'm also involved in a hospital project, and I'll tell you one thing: these kind of efforts are absolutely uphill. They're not very easy because see, if you are a very, very top person in your own field, it's not very kind to become a number 10 in management or number 100 in finance and all that and try to still continue doing that particular thing. Not worth it. Not worth it. So, and what happens is you want somebody who's really very good, who can handle that particular hospitals. It means that you have to be backed by finance. So ultimately, it comes down to the same thing, that a good corporate with a good ethical standard is probably the best one which is equipped to put up the hospitals, and they actually can join hands with groups of doctors, and that would be the best combination. break-even point, please understand, if a powerful group is there, does it really matter to them about the break-even point? Because see, now you gave me examples of two hospitals, right? What is the size of those hospitals? 500 crores? You see what is the size of those organizations. It is child's play for them. Okay, so break-even point and all that. If it's a doctor who has put it, he will be buried under for that break-even point.
Some of the focus of the overlap of all people in this country is always somehow the corporate hospitals. I wonder when our Janta, Janta Janardan कहते हैं, when our Janta is to wake up to question the state of the government hospitals. They also need to be professionally run. And I think the sooner they partner with professionals and get things in order, that will really help the bulk of the nation because it's very 2 to 5% come from the so-called quote-unquote corporate hospital. bulk तो अभी जनरल हॉस्पिटल में जाते हैं उसके बाद भी थोड़ा आप सोचें ठीक
Next question, same table.
Sir, this is regarding this overconsumption of antibiotics. In the earlier session, also in this session, also Dr. Indani has spoken about that. Why it is available on OTC? I mean, there are rules that it should be a prescription drug only and should be available to the whatever doctor has written. Then why overconsumption is coming over this?
So I think the Food and Drug Administration norms, the Indian pharmacopoeia norms are very clear in terms of the schedule, schedule H, schedule, all these schedules are clearly defined. The fact that these drugs are sold over the counter. The fact that these drugs are sold over the counter without any regard to the schedule under which they have to be sold is a matter for the Food and Drug Administration to look into. I do not think we can penalize a doctor for prescribing what he thinks is he, she, they think is the correct medication, right? Remember that the entire gamut of healthcare practice does not end with the doctor's prescription. There is a further process owner, and these process owners need to take their own responsibility. Now, why it is being sold and how it is being done, all of us know why it is being sold, because it is very difficult to constantly look up a prescription and duplicate, inform the authorities. I personally think it is time for us to drop a lot of the decadent policies and procedures that the British government has left us with. Today, even to answer his question also, today the reason you need professionals to run a hospital is because you've got more than 200 acts and laws to be satisfied in order to run a hospital. Similarly, I think the government needs to take away certain drugs from each and every chemist, leave it only at certain points so that when it is truly required, it will be given. Classic example, remdesivir during COVID. You did not get it just like that. And when you got it, it was because you really needed it. I think till we don't reach that sort of maturity level, we are not going to be able to successfully channelize what you're asking for, sir.
Last question from there I'll take, but Parag, I got little worried about British government today morning. All of them are here, and
Good evening, everyone. I'm Amol Savarkar from Wellington, and my question is to everyone here, and especially the delegates, that how is working on the operation theater different from leading an hospital to an epitome?
how is your
How is working in an operation theater different from leading an hospital to an epitome
leading
of
a hospital to
success?
epitome?
Of success.
So what I understand is he's talking about a doctor who is managing in the OT
Yeah.
and successful versus managing the hospital
Yeah.
management and giving the success.
Difficult. I'll tell you one thing. I'll just explain in 2 sentences.
Yes, sir.
I'm a surgeon. Okay. When I work in a hospital, and if I work on either in his hospital or his hospital, I would like to maximize the use of all available resources for the betterment of my patient. Okay. This is what I want. Everything should be, nay, I want this patient to go home. Doesn't matter how difficult it is. If I become an administrator, now they are better equipped to understand that. They would like to minimize exactly the same thing, apportioning of this thing. And the reality will lie somewhere in between. And you will never find an optimum.
Excellent. I think that is the apt answer to end this day's entire deliberation. So thank you. Thanks a lot for being a great audience. And without much taking time, we are going to switch over to the much awaited award function, and Krishnan is waiting here. So over to Krishnan and team to take it forward. Thank you very much.
Thank you. Thank you, Mr. Joy Chakraborty, and to our esteemed panelists. As a token of our appreciation, may I request Joy sir to hand over a thank you letter each to our panelists. A big round of applause, please. Thank you. We'll have a quick changeover. May I request you to please continue, remain seated. Please remain seated. This is the much awaited part of the Health Tech Hospital Tech 2024, the awards for the CII Western Region Innovation and Healthcare and Hospital Technology 2024. May I request everyone to please take your seats? A very good evening, ladies and gentlemen, and a very warm welcome once again. This evening is special as we announce the winners of the CII Western Region Innovation in Healthcare and Hospital Technology Awards 2024. On behalf of CII, I welcome you. I want to thank this august gathering of healthcare experts, industry members, participants, and most importantly, the jury for joining us this evening. The awards program aims to recognize and award hospitals, medical institutions, NGOs, and healthcare providers for their exceptional contributions in the healthcare sector and in service to their patients. Through this platform, CII aims to honor excellence in the healthcare sector in India who are revolutionizing the sector through their innovative processes and approach. With this as background, it is only befitting that establishments addressing these challenges through their solutions should be recognized and should be encouraged. The CII Western Region Innovation and Healthcare and Hospital Technology Awards provides this very platform to recognize contributions of those who have set benchmarks of excellence in the healthcare sector. And without much further ado, may I like to call upon Mr. Krishnan V, Chairman of the CI Western Region Health Tech Awards 2024 and Chief Operating Officer Ramanan V to give the welcome remarks.
Check. Good. Good evening, everyone. May I request everyone to be please seated? Committee members will be good. Anyway, so my name is Krishnan V, the chairman of the Health Tech Awards Committee for the second time. This is the third edition, and this entire show is an output of about 6 months of hard work. And what we realize in this entire journey is India is brimming with many elements of innovation, ingenuity, many process innovations that are happening across the value chain of healthcare. And over the last 6 months, there's been a tremendous amount of learning. I know post the award, there'll be a lot of excitement. So I want to actually do a thanksgiving speech even now. Most people don't stay back after once they receive the awards, but I would be not right if I don't thank these members. So first and foremost, I think I should thank the jury chairman, Dr. Ramakant Deshpande. I don't know where is he. So yes, he's out. Also the co-chair, Dr. Nilesha. I think both of them were one of the guiding lights in terms of curating this whole awards and how we build this together. Last but not the least, also the chair of CII Western Region Subcommittee, Dr. Parag Dandani. Thank you for all the support, as always. And the person who started this all, Joy Chakravarti. So I actually have taken over from his lead. Thank you, Joy. And last but not the least, again, Dr. Darang, who's joined this group as a co-chair. Now, having said that, when we look at these awards, when we built this 3 years ago, it was supposed to be a Western Region award. But what we realized in the third edition, we had over 50 applications, about 25 of them qualified. So today you'll actually have 2 dozens who have qualified. And best part was we had about almost 30 jury members who scrutinized these awardees, their work. And what you see today is a well curated, statistically validated awards, which is extremely democratic in nature and zero bias involved. Having said that, India is a very vast country and we are known as CII Western Region. So you'll be actually happy to know from a perspective of these awards, we had about, I think, 10 states who participated, about 30 cities, various hospitals who participated, a lot of large organizations, large healthcare providers participated. I think that calls for a round of applause for everyone who did the hard work. So round of applause for yourself if you are the participant. Also, this actually gives us and has raised the bar for us. So hopefully next year we do pretty well from here. But I again will not do justice if I don't thank the team that was in the back end, which is Samriddhi, Dhara, we are missing Saurabh, and the entire CI secretariat. I think they did all the heavy lifting. And what you see today is because of the people, they're young shoulders, not very experienced, but they've taken everything on their chin. But what you see today as a show is all curated by them. So without much ado, I'm going to hand over the floor to our MC and wish everyone the best. I must say one thing, over the last few weeks, having heard your presentation, have you seen your applications? I am very proud as an Indian. I think there's a lot happening in the healthcare, and I must say that we have a very, very bright future. So thank you very much once again. Enjoy the evening and Jai Hind.
Thank you, Mr. Krishnan. It is an honor and privilege to invite the chairman of the jury committee of the Healthcare Awards 2024 and executive chairman, Asian Cancer Institute, Padma Shri Dr. Ramakant Deshpande, to deliver the open remarks. A big round of applause, please.
Good evening, everybody. We're coming to an end of the first day, which is a very interesting time, actually. Krishna was just mentioning in Marathi, it's very interesting. He says, what did he say? He's the veil and has to shun. It means that this is the time and this is the moment. That's what he said, that this is something very interesting because the healthcare, the awards is basically exactly like what he said. It is a very well curated, statistically validated, and completely impartial kind of award ceremony for which our youngsters actually have worked quite hard for days together. We have an excellent jury which also contributed their time, valuable time, effort, energy, and several people actually made their presentations. Analysis was done very well. And now you are going to see the result of all those processes. Mind you, all these people who have made their presentations have spent years and decades towards achieving perfection in that particular field. Now, perfection is an ever-ending kind of a quest. So it never really, you don't achieve perfection, it's a process. So, but what you are going to find is the best people in the whole country who have reached somewhere in the topic of their interest, and we have actually been very lucky to be associated with them in even their choice. So thank you very much to all the participants. Some I mean, when you have a competition, you have to come. Somebody will be first, somebody will be second. That way, it doesn't mean too much that way, but it's just a recognition by your colleagues and your fraternity of where you have reached. So I think we will actually start.
Thank you, Dr. Ramakant Deshpande, sir. And finally, the excitement is palpable, and I can also hear the drums roll. I'm sure you're eagerly awaiting the outcome of the awards, and Mr. Krishnan has already taken us through the process of the past few weeks. A stellar jury, more than 50 applications that have come in, and a really unbiased scrutiny of the applications, a shortlisting process, and now we have the scoring of the top 3 teams and 9 award categories that will be felicitated today. So let's begin with the first category, the Best ESG Initiative. This category is designed to recognize healthcare organizations or hospitals that have successfully implemented outstanding ESG-related projects, contributing positively to the environment, society, and governance structures. May I call upon on stage Mr. Krishnan V. and the Consul General of the Kingdom of the Netherlands, Mr. Nabil Taouti. A round of applause, please, as we start with the first category, which is the Best ESG Initiative. The award is a jury appreciation award, goes to Yashoda Super Specialty Hospital. May I call upon the team to quickly come up on stage? Many congratulations. Request you to stay back. The next is the Best Health Insurance Service Initiative. This award highlights the initiatives that have set new benchmarks in the insurance industry, particularly related to healthcare. Here again, this is a special jury appreciation award going out to Zoom Insurance Brokers Private Limited. May I call upon the team representing Zoom Insurance Brokers to come up on stage? Many congratulations. Thank you, Consul General. Thank you. Mr. Krishnan, you'll be up. Now may I also invite Padma Shri Dr. Ramakant Deshpande to come up on stage for the next award handout. From the jury of this particular awards, Lieutenant Colonel L.C. Verma, sir, if you are here, please join on stage. Ladies and gentlemen, this is the Best Primary Care Initiative Award, which basically founds the foundation of a strong healthcare system. The first runner-up is Sir H.N. Reliance Foundation Hospital. May I request the team to come up on stage and receive the award? Sir H.N. Reliance Foundation Hospital. Many congratulations. This is the first runner-up in the Best Primary Care Initiative category. Ladies and gentlemen, the winner in this category is Karma Primary Healthcare Services Private Limited. May I request the team to come up on stage? Karma Primary Healthcare is the winner in the Primary Care Initiative category. The next category is the Best Healthcare Skilling Initiative. This award highlights initiatives that contribute to building a capable, competent, and future-ready healthcare workforce through training, education, and development. May I request if anyone from the jury of this particular category in the hall to please join on stage? The first runner-up goes to Carestream Health India Private Limited. May I request the team representing Carestream to come up on stage? A big round of applause, please. Many congratulations, Carestream Health India. And the winner in the category for the Best Healthcare Skilling Initiative goes to Tech Mahindra Foundation. Many congratulations. Thank you so much. Moving on, the next category is the Best Healthcare Digital Initiative. This category leverages technology to drive digital transformation in the healthcare sector, making healthcare more accessible, efficient, and patient centered. May I call up on stage Mr. Joy Chakraborty, Chairman of the CII Hospital Tech 2024 and Chief Operating Officer of the PD Hinjada Hospital to join on stage. Also the jury for this particular category, Dr. Hardik Ajmera, Medical Director, CII Hospital. Sir, if you are in the room, please join on stage. Ladies and gentlemen, the Best Healthcare Digital Initiative, the second runner-up goes to Sahyadri Super Speciality Hospital, Nagar Road, in Pune. Many congratulations, sir. The first runner-up in the category for Best Healthcare Digital Initiative goes to Baby Memorial Hospital, Kozhikode. Many congratulations. And the winner in the Best Healthcare Digital Initiative, PD Hinduja Hospital and MRC. Mr. Joy Chakraborty accepting the award on behalf of PD Hinduja and his team. Many congratulations. The next category is the Best Health Tech Innovation. This award recognizes the development or application of advanced health technologies that are transforming the medical practice, improving patient outcomes, and addressing critical challenges. May I call upon Mr. Kumar Bagrodia, founder and CEO, to join on stage. The second runner-up in this category is Anand Softtech Private Limited. Anand Softtech is not present here, so we'll hand over the award later. The first runner-up in the category for Health Tech Innovation goes to Doctorpreneur Health Solutions. The 500 will be handed over prize later. And the winner in the category for the Belt Health Tech Innovation goes to Merrill Life Sciences Private Limited. Many, many congratulations. We now move on to the Best Patient Safety Initiative. May I call upon Dr. Parag Randani to come on stage? And the jury for this particular category, Dr. Ravindra Karanjekar, Group CEO, Kiran Hospital. Sir, if you're here, please join on stage. And Mr. Behram Kodaiji, Group CEO of the L. Hirnani Hospital. I apologize, Ruby Hospital. The Best Patient Safety Initiative recognizes efforts that are aimed at reducing medical errors and preventing harm and ensuring patient care. There is a special jury appreciation award going out to Soundara Pandian Bone and Joint Hospital. May I request the team representing the hospital to please join on stage. Many, many congratulations. In second runner-up, the award goes to Aster CMI Hospital. The team representing Aster to please join on stage. Congratulations to Aster. In the first runner-up, the award goes to HCM City Manipal Hospital. The team representing Manipal Hospital to please quickly come up on stage. Many congratulations to Manipal Hospital. And ladies and gentlemen, the winner in the category of the Best Patient Safety Initiative goes to Sahyadri Super Specialty Hospital, Nagar Road, Pune. The next category is the Best Community Patient Education Initiative, which recognizes and highlights efforts to empower individuals with knowledge, promote healthy behaviors, and improve public health outcomes through education. There is a special jury appreciation award in this category that goes to Chaipigo. Team Chaipigo, if you are here, please join on stage. We'll hand over the award to Chaipigo later. The second runner-up in the Best Community Patient Education Initiative goes to HCMCT Manipal Hospitals, Delhi. Many congratulations to Manipal Hospitals. The first runner-up in this category, the award goes to CII Hospital. Team CII, please join on stage. Congratulations. And the winner in the Best Community Patient Education Initiative, Sterling Accurus Wellness Private Limited. A big round of applause, please. Thank you so much, and many congratulations. For the next category of award for Best Healthcare Delivery Initiative, I'm requesting Mr. Joy Chakraborty to come on stage. Padma Shri Dr. Ramakant Deshpande to please join on stage. And the jury team for this particular award, Dr. Anupam Karmarkar, CEO and MD, SPF's Hira Mongi, Navneet Hospital to join on stage. There is a special jury appreciation award in this category, and this goes out to Jehangir Hospital. We move to the next. The second runner-up is HHC Cancer Center Vadodara, a unit of HCG Oncology LLP. They're also not present right here today, so we'll hand over these awards later. The first runner-up in the category for the Best Healthcare Delivery Initiative goes to PD Hinduja Hospital and MRC. Many congratulations to the PD Hinduja team. And ladies and gentlemen, the winner in the category for the Best Healthcare Delivery Initiative. Please put your hands together for Sahyadri Super Specialty Hospital, Nagar Road, Pune. A special jury choice award for exceptional contribution in the category for the Best Healthcare Delivery Initiative goes to Srimad Rajchandra Sarvamangal Trust. The team representing Srimad Rajchandra Sarvamangal Trust to please join on stage. A big round of applause, please, for the Special Jury Choice Award. Many congratulations to all the winners for today, and a big thank you to the jury for their time and evaluating the entries. Thank you so much. Mr. Krishnan, may I invite you to give the vote of thanks?
But I think there is very few words left now. I must say, all the people who came in here, at least the last winner and Merrill Life Sciences, the highest voted presentation, by the way. Uh, as I said, a lot of hard work has gone into it. I think next year as a team, we will try and up the ante. We have just reached about 10 states. And I know some of the people who I spoke to for entries next year will actively participate, but really appreciate all you being here. Thank you again. Have a great evening until we meet next year. Thanks to everyone and have a great time.
Thank you, everyone.
Sorry, I forgot. Sorry. Can we have all the winners on the stage? Oh, I forgot. Can we have the jury, the winners on the stage, chairman on the stage, group photograph? Hey, what is this? Yeah, you guys forgot. You cannot go. The trophy will be couriered back to us if you go. Please come on the stage, jury, chairmen, the winners. We have a great photographer. He has really a good eye. Yes.